Now we will start the symposium on ECS. For this, I would like to call on stage to chair this symposium Dr. Geeta Subramanian ma'am, Dr. Ashish Purohit sir, Dr. Girish Kale sir, and Dr. Sunil Mehta sir. I request you all to be on stage. For the first topic, culprit artery localization, I would like to call on stage Dr. Wasim Rashid sir, who is consultant cardiologist in Super Speciality Hospital of GMC Srinagar and also a cardio electrophysiologist with 2-year fellowship in electrophysiology. He is also IBHRE certified in cardiac devices. Sir, kindly start the session.
Thank you.
I request all the esteemed speakers to be on time.
Respected chairpersons, esteemed faculty and dear delegates, it's a great honor for me to start the opening session of this conference of Indian Society of Electrocardiology. And I want to express my heartfelt gratitude to the organizers for giving me this opportunity. So I'll be talking about the ECG localization of culprit artery in STEMI. And for that, I have a lot of territory to cover, so let me get started. So as you know, STEMI is essentially an ECG diagnosis, and ECG remains the cornerstone of diagnosing STEMI. But beyond the presence of ST elevation MI, the ECG can give us further insights into the infarct-related artery and even the level of occlusion in that artery. So what is the basic principle behind such an analysis is what we call the ST injury vector. It's the direction and displacement of the ST segment, sum of all direction magnitude of all ST vectors. And the resulting vector points to the most pronounced area of ischemia, giving rise to ST elevation in that area. The opposite area will record ST depression, what we call reciprocal changes. And the leads perpendicular to dominant vector will record an isoelectric ST segment. This is the basis of how we localize an infarct-related artery on a STEMI ECG. So let me take you through the facing and reciprocal leads in various parts of the heart. So for inferior wall, the facing leads are 2, 3 AVF and the reciprocal leads are 1 and AVL. For anterior portion of the heart, the facing leads are V1 to V4, but there are no true posterior leads in the 12-lead ECG, which represents the true posterior surface of the heart. For the septal surface, it's the facing leads are V1, V2, while the reciprocal leads are the posterior leads, that are V7, V8, and V9. So why are we doing this exercise? What is the practical utility of this exercise of localizing the infarct-related artery and trying to know the level of block? So it helps in triage, basically for the emergency medicine doctor as well as for the cardiologist. It helps to identify high-risk subgroups like left main coronary artery occlusions, proximal LAD occlusions. It also helps to predict and anticipate infarct-related specific complications, for example, hypertension and conduction disturbances in right coronary artery, ischemic mitral valve regurgitation and circumflex occlusion, and cardiogenic shock or mechanical complications for LAD or left main involvement. So this is a beautiful diagram taken from Kalyanam Shivkumar's latest Atlas of Cardiac Anatomy. I urge DM students to go through it. This is open source. It shows the relationship of the various ECG leads in relation to the in situ cardiac model. So you can see on the upper panel is are the frontal leads, which look at the heart in the frontal view. These are the 1, 2, and 3, and AVR, AVL, and AVF. While as these are the relationship of the various precordial leads in relation to the in situ heart. And these look at the heart in a horizontal section. This section of the heart is at the level of V2 and V3. And see the areas which they represent at this section. And this section is at the level of V4. And you can appreciate that V5 and V6 are very much displaced from the heart because of the intervening lung. V1 rests mainly on the RA appendage and infundibulum, and V2, V3 represent the septum, infundibulum at the septum. V4 looks at the lateral and apical part of the heart. To complete the anatomy overview, we have the coronary circulation. In this particular example is the right dominant because the PDA arises from RCA. These are the various branches. And let's see how the conduction system is supplied. The SA node is supplied by RCA in 55%, AV node in 90%, and bundle of His mainly by RCA. The RBB is mainly supplied by LAD, while as the left anterior fascicle is supplied by LAD, and the left posterior fascicle is supplied both by LAD and posterior descending artery, depending on which it's coming from, depending on the dominance of the circulation. So after this brief overview of anatomy and the electrocardiographic relationship of the anatomy with the electrocardiographic leads, there have been numerous studies invoking these two principles, how the electrocardiographic leads are related to the heart in situ, and the ST segment injury vector analysis. Numerous studies have been done to give algorithms for detection of the infarct-related artery. And this is the latest one in that endeavor. This was published only this year in the American Heart Journal. This study is impressive for the rigor it uses. For it used a testing cohort, a validation cohort, as well as tested the almost more than 60 previously published ECG criteria with the present criteria. But what I want to take away from this study is how fruitful is this exercise? What is the diagnostic accuracy of all these algorithms? So as you can see, they compared the diagnostic accuracy of this algorithm versus a cardiologist versus an emergency medicine doctor in Italy. That's in Italy. This was an Italian group. So if we want to localize just the infarct-related artery, the diagnostic accuracy is almost 88% for the algorithm, 83% for the cardiologist, and 74% for the emergency medicine doctor. But if you want to localize both the infarct-related artery as well as the level of occlusion, then the diagnostic accuracy comes down to 67%, 54%, and 43% respectively. So what I want to impress upon you is that it's not a perfect science, but still worthwhile being well versed with. And this is the algorithm they gave for localization of the infarct-related artery. But I won't go into this algorithm because I want to take you through a anatomy-guided STA segment vector analysis so that we understand the basics behind these algorithms. And we have a deeper understanding of what goes behind these algorithms rather than rote learning. So let me start from the left main coronary artery occlusion. Here the whole LV is at risk, is ischemic, and the ST injury vector is pointed like this towards the AVR. So there's ST elevation in the AVR. There's prominent ST segment depression in lead 2 because lead 2 is just opposite to the AVR. Can I have a pointer so that? So the injury vector faces directly towards the AVR, so it observes a ST segment elevation and at ST segment depression in 2 because it's directly opposite. In the horizontal axis, this is how the injury vector is directed in the cut section of the thorax, directed right and backwards. So V1, there's minimal ST elevation, while as in other precordial leads, there's marked ST depression, especially V5, V6, because they are quite opposite to this vector. And this gives rise to the typical ECG pattern of left main coronary artery occlusion. Diffuse ST segment depression in inferior-lateral leads, ST segment elevation in AVR, and minimal ST segment elevation in V1. This is the same pattern. Now, LMC occlusion can be complicated by right bundle branch block. Why? This is the vector when there's a right bundle branch block. It's still pointing towards the positive quadrant of V1, given it was a big R and V1 and an RBB pattern. So to summarize left main coronary occlusion, there's ST segment elevation in AVR and V1. ST elevation in AVR is more than V1. Ischemic changes in lateral basal region, depression of ST segment in the inferior leads and from V4 to V5. Depression of ST segment in V6 is more than ST segment elevation in V1. And eventually it may complicate with intraventricular conduction disturbances, RBB, LAFB, and LBFB. But we have to remember that ST elevation in AVR is not entirely specific to left main occlusion. It can also be seen in proximal LED occlusions, severe triple vessel disease, or diffuse subendocardial ischemia. Moving down to the downstream proximal LED, this is how the vector is pointed towards. So we record in frontal ECG ST elevation in AVL in 1 and a depression in the inferior leads because it's opposite to these leads. And this is how it looks in the horizontal section. So maximum ST elevation is in the V2 because the vector is directly looking at V2. And this is the, before the LED gives first septal branch, this is the particular pattern. If it is occluded beyond S1 but before D1, so what is the pattern? This is the vector at that level, in the mid portion of the LED. Before D1 but after S1. The vector looks here. So the maximum elevation you will see in AVL, but you will record a ST depression in lead 3. And in the horizontal, this is the ST elevation in the V2 to V6.
Dr. Rashid,
While
can
as
you,
distal, if we go more distal,
Dr. Rashid, can you please?
I'll just try to be brief. If you go more distal, this is the injury vector and giving rise to ST depression AVR because it's opposite to it and an ST elevation in inferior leads. Here and in the precaudal leads. Here I want to point out that whenever we see ST elevation in both inferior leads and the anterior precaudal leads, we invoke a wraparound LED. But that's not always the case. You can see this in just a distal LED occlusion because the vector is pointed like that. So this is how the vectors are in various levels, left main, proximal LED, mid LED, and distal LED. Let me go to the right coronary artery. This is the vector. These are the horizontal ST elevations. And there have been multiple studies showing that because the vector is pointed towards 3, the ST elevation in 3 is more than 2. And because it's just opposite to the AVL, there is an ST depression in AVL. This is very specific for RCA occlusion. Let me straight away go to, and if there is proximal, there can be an RV infarction because the RV branch arises ahead. So V4R will record a RV ST elevation. There can be conduction disturbances. I will not look into that. In the mid portion of the RCA, if there is occlusion, the ST segment vector is like this. Still, the ST3 is more than 2. But the V4R will not have a ST elevation because the RV branch is already given. Coming to CIRC, the lateral wall is involved and the ST vector is like this. The thing that I want to point out is that there's ST depression in AVR and 2 is more than 3 because the vector is looking directly at 2. And there's often a notch typical of LCX occlusion at the end of the QRS. This is very specific for CIRC. And this is of very much importance because the interventionist always wants to know whether inferior wall MI is because of CIRC or RCA occlusion. And I just want to make this the last slide that if we say the V4R in acute inferior posterior MI, it is also of localizing importance because if there is proximal RCA occlusion, there is ST elevation with a positive T wave. If there is distal RCA occlusion, there is no ST elevation but a positive T wave. But if there is a CIRC occlusion causing this, there is a negative T wave and ST depression. The reasons are these vectors. And finally, the isolated RV infarction gives rise to ST elevation in right-sided leads and minimal in V1 because of the vector. So it's all about vectors and the cardiac anatomy and its relation to the electrocardiographic leads. So this exercise has a high specificity, high predictive accuracy, but low sensitivity. And it's not applicable in situations where there's a previous infarction, pre-existing abnormality of the XT segment, left bundle or right bundle branch block, ventricular pre-excitation, multivessel disease, abnormal site of coronary artery, or dominance or underdevelopment of coronary arteries. Thank you.
Thank you, Rashid sir, for the wonderful presentation. I request chairpersons to felicitate Dr. Rashid sir.
Can we have a round of applause from the audience? Thank you, sir. For the next talk, we would like to invite Dr. Rituparna Shinde, who is a senior interventional cardiologist from Pune, former editor of Indian Journal of Electrocardiology, and a reviewer of various international esteemed journals. He'll be speaking on unusual T-wave signs in acute coronary syndrome.
Hello. Yes. Good morning, everybody. In next 10 minutes or so, we are going to discuss some very subtle signs in the ECGs of acute coronary syndrome, which would be very, very subtle but very important so that we do not miss the diagnosis. So I start my lecture by giving my respect to a man who has inculcated interest in the ACS ECGs, none other than Professor Hein Wellens. We all know that initial phase of ACS ECGs, it can be normal in almost 50 to 60% of the patient, and that's why it is very important for us to see the ECG of an ACS very carefully and look at various clues which can lead to impending devastating myocardial infarctions. So we today are going to see for 4 signs. First is called as loss of precordial T-wave balance, and that is NTTV1. Second is Wellen syndrome. Third is early reciprocal changes specific to the lead AVL and De-Winter T-waves. Coming to first normal ECG, just look at lead lead V1. In lead V1, usually the T-wave is not upright. It is either isoelectric or inverted. If at all it is present, it is very low amplitude positive T-wave. And also important is the T-wave balance. That is always the T-wave height in lead V1 is less than the T-wave height in lead V6. This we have to understand. So what is this NTTV1? It's a very cryptic name, new tall T-wave in V1. So if it is upright in TV1, it is abnormal. If it is new, it is all the more abnormal. And why? Is it a new sign? No, not at all. In fact, it has been described by Henry J. L. Marriott in 1960s, and it was known as loss of precordial T-wave balance at that time. It suggests underlying coronary artery disease. If it correlates with the symptoms, it indicates acute ischemia. Again, TV1 more than TV6 is especially concerning, and NTTV1 may precede other ECG changes. Now we will go to cases straight. V1, look at this patient with chest pain. Lead V1 has a positive T wave. Look at lead V6. There is a positive T wave, but this particular T wave is taller than the T wave in V6. This particular gentleman was ruled out for MI using enzymes and other things, but comes back after a few days, and this is the ECG. Now you don't require anyone else. This is a acute coronary syndrome happening. So just to summarize, this was the initial ECG. Look at the lead V1 here, and subsequent ECG has progressed into a frank acute coronary syndrome. So small important clue. Another case, 63-year-old man, brief diaphoresis, chest pain, examination normal. ECG was reported as normal. Now just look at this ECG. Look at lead V1, tall T wave. Lead V6, flattish T wave. Again, a very important. Now, how do you know that this is a new? So this is a baseline or old ECG of this gentleman. You can actually compare these two ECGs. Look at lead V1. There is definitely an increase in the height of T wave in lead V1, and that subsequently person develops this kind of ECG, a frank acute myocardial infarction leading to a polymorphic ventricular tachycardia. He was subsequently taken for a rescue angioplasty. Another case, 78-year-old man, and this is the ECG. Again, always remember, these can be part and parcel of a developing infarct. Again, here the lead V1 is T wave is prominent, but not as prominent as in V6. So there is no change of precordial balance, but definitely there is a new T wave, and this was the baseline ECG. You can go back again. This is the current ECG in the chest pain. This is ECG with before chest pain. So definitely it was an inverted T wave, now it has become a positive T wave. This patient was done serial ECG. Again, very important, whenever you do not have access to enzymes or echo, please do serial ECGs. And this gentleman is now clearly been seen to develop into a very global ischemia, something like a left main pattern or a TVD ischemia pattern. Another case, 89-year-old woman, this is the baseline ECG, chest pain, repeat ECG is done, and you can actually see a infarct developing. Again, look at lead V1. So the important thing here is, and this particular thing develops into acute myocardial infarction. So just, I'll get back. This is the ECG, prominent T wave in lead V1, and then it develops into a acute myocardial infarction. Now this is the ECG. What does it show? A very tall T wave in lead V1. Is it NTT V1? No. This is a lead reversal. V1 and V3 have been reversed. This is not a myocardial infarction. So this brings us to, when is NTT V1 normal? So because it's such a small subtle change. So LBBB, LVH, and people with high LV voltages, it can be there normally, but you have to correlate it with clinical symptoms and signs, and also lead reversal. So beware of the upright T wave. If it is new, if T in V1 is more than V6, and it suggests underlying CAD. Coming to the another concept which is named after none other than Professor Hein Wellens, and this was described in way back in 1982. This particular pattern is highly specific for a proximal LAD occlusion more than 75%, and this pattern is described in absence of pain. There are two types of Wellens syndrome which are described. Type 1, which is a deep symmetrical T wave inversion, very easy, anybody can diagnose. What we are interested in the type 2, which is more subtle and more difficult to understand. Sometimes it is passed on as a non-specific STT change. So always remember, Wellens syndrome, the patient gives history of chest pain, but currently during that ECG, the chest pain might not be there. And one important thing, biomarkers can be negative at that time. One tip is, do not stress these patients. Do not put these patients on stress test, they'll infarct. In fact, original series of Wellens, 75% of the patients developed AMI within weeks if it was medically managed. And mind well, that time intervention was in its infancy. So there were no primary angioplasty, other things. Let's see the patterns. Here you have to just make a clear picture of this particular pattern in your mind. Visualize it, because this is nothing. This is just, you have to remember this pattern. Look at lead V2 and V3, biphasic T waves. Again, similar ECG. Lead V2, V3 and V4, biphasic T waves. This is also another ECG example. Just make a note, visual note of this particular pattern. In fact, this is another case where you can actually see it developing. So this particular pattern heralds onset of AMI in next few days. That is one thing. Again, this is again another classic ECG of a Wellens syndrome. You can see how subtle the changes are. In fact, if this ECG is seen in OPD with 100 patients waiting for you, you can pass it off as no, non-specific hai, kuch nahi hai, jaane do. Do not do that. So, summarizing, biphasic T waves in mid-precordial leads indicates proximal LAD stenosis. It is a high risk for AMI and best treated with invasive therapy. Coming to the third sign, early reciprocal changes in AVL. This AVL usually we don't look at very much. But very important thing to note is in lead AVL, ST segments are usually isoelectric and the T wave is upright. And this is one of the leads which shows earliest reciprocal changes, even before the ST elevation in 2-3 AVF occurs. So it is very important for us to look at lead AVL very carefully. In fact, this was described again by Professor Marriott in 1980s. Coming to the case, a 56-year-old man presents with chest pain, and this is the ECG. If this ECG, you carefully see, AVL shows T wave inversion, and other ECG is normal. This is a baseline ECG. You can compare this with this ECG. There is a T inversion in AVL. Here there is upright T wave. Then this patient was subsequently managed, and if you see serial ECGs, he is now getting into inferior wall myocardial infarction. But you don't have to wait for that. I mean, if you really understand that, you can take actions. So another patient where, again, chest pain, you look at lead AVL, T wave is inverted. Subsequent baseline ECG was normal. Subsequently, you can see he develops a myocardial infarction here. You can see this. So, small change can lead to further devastating changes here. Again, when is it normal? LBBB and LVH can have a normally inverted T wave in AVL. These are very, very subtle changes you have to remember. Coming to the last one, and that is called as De Winter sign. Normally, whenever you look at any ST elevation or myocardial infarction, you get ST segment elevation with hyperacute T waves. De Winter is the only time where you get ST segment depression with a hyperacute T wave, and that is a very classical sign of proximal LAD occlusion. So this pattern you have to make a note in your mind. There is a J point depression with a upsloping ST depression going into a hyperacute ST segment, a hyperacute T wave. This is what the angiography said. And again, look at these ECG patterns, make a note of it. This is how De Winter sign classically is seen with ST depression and T wave, hyperacute T waves. I'll sum up this last few slides with one sign which we described from Ruby Hall. We presented a case in PACE in 2007 where J waves were shown to be the precursor of an impending myocardial infarction. In fact, one of our co-authors was Charles Santezele, which was the original author with the Brugada brothers for Brugada syndrome, wherein we postulated that J waves are indeed repolarization abnormalities which lead to ST segment elevations, and this article has been cited by many papers so far. And I'll finish off my talk with this ECG, and this ECG is one thing which you have to remember. This is left main coronary artery occlusion, more than 8 leads ST depressions with AVR ST elevation. Please do not mistake this ECG, otherwise valuable lives will be lost. So just to carry a home message, beware of biphasic T waves in B22, V4, Wellen syndrome, beware of the upright T waves in lead V1, and reciprocal changes in the AVL may be the first sign of inferior myocardial infarction. Thank you very much.
Thank you, sir, for this very informative presentation. We now request the chairpersons to felicitate Dr. Rituparna Shinde.
For our third presentation for the day on a very interesting topic of ACS mimickers, I would like to call on stage Dr. S.B. Gupta sir, Senior Physician Cardiologist from Mumbai, ex-HOD Medicine and Cardiology, Central Railway Hospital, Mumbai, ex-Consultant Physician Cardiologist, Asian Heart Institute, Mumbai. He is also advisor in Indian Society of Electrophysiology.
Good morning to all of you. At the outset, I would like to thank Dr. Parale and his whole organizing team for inviting me to Solapur and respected chairpersons. I think I must tell that Solapur is my first posting in railways when I started my railway career in 1979, and I worked here for 1 year. So that brings a lot of good memories of Solapur. Now my talk is on ACS mimickers, and I'll just show you certain ECGs, and if you see in this ECG where you are seeing ST segment elevation and lead 2, 3, AVF, and especially in precordial leads are more prominent. So if you just see this ECG, maybe one may say we are dealing with acute coronary syndrome. Similarly, another ECG again showing ST segment elevation in inferior leads as well as in precordial leads. So if you do not know the history, sometimes you may be mistaken, but if I tell you this is an ECG of 20 or 22-year-old male who is asymptomatic, and his earlier ECGs and the following ECGs are the same, then you know you are dealing with a case of early repolarization. So sometimes people do mistake early repolarization for ACS. Now we see early repolarization in different pattern where you see SC segment elevation with upsloping SC segment. Then there may be a J wave with again an upsloping SC segment. Then I think this is a pattern where you see a J wave and you see a downsloping SC segment or a straight horizontal SC segment. And sometimes you just see the J wave in the QRS complexes. So these are the different patterns. But the problem comes when you see a 45-year-old male who is a known case of coronary artery disease, and he presents with chest pain, and you see the ECG are like this. Then you are confused whether we are dealing with ER or acute coronary syndrome. And we know that patients of acute coronary syndrome, if they have got ER, there are high chances of ventricular fibrillation, or there is more mortality, especially if the early repolarization where the SC segment is downsloping or horizontal. Now this is another ECG where you see SC segment elevation in precordial leads and in the inferior leads. It's like a global SC segment elevation. Again, if you do not know the history, you may say maybe this patient belongs to acute coronary syndrome. But if I tell you this is an ECG of 32-year-old with persistent and positional chest pain with history of fever, so then you know you are dealing with acute pericarditis. So in acute pericarditis, you get SC segment, global SC segment elevation, which is downsloping. And if you see the PR segment is upright, the PR segment is depressed, and there is diffuse PR segment depressions are there. So these are the, I think history is more important than just evaluating the ECG. Now to differentiate between acute pericarditis, myocardial infarction and early repolarization, the ST segment is concave upward in pericarditis, concave upward in early repolarization, and convex upward in myocardial infarction. Q waves are absent in acute pericarditis and early repolarization. Then reciprocal SC segment changes are seen in MI. Location of SC segment elevation, these are sort of global, while early repolarization is more common in precordial leads, and myocardial infarction, it's the area of involved artery. There is a loss of R wave voltage in myocardial infarction, and PR segment depression is seen in cases of acute pericarditis. Then you see such an ECG again, marked SC segment elevation, you may feel that this is a patient of massive acute MI. But if you know the history that this patient is a case of CKD who is on different drugs like ARBs or MRAs, then you know you are dealing with the case of hyperkalemia. And if you treat hyperkalemia, then this is the ECG. So this ECG belongs to a case of hyperkalemia. Now if you see such an ECG, again classical, it may look like acute coronary syndrome or acute MI. But again, if I tell you the history, this is an ECG of 30-year-old female who was sitting in a lobby and got the news that her child has got atrial septal defect and she collapsed, and ECG was taken. So this is the ECG. But again, if you know, there is a condition called as stress cardiomyopathy or Takotsubo cardiomyopathy, and we do 2D echo image was done. It shows the apical ballooning of the heart, and after a few weeks, after 6 weeks, of patient has recovered completely and coronaries are normal. So this is an ECG of stress cardiomyopathy or Takotsubo cardiomyopathy. And ECG and echocardiographic features, they reverse within a few weeks. LV function becomes normal in just maybe 3 to 10 days. Prognosis is much better as compared to AMI, but there are case fatality rates are there, and sudden cardiac death can happen because of cardiac rupture. ECG shows SC segment elevation in anterior, inferior and lateral leads with more pronounced SC segment elevation, and echocardiography, as I have shown you, a marked apical ballooning of the LV apex in the acute phase of presentation. Now another, you see such ECGs. Patient may be asymptomatic, There may be a history of there are 4 ECGs of different patients, but presentations are like there is maybe a history of sudden cardiac death or these are the ECGs of Brugada syndrome. You see V1 and V2, the ST segments are elevated. There may be an appearance of right bundle band block. So these are all the 4 ECGs are cases of Brugada syndrome, which may mimic like acute coronary syndrome. Now, if you see this ECG, again, I'm going to non-ST-MI. So if you see such an ECG, again you may say कि most probably you are dealing with acute coronary syndrome with an ST-MI. But if you again know the history, then sorry. If you know the history, if you examine the patient, this is the ECG of apical hypertrophic cardiomyopathy, where patient may be asymptomatic or he may be having just a shortness of breath, and this is the ECG. So, and sometimes even severe hypertensive heart disease who has got gross LVH, sometimes they mimic like our patient is having chest pain, because a lot of hypertensive heart disease patient also complains of chest pain. So how to differentiate between left ventricular hypertrophy or ischemia? These are the differentiating points are there. So you can differentiate between the LVH and ischemic T wave changes. This is another example, maybe the last example. Again, if you do not know the history, you may say this is an acute coronary syndrome. But if you know that this ECG is of 75-year-old male patient who has come in a comatose condition, and likely that he has got either intracerebral hemorrhage or subarachnoid hemorrhage. So this is the ECG when we see there is nothing coronary artery disease, but these are the ECG changes of intracerebral hemorrhage or subarachnoid hemorrhage. So just to conclude, whenever you are reading an ECG, always read ECG in the context of history and examination. I think that will give you a lot of clue as far as the diagnosis is concerned. Thank you. Thank you very much.
Thank you, Gupta sir, for the great lecture. I request chairperson to felicitate sir.
I think just before I leave, the 2 announcements. We have got, no, sorry. Can we have the slide, please? We have got ISEOCN 2024 in February, 9th, 10th and 11th February at Ahmedabad. And Dr. Anup Gupta, he is the organizing secretary. So I request all of you to be there. And those physicians and cardiologists who are not the members of Indian Society of Electrocardiology, I request all of you to become the members of ISC. Thank you.
I request chairperson to felicitate sir.
For our next talk, we would like to invite Dr. Ajay Mahajan, who is a senior interventional cardiologist and the head of the Department of Cardiology at KEM Hospital, Mumbai. He is the recipient of various awards, including the prestigious Maharashtra Vaibhav Award, and he will be speaking on ominous ECG markers in acute coronary syndromes.
Good morning. My sincere thanks to the organizing committee for giving me this opportunity to stand in front of you and giving this lecture. So this lecture I just designed for the PG students. Actually, most of the things are already covered by Dr. Shinde and Gupta sir. So coming to one new concept which is coming, that is occlusion myocardial infarction concept. So if the arteries are occluded, then the ECG will get evolved, and sometimes the sensitive progression of ECG changes takes some more time. So when in that particular case, the most important thing is history and history of chest pain. So never ever deny the respect to the chest pain history. Always if there is a chest pain, always you have to see the ECG, repeat the ECG and find out some signs. So coming to the 10 ominous signs, one is valence, second is D winters. Already these 2 are discussed by Dr. Shinde. Then dead man sign, that is a new thing. Then South African flag sign. Then Tomstum ST elevation, shark fin sign, ABR elevation, Garbosa pattern, isolated ST depression and RBB pattern. So valence sign, already we had, Dr. Shinde had discussed, that is the biphasic STT changes, which was described by Dr. Valence in 1982, which is suggestive of proximal LED occlusion. So subsequently, Valence student, Dr. D. Winter, he had described similar sign in lead V1, V2 in 2008, and it is a J point depression with a ST depression with a tall TVOs in proximal anterior leads, and it is also suggestive of total occlusion of the proximal LED. So what is the difference between the valence TVOs and D. Winter's TVOs? So this is the difference. So there is a ST depression with the J point with the tall TVOs, while valence there is a biphasic TVOs. So both the things, there will be proximal LED occlusion, but in then this is a new sign which is coming, that is the dead man sign. So it is suggestive of very hyperacute inferior myocardial infarction, and you can see this particular thing, lead AVL and lead AVF. There is significant depression in AVL and elevation in AVL, and ultimately it gives the diagram suggestive of dead man sign, and it is suggestive of hyperacute inferior myocardial infarction, and in that case the angiogram shows proximal RC occlusion. Then very interesting thing which comes for the circumflex territory, there is ST elevation in one AVL with subtle ST elevation in lead V2 and significant ST depression in lead 3. So this is a South Africa flag sign. It is suggestive of circumflex or OM occlusion. If you do the angiogram, you will get the circumflex occlusion. Then when there is a very proximal LED occlusion, when there is a absence of ramus or proximal OMs or diagonal, then you will get a very tall TVOs, particularly in V2, V3. They are like a tombstone, and there is associated elevation in one AVL also. So it is a very large anterior myocardial infarction which is coming from the ostial LED or proximal LED without any collaterals or without any collateral findings in that thing. Then come the shark fin sign, which are described in 2011. So it is also a mimic of hyperkalemia. Sometimes in patients with a severe chest pain with a ST elevation in anterior lead, one may get this type of sign, and this is also known as a shark fin sign, and it shows proximal LED occlusion. Then this is the most important thing which was described in 1996, that is Garbosa criteria, and in presence of LBBB or in presence of paced rhythm, how to diagnose the ischemia. So this is the most important slide for all PG students. So ST segment elevation with concordance pattern, or ST segment depression, or some new signs like a Cabrera signs, Chapman sign. So the concordant ST elevation, then discordant ST elevation and ST depression. These are the three important things. So if there is a concordant ST elevation, that is a very specific. Discordant ST elevation more than 0.5, or if the ratio is more than 0.25 of all QRS segment, and then ST depression in V1 to V3. So it is suggestive of ischemia or infarction in that particular territory. So same thing is here. So you have to take the ratio of ST segment elevation to the total ST segment duration, and if it is more than 0.25, then it is suggestive of ischemia. Then AVR elevation. So the AVR is one of the most neglected need. Most of the time this AVR we don't give respect, but the AVR is the lead which is very important for the left main or left main equivalent. So if there is any chest pain with the AVR elevation, you have to give the respect, and most of the time these patients present like a very proximal left main or ostial left main, and there you will get a significant ST elevation in AVR with along with the ST depression in anterior leads. So AVR is one of the most important lead. If there is any changes in AVR with some changes in anterior lead, we have to give the respect to that. Then another important thing is that sometimes one may get a isolated STD changes in V1, V2 with a significant chest pain. This is in spite of absence of RVO in V1. So this one may get in patients with a true posterior myocardial infarction. So if there is a distal RCA involvement, one may get this type of ECG changes with ST depression in V1, V2. Then now we just describe one new sign. There is isolated ST elevation in V1, V2 with RBVP. So subtle changes, minimal changes with some ECG changes in V1, V2 with a chest pain. And when we do the angiogram, the patient present like this, there is some atheromatous changes or thrombotic changes, and there is a knockdown of S1, and there is a patent LED. So these are the signs. This sign we had given the name of card KM sign because we had just reported this particular ECG changes now. So take home message, symptoms are more important. Patient may not always present with the traditional STEMI. These notable hallmark patterns of ECG should be kept in mind. Biomarkers may prove to be helpful in some cases. Some subtle ECG changes, one may have to take the help of biomarkers. The new paradigm of ECG in acute chest pain is either it is because of occluded myocardial infarction or non-occlusion myocardial infarction. Non-occlusion myocardial infarction ECG changes may not evolve to the classical STD changes, but still we get a chest pain with some ECG changes. And remember, the most important thing is time is myocardium, and time will decide the outcome. So all patients with chest pain, we have to take the history properly, and we have to repeat the ECG if the ECGs are doubtful, and try to find out some changes in the ECG, and if they are there, then we have to go and take the patient for early revascularization, either by pharmacotherapy or by invasive approach. Thank you.
Thank you, sir, for this very comprehensive presentation. I now request the chairpersons to felicitate Dr. Jai Mahajan. Can we have a round of applause from the audience? Thank you, sir. We have a small announcement to make. In between the sessions, we will be having multiple quizzes for the audience. So the link for the quiz will be displayed via a QR code on the screen. So I request everyone to download a QR code scanner from the App Store.
Thank you, all the chairperson. Considering the very tight jam-packed sessions for the day, I request all the esteemed faculty to stick on time for the lectures. Now we start the second symposium for the day on critical care. For this, I will like to call upon the stage Dr. Vitthal Dhadke sir, Dr. Mahendra Joshi sir, Dr. Sheetal Mehta sir, Dr. Sanjay Raut sir. For the very common clinical issue we face in the ICU setting or casualty, that is non-ischemic arrhythmias, I will like to call on stage Professor Dr. Vijay Garg sir, Senior Physician Cardiologist from Ujjain.
आप सबको नमस्कार. First of all, I am highly thankful to Solapur team for a nice arrangement and nice gathering. I came from the city of the Lord Mahakal, which is the one of the topmost Jyotirling in India. So I salute Lord Mahakal and I will start my talk. I salute these three stalwarts, Professor J. Valence, Valor, enthusiasm, who invented ECG, and 100 crore ECGs we are doing in 1 year. Arrhythmia is a very common thing. In the presence of abnormal cardiac rhythm, impulse production arrhythmia can be grouped into 6 categories: premature beat, non-sinus rhythm, fibrillation, tachycardia, bradycardia, and atrial fibrillation. Atrial fibrillation ventricular fibrillation, tachycardia are most commonly seen in arrhythmias. In addition, impulse conduction arrhythmias include AV blocks, bundle branch block, WPW syndrome, and escape beat. So my talk is common problem encountered in ICU represent a major source of morbidity. In the critically ill patient, arrhythmia can be caused or potentiated by increased catecholamine, hypoxia, hypercarbia, severe acidosis, gross electrolyte imbalance, pain and anxiety. And you will be surprised to know that patients who are having sustained ventricular arrhythmia have got a more 73% mortality in ICU and 29% mortality in supraventricular arrhythmia and in CNS disorder. So management include correction of this imbalance as medical therapy directed to arrhythmia itself. Arrhythmia is in critical because of structural influence or because of transient influence like hypoxia, acidosis, electrolyte imbalance, neurophysiological balance, and toxicity. Risk factor for arrhythmia in intensive care are male gender, more than 70, pulmonary diseases, electrolyte disbalance, volume fluctuations, critical ill, CKD, thyroid disease, metabolic derangement, vasopressure. Well, first, we have to decide when the patients present with arrhythmia in critical care, non-ischemic, if there is any urgency. And the marker for urgency are hypotension, ischemia, heart failure, altered mentation, and other signs of hyperperfusion. So you have to be very guarded and you have to be in frontier for treating the arrhythmias. Causes of arrhythmias, I already told you. The most common arrhythmia is atrial fibrillation. In 31% patients of ICU, triggers of atrial fibrillation during critical illness are receiving vasopressor agent, dopamine, dobicin, noradrenaline with electrolyte derangement in patient with greater disease of severity. Atrial size on echocardiography with new onset of AF in the ICU. Vasopressor may cause hypokalemia and changes in the balance of autonomic activity, hence altering ion channel activity and cell automated predisposed to AF. Regarding management, we will hear in again in 2 days so that I am not covering supraventricular arrhythmias, a wide QRS tachycardia. It is important to differentiate SVT and VAT. And if the diagnosis is not possible, tachycardia should be treated as a VT. This is the fundamental rule. Amiodarone may be necessary in case of impaired LVA functions. In case of recurrence, ablation may be there. Now, ventricular arrhythmia. It is very difficult, and our PGs are frightened whether it is wide QRS is SVT with aberrant or ventricular tachycardia. I wanted to tell only two things. Initial R wave in AVR, AVR with initial QE more than 40 seconds. AV dissociation, QR is more than 140 millisecond and left axis deviation. And if patients having structural heart disease with QR more than 0.8, it is VT. And still if you are not sure, treat as a VT. And this is the management of ventricular arrhythmia in post-surgery patients are like they think PVC, symptomatic may require SVT. If patients having hemodynamically unstable, nothing. If patient is having hemodynamically unstable, then procainamide, amiodarone, electroconvulsive therapy. VF, we know all. Patient DC, polymorphic VT, we know electrolyte corrections, isoproteining, and patients having in patients having ES defibrillations. And these are the cardiac causes of arrhythmias in ICU. And you must know cardiomyopathy, congenital heart disease, aortic stenosis, mitral valve prolapse, long QT syndrome, drugs, idiopathic, electrolyte imbalance. And these are the non-cardiac causes of pulseless electrotherapy. Always should be known: pulmonary embolism, stroke, aortic dissection, tension pneumothorax, sepsis, neurogenic drug overdose. Premature ventricular VCV, as I told, if patient is not asymptomatic, nothing should be done. If PC is more than 30 per hour, may influence the short-term outcome by reducing ventricular functions. Now we are having PVC cardiomyopathy also. Polymorphic ventricular tachycardia, always be dealt. Patients having drugs, lot of drugs causes that thing. Management differing markedly from other form of VT. And this is the things electrical storm is a ventricular tachycardia, refer to the occurrence of 3 more episodes of VT and should be treated like that thing. Supraventricular and ventricular in the pregnant patients, amniotic fluid embolism, obstetric hemorrhage, obstetric infections can cause ventricular arrhythmias, and pregnancy is a risk factor both SVT and VT. Bradyarrhythmias are common sinus node functions because of hypothermia, hypoxia, hypothyroidism, muscular dystrophy, CNS diseases, and all these causes that thing. Dizziness, syncope, and congestive heart failure. AV blocks is also very common. Arrhythmias in specific situations. Arrhythmias in septic situations. Sepsis-related myocardial infarction does not relate to myocardial ischemia and necrosis, but it associates cytokine-induced myocardial depressions. Study shows new onset of atrial fibrillation episodes with high mortality rate in critical septic patients. So if patients having septicemia with atrial fibrillation, take care. A new AF event lead to be treated by electrical or pharmacological cardioversions. AF in pneumonia setting is a distinct entity, even the setting of pneumonia, it should be therefore managed with guideline-oriented approach. Is the most common arrhythmia in the setting of critical indispositions. Arrhythmias in acute respiratory failure is the transmembrane action potential of cardiac conductive tissue causing electrophysiological phenomena known to trigger arrhythmias. Arrhythmias in COPD with ventricular tachycardia mortality was around 4 to 50% in 8 area. Common arrhythmias are atrial tachycardia, supraventricular, ventricular arrhythmia. Arrhythmias in acute kidney injuries in a population patient with severe hyperkalemia required hospitalization. Close relationship between renal dysfunction and bradyarrhythmia should be treated. Various electrolyte abnormalities we all know, hypokalemia, calcium, magnesium, and hypercalcemia. Acute brain injury. Patients having brain injury, 28%, 37% with acute stroke and subarachnoid, we get arrhythmias. Arrhythmias in COVID. Current understanding of impact COVID in continuing to evolve new data. To manage these arrhythmias, it is imperative to increase the awareness of potential drug-to-drug interaction, monitor QTC prolongation while receiving COVID therapy, and provide special consideration for emerging. And these are the important arrhythmias, all sort of arrhythmias we had get in a COVID cases. Now ventricle mimics. Most common mimic in real world. Advent of recording devices, smartphones, VHS, where long-term ambulatory monitoring, loop recorder, pacemaker and device, we take care of these things. Characteristic things, artifacts by electrical interference, inadequate grounding, skin interference, improper hair unit jelly applications. Common sense of attending collision should be kept in mind, including in the absence of hemodynamic deprivations during the event. An unstable baseline should be kept in mind with ventricular mimic. And these are the example of mimic, normal rhythm, Parkinsonism. And please remember these things because of advent of computerized ECG. Always see for arrhythmia with raw ECG baseline, otherwise you will be in the soup. And this is the important ominous sign in critical care, spike helmet sign. This is described in circulation. Patients present with septicemia, patient present with acute respiratory failure, and if you get this type of sign, it is ominous sign. It is the ECG of a dying heart. And first step in arrhythmia to summarize, to assess the hemodynamic status of the patient. If hemodynamic status is poor, DC shock is the treatment. If cardiac shock, arrest is there, cardiac shock is there. If patients having cardioversion and decay arrhythmia. These are the arrhythmias we can treat without cardiac drugs like pulmonary embolism, medication, mechanical hypothermia, metabolic acidosis, hypothyroid, hypoxia. In summary, occurrence of arrhythmia in patient under critical care significantly worsen the prognosis and disease outcome. Never diagnose the cause of wide complex tachycardia based on the ECG isolation. Clinical correlation is must. ECG recording doctor will help to detect the occurrence of arrhythmia. Thank you very much.
Thank you, Garg sir. I request chairperson to felicitate Garg sir.
For the next talk, we would like to invite Dr. Jagdish Hiremat. He's the senior interventional cardiologist with more than 25 years of experience and the director of Cath Lab at Ruby Hall Clinic, Pune. He's the president of Pune chapter of Cardiology Society of India, and he'll be speaking on ECG in poisonings today.
Good morning to you all. If you ask me how many ECGs I have seen in poisoning, very few in the last 30 years. That means it's something which is not very common. And if you search through literature, everything is talking about drug toxicities. And that topic is following this. So as such, content-wise, I have very few things to show you. Let's say the commonest poisoning is a snake poisoning. And though we think sinus bradycardia would be common, it is mentioned that a lot of sinus tachycardias are also seen, especially seen in vascular toxic snake bites. They have tachycardia. And other poisonous snake bites can have sinus tachycardia, sinus bradycardia, and non-specific STT changes, AV blocks, and sinus arrhythmia. It constitutes about hardly 2% of all the cases. We've seen this and we have given loads of atropines, and we see on medical emergency days, next day, many patients in atropine toxicity related to snake poisonings. Dish toxicity I was going to talk of, but I think I'll leave it for the next topic because I wanted to show this ECG of atrial fibrillation with complete heart block. Like a patient of A being treated with AV blocking drugs comes with a regular pulse, and you find that pulse is slow and regular. It's a complete heart block established by the combination that you have used. And many times because of this combination, there could be complex arrhythmias which are over-treated by temporary pacing. Many poisonings can come with prolonged QT intervals, and the QT intervals, as you know, are the three types, with a broad-based T wave, or the second one is a T wave with a low amplitude, with a distal bump, which is actually so many times a U wave combining with the T wave, and long ST segment. T wave occurs late and is prolonged. So all these three are possible in various types of poisonings, and especially they are described in drug toxicities. So this is acute sotalol poisoning with marked QT interval, and of course with VPBs, a perfect milieu for a torsade. This is a QT prolongation with a T wave which is broad, and if you see the QTC, it is markedly prolonged. Another type of QT prolongation where the T remains, ST segment remains flat for a long time, and then you get a distal inversion of the T waves. And all these drugs cause, I would talk of cocaine toxicity more in the latter part. Cocaine can also lead to Brugada pattern, and again there are of three types. We'll be discussing Brugada almost ad nauseum through the conference. So I would just give you the visual impression of what Brugada-like syndrome or Brugada ECG pattern looks like. And many of the poisonings described can get right bundle bronch pattern, or a Brugada pattern seems to be extremely common in many types of poisonings. So this is a Brugada pattern, another type, and another type. So many of the poisonings are still coming under toxicology. So it would be tachycardia, bradycardias, wide QRS, narrow QRS, all this I'm sure will be covered in the next talk. I'll stick to the last part, that is cocaine toxicity, cocaine overdose. Not uncommon. I've seen one patient of cocaine overdose, and he came with frank acute coronary syndrome. But cocaine also can cause wide QRS tachycardia. And this was the patient wherein you get coronary spasm, ST elevation in mainly leads, coming with typical symptoms of chest pain, acute coronary syndrome, and treated with nitrates and other drugs, and usually the coronary arteries are quite normal. It's not such a menace so far in our society, but probably we are heading there. Then there are poisonings which lead to all these electrical arrhythmias like hyperkalemia, hypokalemia, or hypercalcemia, hypocalcemia. All these patterns we should remember and then try to fit in what poisoning it can lead to. As I said, very tall tented T waves are early signs of hyperkalemia, and then we go on to the sinoventricular patterns which come in later. And hypokalemia can have a prolonged QT interval and a U wave mixed with it. So it's an exceptionally prolonged QT interval, as you can say. And this is a kind of a diffuse ST segment. You can't make out where the ST segment has ended or the T wave has ended. Hypocalcemia is also seen in many poisonings. And if you, one thing which comes to my mind is the chelation therapy, which is done. In chelation therapy, all the calcium probably absolutely gets sucked out, and your patient can come with hypocalcemia. It's a very well described pattern, abnormality or complication of chelation therapy. It leads to prolonged QT interval due to lengthening of the ST segment, flat ST segment and terminal T wave inversions, heart block and VF when hypocalcemia is severe. And this is all could be seen like this. T wave which is prolonged. And hypercalcemia also peculiarly can result into some of the drugs. None of the real poisonings have been showing to have hypercalcemia. I would remember a thiazide diuretic causing hypercalcemia because they reduce the renal excretion of calcium, so overdose of that. And this kind of ECG changes are possible, which looking like Brugada again, but all these described findings here of hypercalcemia, like a short QT interval, shortening of the ST segment, flattened and widened T wave with ST elevation. Third point, increased QRS voltage without, of course, left ventricular hypertrophy. Notching of the terminal portion of the QRS complex for a prominent J wave. All these are seen in this one particular ECG, wherein shortened ST, shortened QT, tall QRS complexes and tachycardias are noted in this ECG. Many of the poisonings which are seen are actually because of the leaves and the seeds which are consumed accidentally or in a suicidal intent. And the toxins are basically cardiac glycoside and alkaloids. So they are digitalis-like toxicities like in Nerium poisoning, Thevetia poisoning. And the spectrum of all the ECGs actually is like a digitalis toxicity. Then we have Datura poisoning, which actually is belladonna, like atropine-like effects related to that. But Datura can cause prolonged QT. I have seen cases presented of Datura poisoning in CMEs with remarkably abnormal ECGs. Crude opium leads to tachycardia and conduction abnormalities and ST changes in Q waves. This is the Datura plant and the flower which is generally seen. And this was one ECG presented which actually was very similar looking to the sotalol poisoning that I showed you. But look at the remarkably prolonged QT interval, and this kind of abnormal thing you can be seen in Datura poisoning. The other poisoning that is thought of is the kaner. That is a kaner what we get in Maharashtra, and otherwise it's a little different. But yellow oleander or kaner is exceptionally toxic plant. Not only the flowers, the seeds. In East India and Sri Lanka, it is consumed as a suicidal, with a suicidal intent. So it's a highly poisonous seeds, usually consumed with suicidal intent. There is a data related about 300 patients from one of the East Indian universities. 300 patients over 1986 to 1990, I think. 46% had various types of arrhythmias. Sinus bradycardia was the commonest. And autopsy in these patients revealed focal myocardial edema and perivascular hemorrhage. So actually the kaner was causing those abnormalities and leading to these arrhythmias. At the time of discharge, many of those who had reverted back to normal, but some of them retained sinus bradycardia and ST segment changes in the after discharge also. So dictum to remember in poisonings is unexplained acute changes in ECG, like all above, should alert towards the poisoning or toxicity. Because of suicidal attempts and denial, history may have to be dug out. Patient may not come out with the history at all. Drug-induced should also feature in the differential diagnosis when patient is on medication. Never be shy of approaching the net or even in front of the patient. The lawyers do it all the time, so we can do it also. And the last line, do not eliminate Ayurvedic, homeopathic or Unani drugs from the suspicion when you come with bizarre ECG arrhythmias. Thank you.
Thank you, sir. We would now request the chairpersons to felicitate, sir.
Thank you, sir. For the next interesting topic on ECG in drug toxicity, I would like to call on stage Dr. Panchanan Sahu, sir, renowned cardiologist from Bhubaneswar, who is Professor Cardiology in Kalinga Institute of Medical Sciences, Bhubaneswar.
Respected chairpersons, I am immensely delighted to be part of this midterm ISEOCN conference at Solapur. I am thankful to the organizers, Dr. Perelle and Dr. S.P. Gupta particularly for giving me this topic as a faculty on ECG in drug toxicity. As you know, ECG changes in cardiac and non-cardiac drugs are very diverse, and they cause ECG changes at therapeutic and toxic levels also. And in drug toxicity, the mortality is mostly due to cardiac complications. And in some cases, ECG changes encountered due to drug overdose or poisoning becomes challenging for survival of the patient. So my approach to the topic will be on three headings. The therapeutic, when you see overdose of a drug or toxicity of a drug, we see the ECG. The second in the pharmacological research, when study the drug, the ECG changes at a spectrum of dose of the drug is studied by ECG. The third in drug toxicity already covered by Dr. Hiramat in forensic medicine for drug toxicity, we look to the ECG. My approach to the ECG, it is just like any other 12-lead ECG study, starting from the rate, rhythm, PR interval, QT prolongation, ST changes, QT interval, and with prolonged interval, the torsades, pontis, ventricular tachycardia, ventricular fibrillation. Whatever we find in the ECG, we have to study the ECG very well. And this is a electrophysiology, just I have shown the mechanism of the drug action, drug toxicity. The cardiac action potential, we must look into it. It has phase 0, phase 1, 2, 3, 4. In phase 0, the sodium becomes intracellular, and phase 0. In phase 1, the potassium starts to be extracellular, and calcium becomes intracellular. The depolarization, cardiac cell contractility starts, and in phase 3 also there is the potassium efflux, and phase 4 there is the sodium potassium ATPase change. So the mechanism of cardiac toxicity already I have started telling. The sodium channel blockade leading to slowing of the phase 0, blockade of the potassium efflux in phase 2 to phase 3, and sodium potassium ATase pump blocker in phase 4. Besides other mechanisms, beta adrenergic blockade, calcium channel blockade, myocardial ischemia and hypokalemia, all these mechanisms can lead to drug overdose or toxicity, ECG changes. So the sodium channel blockers, as we know, there is a battery of drugs starting from antiarrhythmic class 1A, class 1C, class 3 drugs, local anesthetics, the tricyclic antidepressant drugs, antimalarials, amantadine, and diphenhydramine, carbamazepine, all these cause sodium channel blockade. And the ECG changes also, there are very wide ECG changes, starting from QRS widening, right bundle block, right axis deviation, or elevation in AVR, VT, VF, bradycardia, STT changes, asystole, all these can occur due to sodium channel blockade. And the potassium channel efflux blockade, the similar drugs, starting from the antiarrhythmic drugs, class 1A, 1C, class 3, and antidepressants, other antihistaminics like diphenhydramine, amantadine, all these cause potassium channel efflux blockade. And the ECG changes, as we know, start from QT prolongation, and with significant QT prolongation, there is torsades de pontis, and sinus tachycardia, T and UF abnormality is found in potassium efflux blockade. Then this important, from our MBBS days, we see digitalis poisoning, digitalis effect. The mechanism we know that sodium potassium ATase blocking is the mechanism, and these drugs can diverse ECG changes, supraarterial ectopy, atrial tachycardia, atrial flutter, fibrillation, oscillator junctional rhythm, ventricular premature complaints, VT. Bidirectional VT is very typical of a dioxin poisoning, first, second, third degree AV block, combination of atrial tachycardia and second degree AV block, sinus bradycardia, junctional bradycardia, when can work with JBP is also typical of a dioxin effect. Then the sympathetic inhibitors, the methyl dopa, reserpine, prazosin, they cause sympathetic blockade. ECG changes can be sinus atrial, junctional, ventricular bradycardia, fast and fast degree AV block, ventricular tachyarrhythmia, all these are possible with a sympathetic blockade. Then the calcium channel blockers blocking, we know the first, second, third, fourth generation calcium channel blockers. Besides diltiazem, benzothiazepine, bepiridil, all these drugs, calcium channel blockers, can cause a lot of ECG changes, sinus bradycardia, reflex tachycardia, varying degree AV block, sinus arrest, asystole, wide QRS, and ST and T changes. So the dioxin toxicity, as I already told, very common. We read, although dioxin was invented some more than 400 years back by William Withering, still it is in use. And we know very well the downsloping ST change, the reverse tick sign in dioxin overdose or poisoning, that is Salvador Dali sagging appearance. And in dioxin effect, the mechanism, as we have already discussed, dioxin effect refers to presence of the Salvador Dali sagging appearance or reverse tick sign. And the ECG changes can be sinus bradycardia, slow atrial fibrillation. This is sinus bradycardia, slow atrial fibrillation, frequent VPC, ventricular bigeminy, trigeminy, and any type of heart block, first, second, third degree, regular AF. My previous speaker was telling, when atrial fibers become regular, we suspect it is a complete heart block. And treatment of dioxin toxicity, besides taking care of the electrolyte imbalance or whatever gastric side effect, then we, in advanced dioxin poisoning, we think of digifab or fab antibody digibind we use in advanced cases. Then ECG in drug toxicity, I have told various drugs. ECG is essential for screening, diagnosis, and day-to-day monitoring for drug overdose and poisoning in drug toxicity. This is we know that organophosphorus is a very dangerous causes QT prolongation, torsades fundus, ventricular arrhythmias, also myocardial ischemia, myocardial infarction, besides electrolyte imbalance. This just I have shown a organophosphorus poisoning on day 5. R-on-T phenomena is also common, which is very fatal in organophosphorus poisoning. And in organophosphorus day 5, it can cause myocardial ischemia, infarction. It is anterior myocardial infarction. As we see the ST elevation in V1, V2 due to organophosphorus poisoning in day 4. And most abused drugs in arrhythmia like amphetamine, cocaine, cannabis, gamma-hexyl benzamin, hallucinogens, opioids, propoxyphene, all these drugs, of course I have not seen adverse effect of many of these drugs, but in practice we see all these drugs causes ECG changes. And already you have seen my previous speaker was telling of sotalol poisoning, which causes very advanced prolonged QT. And bradycardia QT interval prolongation is more marked in cases of bradycardia, causing more symptom. And severe QT prolongation, it can cause polymorphic ventricular, premature ventricular beats. So, besides the drug effect, so we have to look to the ECG being most important in cases of drug overdose and drug poisoning, which has to be seen carefully for treatment or to be sent for treatment of the poisoning. Thank you. Thank you, sir.
Thank you, Sahu sir, for the great presentation. I request chairperson to felicitate Sahu sir.
I think just to let you know, the next midterm conference will be in Bhubaneswar, and Dr. Panchanan Sahu will be the organizing the conference. So next September in Bhubaneswar.
I thank all the chairperson. Now we will be starting with the third symposium for the day on atrial fibrillation. As chairpersons, I would like to call on stage Dr. Praveen Kulkarni sir, Dr. Prem Zawar sir, Dr. Viraj Kalburgi sir, Dr. Milind Lamkane sir, Dr. Ilyas Kampali sir, on the next topic of when and how to cardiovert, I would like to call on stage Dr. Amit Vora sir, a renowned cardiac electrophysiologist from Mumbai, ex-associate professor, Department of Cardiology at KEM Hospital, Mumbai.
Good morning to all of you, and with the permission of the chair, may I start? So, cardioversion for atrial fibrillation, when and how? I guess cardioversion is meant to restore sinus rhythm in atrial fibrillation, And the way we can achieve it is by pharmacological or chemical cardioversion using antiarrhythmic drugs, or we give a synchronized direct current electric shock and do an electric cardioversion. Electric cardioversion often will be done in conjunction with antiarrhythmic drugs on board because that increases the efficacy. The key to remember when you perform an cardioversion is to take care of thromboembolism. So not to forget anticoagulation in these patients when you are performing cardioversion. If I were to briefly enumerate the classic reasons why we consider cardioversion in atrial fibrillation is, in an emergency or an acute situation, if you have a very rapid ventricular rate beyond 150, 160 persistent all the time, if you have a patient who complains of angina along with the rapidity of the heart rate and atrial fibrillation, if he's gone into heart failure, has pulmonary edema or hemodynamic compromise, low blood pressure, if you have atrial fibrillation in a patient with WPW syndrome, fast, broad, irregular, very rapid tachycardia, these are the classic reasons why you would immediately want to do an electric cardioversion. Also to remember is the AF types. Which are the types of AF where we think in terms of cardioversion? One is the recent onset atrial fibrillation. Now, here lies a little bit of catch, and one needs to understand. When we say recent onset atrial fibrillation, I think we talk of those within 48 hours. Now, those who are very acutely presenting with a new onset or a paroxysmal variety of atrial fibrillation, remember that almost 2/3 of them will spontaneously convert to sinus rhythm within the first 24 hours. So it is not necessary for you to jump into doing a cardioversion in the first 24 hours, but after 24 hours, spontaneous conversion rates go down, and between 24 to 48 hours is the correct window when you want to cardiovert these patients, because after 48 hours also you can do the cardioversion, but unfortunately then the AF has lasted long enough that if the person is not adequately anticoagulated, you will have to have a proper anticoagulation strategy before you consider cardioversion. The other reason is those who are very symptomatic and have persistent atrial fibrillation. So in these group of people, we often want to restore sinus rhythm by means of either chemical, pharmacological or electrical cardioversion. I would recommend that any patient of atrial fibrillation, you should always attempt or give a thought whether rhythm control can be achieved in this person or no. I know that 2 decades ago, Affirm, Race, all those trials debated rate versus rhythm, and they said that rate is equally good as rhythm. But over the years, our understanding has improved much more, and we realize that those who are in sinus rhythm do fare better. So in the current context, make a conscious effort to identify whether you would like to achieve sinus rhythm in a patient and attempt at least once by cardioversion. So now, between pharmacological and electrical cardioversion, obviously pharmacological cardioversion is very popular because it's very simple, effective. I mean, you give a drug and it helps, but remember, it is less effective. It is less effective than a direct current cardioversion. When you give drugs to convert an atrial fibrillation, the drugs can cause toxicity. The main problem is in terms of torsade de points, the long QT and polymorphic VT that can happen. It cannot be considered if a person is hemodynamically unstable. If it's hemodynamically unstable, you have to do electric cardioversion, not pharmacological conversion. And yes, now we have also understood the pill in the pocket where the patient himself will cardiovert if a structurally normal heart, class 1C drugs could be given. Though electric cardioversion is more cumbersome, it requires conscious sedation and anesthesia, it is much more successful, much more effective. In fact, in my practice, in a tertiary care center, our leaning is more towards doing an electric cardioversion than relying on drug therapy. And of course, electric cardioversion is more effective when a person already is on antiarrhythmic drugs. because electric cardioversion just restores sinus rhythm. After that, you need maintenance of sinus rhythm. Maintenance of sinus rhythm could be achieved if the patient were already on antiarrhythmic drugs. A little bit of backup facility for bradycardia, taking care of bradycardia should be available when you perform cardioversions. What are the contraindications for cardioversion? Are there any contraindications? Virtually not many, but yes, if you think that after cardioverting the atrial fibrillation, there is going to be significant bradycardia. So either a person has a very bad sinus node dysfunction, long pauses history, or a bad AV conduction disease happening, or the patient is on antiarrhythmic drugs, and the possibility of a long QT, which you can identify even during AFib, that's going to be a problem, because if you, with bradycardia, there will be a lot of ectopy, and with the ectopy in a prolonged QT patient, there can be torsade pointus. So just be careful when considering cardioversion in this group of people. So essentially, if you have a recent onset atrial fibrillation, hemodynamically unstable, you should perform an emergency electric cardioversion, no questions. If you have a hemodynamically stable patient, you can choose pharmaco or electrical cardioversion. And for pharmacological conversion, what next question you need to ask is, what is the underlying structural heart disease? That will help you to choose the correct pharmacological agent for cardioversion. So when there is no structural heart disease, no left ventricular hypertrophy, no ischemia, no LV dysfunction, then the drug of choice becomes class 1C antiarrhythmic drugs, flecainide and propafenone, and we can also use IV ibutalide in these people. But all other patients with structural heart disease, our go-to drug continues to remain IV amiodarone. So this is a list of all the drugs which we use in the Indian context. We now have flecainide available, we have amiodarone available, and we have ibutalide available. So a word about these drugs. Flecainide, orally 200 to 400 milligram can be given, but you can use this drug only when you know that this drug in the past has been effective, or the person has a completely structurally and a functionally normal heart. No hypertrophy, no ischemia, no LV dysfunction, safe to use this drug. Intravenous flecainide is not yet available to us. Varnakalant, unfortunately, not available to us. IV amiodarone, our go-to drug, which often we use. Remember that IV amiodarone is not going to act fast. It is going to take 24, 48, 72 hours, a little more also, to get back to normalcy, and just about 50% or so you will be able to achieve sinus rhythm with amiodarone. And giving amiodarone in the acute setting, be careful, because it causes lot of thrombophlebitis. Giving in a peripheral vein is a problem. Giving a longer infusion is a problem. So using a central vein, large bore cannula to inject the drug is important, and take care of these acute things. And of course, QT prolongation is something which you should be always worried about in these people. As I said, one of the important things not to forget is cardioversion. There can be thromboembolism happening. The risk is 1 to 5%, and you need to minimize the risk of thromboembolism happening in a patient when you are planning cardioversion. And it's not that pharmacological cardioversion is going to cause less of thromboembolism. It is as much as an electrical cardioversion can cause. This is because after a period of atrial fibrillation, there is an atrial stunning that happens, be it spontaneous conversion, be it because of drugs, be it because of electric cardioversion, and the stunning of the atrium promotes sluggishness of the flow in the atrium, which promotes the thrombus and thromboembolism. So not only acutely in the first day after the cardioversion, successful sinus rhythm, that there is a risk for thromboembolism, but for the next 10 days, there can be a risk of thromboembolism happening, and therefore appropriate and adequate anticoagulation is the key. So how do you do it? If you know clearly that the AF duration is less than 48 hours, you are allowed to cardiovert immediately, use IV heparin bolus followed by oral anticoagulation once the cardioversion is performed for a minimum period of 4 weeks. If the AF duration is more than 48 hours, and if the person is hemodynamically stable, there is no urgency, in such a situation, you should best anticoagulate the patient if he has not been on anticoagulation for a minimum period of 3 weeks before subject him into electric cardioversion, and post cardioversion continue for at least a period of 4 weeks. But if you have a patient with atrial fibrillation longer than 48 hours, but he is hemodynamically unstable, Because he's unstable, you need to perform the cardioversion. Give him a bolus of heparin. Consider, if possible, if a TE can be done, if the chance of stroke is going to be high, and then you can, based on the CHAD-VAS score, you may want to continue with oral anticoagulation beyond 4 weeks. I think I have short my time, so I will take 1 extra minute. In electric cardioversion, biphasic shock is important. Post cardioversion, cardiac enzymes can be elevated. Paddle location is important. In patients with pacemaker and defibrillators, keep the paddles 6 inches away from the device, and perpendicular vector should be used. Appropriate jelly should be applied. In very obese individual, 2 simultaneous defibrillators may be used. And I think let me conclude here by stating that post conversion also you need to assess your goals. You should look at AF recurrences. You should look at the rhythm control approach, how long you need to continue. You should look at the anticoagulation status. You should look at the side effect profile of the drugs that are likely to happen. You should weigh the pros and cons. You should address the underlying comorbidities also. Thank you very much for patient listening.
Thank you, Ora sir. This is quite a common dilemma we face in casualty or ICU setting. Are there any questions?
Yeah, so as regards ibutylide is concerned, that's a drug which can acutely be used for cardioversion. And that's the only other drug other than amiodarone available to us. And 1 milligram over 10 minutes is what we use. Now, when do you use ibutylide? I think you should use it again, the way class 1C drugs are recommended, that you don't have significant structural heart disease, you don't have LV dysfunction, you don't have hypotension. In those group of patients, ibutylide may be used. So near normal hearts, structurally near normal hearts, ibutylide is a good drug in the ICU setting to achieve cardioversion. And the first bolus does not work. After 10 minutes, you can repeat the bolus. The caveat with ibutylide is again that it causes QT prolongation. So you cannot just give the drug. You need to preempt this patient with a empiric magnesium of 2 grams or so to negate the effect of long QT that is likely to happen post ibutylide, and therefore monitoring the patient, though textbooks would recommend 4 hours minimum, I would say 1 day monitoring of a patient post ibutylide is necessary, where a long QT and torsade like thing may happen when a person converts into sinus rhythm. So it's a good drug, may be used, but to be honest, I have practically not found I have not used it very frequently.
Getting a thromboembolism?
So the chances are pretty high. So after 4 weeks of cardioversion, anticoagulation is a must, because you cannot predict the stunning of the atrium. You see, if the duration of AF was very short, and if also the CHAD-VAS score is very low, you may, in a given situation, probably think of not anticoagulating, but it is not recommended. The recommendation is that once you cardiovert for 4 weeks minimum, continue with anticoagulation, though as much low risk a person you may find, because you cannot predict the stunning of the atrium that might happen. You cannot predict the thromboembolic events that might happen. Historically, 8-10 days after cardioversion, thromboembolism has been known to happen. So a window period of 4 weeks, mandatory anticoagulation. Post 4 weeks, you can, based on the CHAD-VAS score, decide to continue or not continue.
Any contraindication with the associated coronary artery disease to give ibutylide? Because I had in one paroxysmal AF, I had converted with the ibutylide. After that,
Sorry, after that what happened?
I did angioplasty in that case. So any contraindication associated coronary artery disease,
So,
myocardial disease
so,
in
so
the
active coronary ischemia is generally a contraindication for class 1C drugs for sure. For ibutylide, there is no specific reason, but I would say that only in normal hearts it is safe to use ibutylide. All abnormal hearts, it may not be safe to use ibutylide, or you have to be very careful.
Hello, hello, sir.
Yeah, we can do ablation, and I think we have a full session on ablation, so we'll go over it in details.
I have used ibutylide in quite a number of patients with quite a good effect. But in certain patients I've seen after ibutylide, they have developed ventricular tachyarrhythmias. Probably you said about the QT prolongation, probably that was the reason. Any word about propafenone?
So I guess now flecainide is so easily and readily available that our use of propafenone has gone down. Propafenone should work as effectively as flecainide. Literature says that probably a little less effective than flecainide. So I guess you can use propafenone the way you use flecainide, but flecainide would be the first choice and propafenone would be the second choice. I think we are short of time. Last question.
Sir, last question. In a normal heart patient, in critically ill patient, if patient is having AF more than 48 hours, should we cardiovert the patient if he is hemodynamically unstable, or wait for drugs to act?
I think this is a very challenging problem in the critical care setting, and if hemodynamically unstable, you should definitely make an attempt to cardioversion. But the hemodynamic instability in a critical care patient could be for various reasons. It might be septic shock, it might be use of many inotropes and many other comorbidities. So your shock may not be effective. So you need to be very judicious. Whether AF is driving the heart failure or the shock state, then definitely go ahead and cardiovert, but not otherwise.
Thank you, sir.
Sir, when we should stop it, or we should increase the joules, or when we should know that we should stop it? That is also more.
Sorry?
Like the first joules we give it 200 joules, and then suppose we feel that again we should go to 300, or we should stop it.
Yeah, so how many joule shock should be given? I think this is a good question. It's atrial fibrillation probably requires a maximum energy that can be given by the defibrillator. Believe me, the reason is that atria are posterior structures, and when we do our electric cardioversion in a conventional location, the right parasternal and apex, often the energy might not reach in the posterior structures, atria might be dilated. So antero-posterior location of the paddles is more effective but not practically done in most situations. So first shock being effective in atrial fibrillation should be your goal and aim. So use the maximum 200 joule biphasic shock should be your first default shock in atrial fibrillation. And if one does not work, if you have already used adequate sedation, you can attempt a second shock. But if your second shock does not work, either you stop giving further shocks, or what has been recommended now is to use 2 defibrillators, especially in an obese, thick individual. You might have 2 defibrillators, 2 people simultaneously delivering shock. So higher energy shock delivery may be required in some people.
Thank you, Vora sir. I would like to be you on stage, sir. I request chairperson to felicitate Vora sir. And you clearly answered when and how to cardiovert.
For our next talk, we would like to invite Dr. Ajit Bhagwat on stage. He is the Director of Cardiology at Kamal Nayan Bajaj Hospital, Aurangabad, a recipient of various awards and has more than 80 publications to his name. He'll be speaking on DOACs, which, when and for whom.
Good morning, everybody. I'm going to talk about the anticoagulation in patients with atrial fibrillation, particularly with NOACs. I'm going to talk about which NOAC. We have 3 choices and for whom. with special emphasis on people with low CHAD-VASc score, renal insufficiency, high bleeding risk, very elderly, and very high risk of stroke. Now, all of you know this CHAD-VASc classification and score, and everybody must have this hung in their consulting rooms because you have to refer to this chart very often. So you can see the various risk factors which are considered while calculating this risk score. And this is actually on this side is the risk of stroke based on the score. The higher the score, the higher the risk of stroke. Now, unfortunately, patients on anticoagulants, they bleed. And if you really look at the risk factors for bleeding, most of them are also the risk factors for clotting. So people who clot also bleed. So that's kind of a catch-22 here. We have these 4 choices, actually 3 choices, because edoxaban is not available in India. So we have to choose between these 3. Now, meta-analysis shows that as compared to warfarin, NOACs reduce the stroke risk, particularly intracranial bleeds, by a whopping 50%. All-cause mortality reduced by 10%, major bleeds by 14%, and intracranial bleeds by again 50%. The only thing which was consistently seen was the incidence of GI bleed was more with NOACs as compared to warfarin. Unfortunately, there is no head-to-head comparison between NOACs. This is an interesting, this is an important slide where you can see that on the left side you have dabigatran 150 milligrams twice a day, dabigatran 110 milligrams twice a day, rivaroxaban and apixaban. These 4 different trials. Actually, the left 2 columns are from the same relay trial, but 2 doses of dabigatran. You can see that the maximum benefit in terms of stroke reduction amongst all doses of all anticoagulants was seen with dabigatran in 150 milligram twice a day dose, which was a whopping 35%. And also this was stroke plus systemic embolism, and if you take only stroke, it was about minus 24%. All NOACs reduce the risk of intracranial bleeds. And if you really look at the risk of bleeding, the lowest risk of bleeding was with apixaban. Interestingly, if you look at rivaroxaban, the bleeding kind of, in terms of being, instead of being minus, it was plus 4%. But does it mean rivaroxaban increases the risk of bleeding? I don't think so, and I will tell you why. You can see here that all NOACs in phase 3 trials showed that the incidence of GI bleed was slightly more than warfarin. Now here we can compare these 2 trials, RELY and ROCKET-AF, in rivaroxaban versus dabigatran, and I will show you why rivaroxaban is as good as dabigatran, although the figures are a little different. You can see here, if you compare these 2 trials, in RELY trial with dabigatran, the CHAD score was 2.1, and people with CHADs more than 3 were 32%, as against in ROCKET-AF, CHAD's mean score was 3.5, and people with more than 3 CHAD score were 87%. People with heart failure and stroke were 32 and 20 here, while 62 and 55 here. And people who discontinued NOACs were also more common in ROCKET-AF. So in ROCKET-AF, patients were much sicker and were more likely to have events. And that's why this kind of, it's a little bit of difference in the efficacy and increased bleeding, which was seen in patients in ROCKET-AF. And when the results were compared after adjusting the CHAD score, this was published in Circulation, you can see that the bleeding risk with dabigatran 150 and rivaroxaban was approximately the same. Apixaban, of course, took the cake in terms of reducing the bleeding risk. What about low CHAD-VASc score? Now, CHAD-VASc score of 0, you don't have to anticoagulate. CHAD-VASc score of 1 in male and 2 in female, the recommendations are a little different and ambiguous. In terms of AHA, ACC recommendations, either of these 3 approaches is okay. You can have no treatment, aspirin or NOAC, all are reasonable with class 2BC evidence. So with low risk, ACC AHA allows you to do anything that you want. But ESC recommendation for this is little nuanced, and they recommend that you should individualize therapy in terms of, you have to consider obesity, troponins, LA size, EGFR, proteinuria, and if these things are present, you might consider anticoagulation in these patients. Now what happens in real life? Now this was Orbit registry of almost 10,000 patients. I know these were here patients with CHADVAS score of 0, CHADVAS score of 1, CHADVAS score of 2, and these were all people with score of more than 2. And they looked at what is really happening to these patients in real life. And you can see that patients in any group with no antiplatelet or no anticoagulation were hardly less than 10%. So practically every patient, regardless of his CHADVAS score, was on at least one antiplatelet agent or one anticoagulant. So almost 60% patients in CHADVAS 0 received anticoagulation in United States. In CHADVAS 1, you have 70%, here we have 72%. So regardless of what the recommendations are, people end up getting anticoagulation treatment regardless of their CHADVAS score. So this is the real life situation. And what happens to these patients? You can see that the risk of having stroke in these patients was 0% here, 0.8% here, 0.8% with CHADVAS 2, and 1.7% sudden jump when the CHADVAS was more than 2. So actually, when the event rates were compared for anticoagulated as well as non-anticoagulated patients, the risk was no different. And what happens to these patients in terms of their hospitalization? You can see that hospitalization rate was pretty high for every group. So this was not for stroke, but for hospitalization for any other reason. And it just shows you that atrial fibrillation itself is a risk factor. It's a risk factor which identifies people for getting admitted for various reasons. Now here again, rivaroxaban must be given with food. Bioavailability of dabigatran is pH dependent, so it is affected by diseases of the stomach. Dabigatran is 80% cleared by kidney, so it cannot be used in patients with renal insufficiency. So once a day is the advantage of rivaroxaban. If the patient has a nasogastric tube, you have to give rivaroxaban or apixaban because dabigatran will not be absorbed. In patients who had a gastric bypass or gastrectomy, no dabigatran because it will not be absorbed. And with antiretroviral drugs, no 10A inhibitors, you can use dabigatran here. So last couple of slides. What are the recommendations on the use of NOACs? In patients with high risk of stroke, very high risk of stroke, the preferred agent is dabigatran in full dose, while others may be considered. When CHADVAS risk is like 2 or 3, all agents are all right. Patient has high bleeding risk, apixaban or low dose dabigatran. Patients with severe valvular disease and patients with mechanical valve, you should not use NOAC. Mild to moderate heart disease, you may consider it, depending on an individual patient. Atrial fibrillation and hypertrophic cardiomyopathy, when there is this combination, irrespective of CHADVAS score, patient should be anticoagulated. Now, what about renal impairment? With moderate renal impairment, no dabigatran high dose, but you can consider dabigatran in low dose, rivaroxaban, again in low dose, or apixaban. With severe renal impairment, you may consider low dose rivaroxaban or low dose apixaban. When patients are more than 80 years old, you can give low dose dabigatran, rivaroxaban, or low dose apixaban. So in summary, non-valvular AF patients with a score of more than 2 must be anticoagulated. Low CHADVAS score needs individualization according to European Society, and AHA-ACC says do whatever you want. But then despite of these, as I have shown you, most of the patients in real life end up receiving anticoagulation treatment. Bleeding risk is lower with apixaban. Dabigatran is to be avoided in renal insufficiency. and low-dose dabigatran or apixaban is used in very elderly patients. Thank you very much.
Thank you, sir, for this wonderful presentation. I would now request the chairpersons to felicitate Dr. Bhagwat, sir.
Just before this, elderly female by default gets a 3 score.
Sorry?
A female with her age 75 plus by default gets a 2+ score. So how do we go about, what is the controversy?
See, female sex is included in as 1 point in the Chadha score, and that's because their prognosis is worse than males. So, a female, when you consider low, your question is why?
Do we really anticoagulate them? Because anybody with 75-year-old female gets a 2 score on Chadvas.
Yeah, so any non-sex risk factor is an additional risk factor. So a female who is 75 plus becomes 2. So 2 is high risk. So an elderly female is worse off than an elderly male, because then he's just 1 risk factor.
Yes.
So the female with 1 more non-risk factor is always at a higher risk. Well, actually, there is no specific recommendation for liver because most of these agents are cleared by the kidney. But in terms of there is a recommendation in that in severe hepatic failures, one should not use NOACs. No NOACs should be used in patients with very, very significant liver disease. But in moderate liver disease, again, you can use it, but with caution.
Thank you, sir. For the want of time, we would like to move to the next session. We would request the chairpersons to felicitate Dr. Bhagwat, sir.
Yeah, post-angioplasty is a different scenario. I didn't include it because it's a different topic by itself. But if you have a post-angioplasty patient with atrial fibrillation, the recommendation is if it's done in acute coronary syndrome situation, you have to use dual antiplatelet for at least along with anticoagulant for first 1 month. Then depending on the bleeding risk, you have to decide about 1 antiplatelet and 1 anticoagulant for next 6 months to a year. And after a year, the patient continues to be only on 1 anticoagulation.
Can we have a round of applause from the audience?
For the next topic on rate versus rhythm control, I request on stage Professor Dr. Muralidharan sir, HOD and Director of Cath Lab at Sri Ramchandra Institute, Chennai.
Good morning. At the outset, thank you, Dr. Gurunath and IC. It's a great morning, and I'm going to cover on this important topic, that too in 10 minutes. Maybe a very huge one, but I'm going to do it within 10 minutes because the advantage is I have 2 great players after me, Professor Narasimhan sir and Sam, the doyens in AFib. So we are going to have a lively AFib session. Maybe I'll do the introductory work. Objectives of the talk going to be rate control strategies, rhythm control strategies, and what is the evidence, what do we understand. We know the impact of atrial fibrillation, more so in our country also, lifetime risk, its effect on the morbidity, mortality, and it's a growing problem globally, more so in India also. Coming to rate control, so when you have a person with atrial fibrillation, sometimes we resort to maintain or allow the atrial fibrillation to continue just to control the ventricular response. That's what we call as rate control. To understand the type of patient we consider, one is like a background therapy in all AFib patients, whether you cardiovert or revert, because we know it can come anytime. First choice in asymptomatic patients, they are totally asymptomatic. And when the rhythm control strategy fail, or patient would not have a heart failure, or patient elderly people, very elderly people, persistent atrial fibrillation, sometimes we resort to that. And of course, patient preference, both the things. What do we mean by rate control? Uncontrolled atrial fibrillation. What you do is you give drugs to suppress the AV node conduction to maintain a heart rate little lesser. At one stage, we are thinking up to 80 was the ideal thing. With the raise to, we know now today, we can maintain a lenient heart rate of 110 in the daytime. That is the aim of rate control today. No need to be very strict, but assess the response during exercise. That is very important. Where the rate should not go very high or go uncontrolled during exercise. And very important when we optimize, many of our patients on pacemaker, like particularly biventricular pacemaker, you need to achieve good biventricular pacing. So rate control, you have to show some extra interest in this patient to assess them by proper programming. Moving to that options, what do we have by rate control? You do it by AV node blocking drugs. The commonest drug being used are calcium channel blockers, typically verapamil or diltiazem. Beta blockers, of course. I do use a lot of non-selective like propanol, but there is a role for selective beta blocker also. Digoxin being used infrequently nowadays, except in patients with associated heart failure. Antiarrhythmics to be avoided mostly. To control rate alone, using drugs like sotalol or amiodarone should be discouraged unless you have no other option. There are, of course, non-pharmacological methods like surgical methods wherein you do an AV node ablation by catheter-based ablation and putting a pacemaker in refractory or resistant cases. Coming back to rhythm control, I want to get back the rhythm. I want to maintain the patient in sinus rhythm. Then you look for the type of patient we look for is patients who have heart failure, first of all. Paroxysmal atrial fibrillation or younger people who are symptomatic, newly detected atrial fibrillation, and of course patient prefers. How do we do it? Again, using antiarrhythmics, as Dr. Amitvara rightly pointed out, drugs like flecainide, propofol are being used. Remember to give nodal blockade, not to give the drug alone because they can increase the AV node conduction. So, nodal blockade with beta blockers are usually recommended. Drugs like sotalol, dofetilide, amiodarone, dronedarone, across the globe. In India, we have amiodarone. Usually, we do use sotalol in some patients. And non-pharmacological, of course, Narasimhan sir is there going to talk about it. Out to cardiovascular, we have discussed, ablation, and rarely surgical, like MACE procedures are being done. What are the evidence? Which one to choose? Why we resorted this? We'll spend few minutes on that. First thing is 2002 trial, AFFIRM. What they did, 4,060 patients were followed up for 5 years. It is in 2002. That means the study was done starting somewhere 97, 98, where ablation was not the mainstay of therapy in atrial fibrillation, rather drugs. Some other drugs are not being not even being used today in practice. The main drugs they were using was amiodarone, that group sotalol, rate versus rhythm control, and there was quite a lenient anticoagulation approach also at that time. But going to the results, they found no difference, no big difference between rhythm and rate control. So that opened a new avenue or new thinking that let the patient continue to atrial fibrillation, we anticoagulate them, not to get back the P wave in front of QRS. That was thinking going on from 2002, which was being the practice was nearly now the last 2 decades. But interestingly, when you go into the details, patients who have sinus rhythm in AFFIRM subgroup itself, they did better. But if the sinus rhythm was due to a drug, they didn't do well. That indirectly means having a sinus rhythm is always superior. But the way we try to achieve is fraught with its own drawbacks, like side effects of antiarrhythmic drugs and not properly optimized anticoagulation also. But coming back to the same game, after AFFIRM trial, meta-analysis in 2012, again rate control was preferred. Even as recent as 2017, meta-analysis, but most of the meta-analysis, the weight of evidence is primarily from these 2 trials only, AFFIRM and AFCHF only. All others are minor contribution for the meta-analysis, but what they said, rate control is preferred or rate control is sometimes superior to rhythm control. But over time, like in papers like this in 2005, where when they looked at the efficacy of the antiarrhythmic that we used, like amiodarone or sotalol, we saw already they don't do well, and even when used, by the end of 3 years, the efficacy drops down to 50%. So the drug we think is working is not working all the time. We need to look at other avenues, other ways to control it. At this point, I like to bring the attention, there are so many other factors coming into play. Reversible risk factors, non-reversible risk factors, things like obesity, sleep apnea, all these factors are going to influence. So it is not giving drug bring back the rhythm, rather see the patient as a whole, look at the comorbids, how to make it optimal, because for example, a simple treatment of sleep apnea brings down the AF recurrence significantly. Simple weight reduction gives a result as good as a ablation. What it indirectly means is, don't look at how to make the rhythm to come back by just giving drug. Rather, look at the patient as a whole and correct all the comorbids. To add to evidence, lot of trials came in. This is not truly a rhythm control trial, but Cabana trial is one thing, looking at ablation versus antiarrhythmic drug, 2,200 patients. Lot of them are in paroxysmal AFib, 5 years follow-up. What they said is equal. But the sub-analysis said in people with a heart failure, other group, they did very rhythm control is better. But what Cabana trial mainly said was, ablation is safer. Achieving rhythm control is possible with the right way of treatment. And like other smaller trial like Castle AF, look at atrial fibrillation with a patient with LV dysfunction, rhythm control is superior. And other things like when you are doing it. Most important point, how early you do it from the onset, like arrhythmia-free survival or hospitalization. If you bring in the treatment, if you bring the rhythm early after the onset of atrial fibrillation, the results are superior. Indirectly, it means a chronic AFib. You allow them to persist for longer time, they don't do well. Early reversion or early control is always preferable. That was amplified by a great paper came in 2020, where AFNET4 trial results, 2,789 patients who are enrolled within 12 months of AF diagnosis. In fact, in reality, within 36 days, that's the median days, they were looked at the results, how ablation and antiarrhythmic versus usual care, there was a significant lower composite rate in this group with early rhythm control. So this opened again a new story, like we were looking at rate control, we are started realizing if you achieve properly the rhythm control, you hit the patient very early, bring back the rhythm, you do well. So today, to summarize, I think for rate control, we know, select the right patient, achieve for 110. If you are not able to achieve, try other means. There are many other means, but evaluate the patient carefully while they are doing exercise. And coming to the catheter ablation, today catheter ablation is preferred as the first choice in patients with heart failure. Paroxysmal, persistent heart AFib with heart failure, catheter ablation could be a class 1 indication. And patients who have failed drug therapy in paroxysmal AFib without heart failure also can be a class 1 indication. In other groups, in paroxysmal AFib itself, slowly is emerging like catheter ablation can be a 2A indication and others is 2B. Indirectly, it means younger patients, heart failure, paroxysmal, think of atrial fibrillation. I would like to thank Dr. Sam Asirvadam. This slide was given to me several years ago, how the atrial fibrillation changes the heart, particularly atria. A paroxysmal atrial fibrillation, where the triggers play a major role over time. AFB gets AF sets in, atrial myopathy sets in. So the very same paroxysmal AFib progress to permanent atrial fibrillation. So early intervention going to halt the disease at paroxysmal level rather than progressing to persistent permanent. That is what we understand over 2 decades, and a lot of studies have emphasized it. So to conclude, rhythm is better than rate, definitely. But the rhythm control methods are fraught with their own drawbacks. You have to plan that carefully. So the rhythm control methods should be properly planned in the patient, and holistic approach is essential, not to treat the rhythm alone, but treat the patient as a whole, and preferable, I prefer to have P-wave in front of QRS. Thank you.
Thank you. Thank you, Muralidharan sir, for the great insight. I would like to call the chairperson to felicitate Muralidharan sir.
Followed by rate control or vice versa, and sometimes you have to combine a rhythm control and a rate control drug. Many times we combine cordron beta blocker. Just a comment on this thing.
So let us think of a scenario. I have a patient with minimal risk factors, atrial fibrillation. I know it is symptomatic, but I want to maintain the rhythm. I am going to give him drug like amiodarone. At the same time, I would like to keep a rate control also, because there can be episodes where we would like to have the ventricular response optimal. But if your aim is not to bring back the rhythm or not to maintain the sinus rhythm, in that group, I may say, let us try to avoid amiodarone as much as possible, try to maintain on calcium blocker or beta blocker.
Can we have a round of applause from the audience? For our next talk, we would like to invite on stage Dr. Kalyambur Narasimhan, who is the head of electrophysiology department at AIG Hospital, Hyderabad.
Good morning, chairpersons, ladies and gentlemen. I'd like to thank the organizers for the kind invitation. I've been tasked to speak about catheter ablation of atrial fibrillation. Over the next couple of minutes, we should emphasize that the importance of atrial fibrillation as it affects significantly the quality of life, increases the cost of medical care, increases the risk of sudden death, and overall mortality and heart failure and stroke. So it's not a small disease. I'm glad Dr. Muralidharan did mention that even in affirmed trial, that when a person maintained sinus rhythm, their survival was better. Most of the strokes occurred when the patient was in atrial fibrillation, and seldom when it occurred in sinus rhythm. So maintenance of sinus rhythm is good, but we have problems there. And our understanding of atrial fibrillation has improved because not only we use drugs, we have also understood that controlling the risk factors is extremely important to prevent the progression of disease in terms of prevention of sleep apnea and weight loss and other risk factors like hypertension and diabetes. And this was again amply exemplified that earlier the rhythm control, the better it is, and there is an increasing benefit of catheter ablation among patients with heart failure. The first understanding of this, we owe this to the work from France, Michel Hassagre group, which showed that the most of the triggers for atrial fibrillation came from the pulmonary veins, and if you can electrically isolate them, you can achieve sinus rhythm, and this is how we used to do for several years. We used to map the left atrium and do a point-by-point ablation around the ostium of the pulmonary veins to restore sinus rhythm. But over the last decade, there have been a lot of one-shot devices like cryoballoons which were deployed within the pulmonary veins, which tends to freeze the ostium of the pulmonary vein and achieve electrical isolation. And another emerging technology called pulse field ablation, which is able to achieve the same results by one-shot procedures, simplifying the catheter ablation. So in short, we obtain access with ultrasound to minimize all complications, and after this is done, we always obtain esophageal temperature monitoring throughout the procedure because esophagus is just adjacent to the pulmonary veins. And roughly this is what it is done. We inflate the balloon near the ostium of the pulmonary vein, get an occlusion by making sure that you occlude the ostium of the pulmonary vein, and one by one, right, left upper, left lower, we isolate one by one. And as the culprit vein is isolated, we may get lucky, the atrial fibrillation terminates and sinus rhythm gets restored. This is effective in approximately about 70 to 80% of the patients in paroxysmal atrial fibrillation. We continue to have approximately 20% of these patients who continue to have recurrences. So considering all these things, especially among patients with paroxysmal atrial fibrillation, catheter ablation can be offered as a first-line therapy when the drug therapy fails, and this comes as a class 2A indication. Among persons with persistent atrial fibrillation without major risk factors, this can be an alternative for antiarrhythmic therapy. This is important to say that when we escalate antiarrhythmic therapy, we may be able to achieve sinus rhythm. Say today it's 100 amiodarone, and 2 months later we increase it to 200, so on and so forth, but it comes at a price. As we escalate these drugs, the complications do increase, and at that stage, it's prudent to consider more definitive therapy. And among patients who have failed antiarrhythmic therapy, especially with paroxysmal atrial fibrillation without risk factors, it's emerging as a class 1 indication based on the current level of evidence. Catheter ablation is also emerging as a form of therapy when you have chronic or persistent atrial fibrillation and heart failure. Heart failure increases the risk of atrial fibrillation, and atrial fibrillation increases the risk of heart failure. So it's kind of a bidirectional relationship, and there's data to suggest that if you achieve sinus rhythm and maintain sinus rhythm, you can reverse the LV remodeling over a period of time, and this translates into reduction in morbidity and mortality. And this should be considered for patients with heart failure with reduced ejection fraction, not only to improve survival, but reduce recurrent hospitalization due to heart failure. So in summary, patients with paroxysmal atrial fibrillation who continue to be symptomatic despite antiarrhythmic therapy or who have side effects to antiarrhythmic therapy, we can consider catheter ablation of atrial fibrillation. Among persons with persistent atrial fibrillation who fail drug therapy, we can consider them for RF ablation. If a patient goes for concomitant surgery, like a valve surgery, or a patient who goes for bypass surgery and he has chronic atrial fibrillation, you can ask the surgeon to do concomitant maze procedure if he is comfortable doing it during the course of the surgery. The second thing I was asked to talk about is about left atrial appendage occlusion. Left atrial appendage occlusion is with the premise that it reduces the ischemic stroke and reduces the bleeding events. Now, for a rare event, I'm sure all of you saw the slide that Dr. Ajit Bhagwat put up. The annual risk in patients with even class 2 and class 3 is 2%. So to show a benefit, you need to randomize thousands of patients to show a benefit, because it's a rare event. I can put in a left atrial appendage and close, but I need to wait for several years to show the benefit. So if you look at the main problem with these trials, the patients who were randomized to appendage occlusion were far less compared to drug therapy, and most of the trials were non-inferiority trials. And that kind of casts a doubt on the usefulness of this. Rates of major bleeding in the Watchman and warfarin arms, if you continue them long enough, they almost become equal. And it has never been compared with the safer DOACs like apixaban. If you take apixaban, Averroes trials has shown that the risk of bleeding with apixaban is identical to aspirin. So if you put a Watchman or any device in left atrial appendage, you are forced to give aspirin or clopidogrel, and it's the same risk. So that is where we stand in terms of appendage occlusion. And the appendage anatomy is highly variable, and the device-related thrombus, which forms a nidus along the crevices of the appendages, forms a nidus for thrombus, and this is not a small number. It occurs in a fairly significant percentage of patients, and if you follow them long enough, you will have problems with embolization. And in the setting, there are newer and safer drugs which are coming up, like 11A inhibitors, which reduce the risk of bleeding significantly and also offer protection against stroke. So that is the background we have for LA appendage occlusion. I think we still have data, or better devices have to come in to prove the practicing clinicians that it's a superior form of a device. I'll stop here and take any questions if there are any. Thank you very much.
Although conventional radiofrequency ablation and the cryoablation, is there any advantage in cryoablation, superiority of cryoablation over the...
They are very identical in terms of results, but the learning curve for catheter ablation, point by point ablation, is a little longer compared to cryoablation. So you need to do many more cases to have a sufficient degree of proficiency to do the point by point ablation. Whereas cryoablation is a little more forgiving. After about 10 cases you are on your own, you should be able to do on your own.
What is the overall success rate of the ablation overall?
So if roughly about 75 to 80% if you have done everything right.
Sustainable it is actually going on.
Sustain.
Sustain 70%.
Yes.
Recurrence is 30%.
Yes.
And the newly actually these GLP-1 analog drugs have shown a lot of benefit in atrial fibrillation reversal by weight reduction itself just actually.
That's right.
So 2 trials have come actually now, Socrates and
So there are several things, I didn't address this. High dose vitamin D is useful, colchicine useful, GLP-1, but patients with SGL2 have been beneficial. So we are looking at several agents to limit the weight loss and address the metabolic factors. One of them is GLP-1 analogs.
colchicine one by anti-inflammatory method actually.
Yes. Then thank you very much.
Thank you, sir. We request the chairpersons to felicitate Dr. Narasimhan, sir.
For the next topic, we have on stage Professor Dr. Samuel Asirvatham, great minds in cardiology, world-renowned cardiologist and consultant at Mayo Clinic, Minnesota.
Can get the slide up there. Okay. So atrial fibrillation, I think you've kind of gathered from the last few talks, is an unsolved problem. So whenever there is an unsolved problem, there's always many things new. And I could easily do the entire symposium on what are the new aspects of understanding and treating atrial fibrillation. 10 minutes, I want to focus on 2 that you will or have already heard quite a bit about in our field. First has to do with one of the reasons why atrial fibrillation is unsolved. It's actually not one disease. It's a symptom, it is also a disease, it's also multiple diseases. There's one disease that takes you from sinus rhythm to atrial fibrillation, another disease that keeps you in atrial fibrillation, another disease that prevents just the routine coming back to sinus rhythm. At least we know persistent atrial fibrillation has got strong structural components in the atrium. Paroxysmal atrial fibrillation, mostly the atrium, especially in the early stages, is normal. And as you heard, our main target for ablation has to do with this now very well established idea that pulmonary vein that interface with the atrium is important for the starting of atrial fibrillation. This ostium within the pulmonary vein triggering and starting the atrial fibrillation. But you also saw from Narasimhan's talk that we are not ablating in the pulmonary vein. And this is one of the reasons why we have limited success. Even though I agree with Dr. Narasimhan, 70, 80%, it is short term. When we look longer and longer and longer, patients do get more and more and more recurrences. We are ablating away from where the actual problem is. It's just like if one tiger is walking around this room, we are saying, I don't want to shoot the tiger, I will just put a cage and I will go about my daily business. We still have to fear that tiger will break from the cage. Why don't we ablate inside the pulmonary vein? The main reason is because the pulmonary vein will stenose. Just like arterial stenosis, it will close, it will narrow, very difficult to open and keep it open even when we stent a stenosed vein. That creates a great fear with ablation. Second thing, all on our mind, anybody who touches catheter and does AFib ablation, we fear this lesion, esophageal trauma. It's fatal if not surgically treated once it occurs. And subconsciously, we limit our ablation in certain areas, sometimes consciously, because of this fear that the heat or the cooling will go and damage this esophagus. Further fear is a lot of patients, maybe even 15% of patients, after we do a catheter ablation, if you do diffusion weighted MRI, you will see these small lesions. Many times patients are asymptomatic, but I am sure nobody in this room wants to have the knowledge that there is some small lesions inside your brain, how much ever you may be asymptomatic. So as a result, one of the things that is new is technology for ablation. How this evolved is the understanding that the big problems with ablation have to do with heat or cooling, thermal injury. That heating can coagulate the blood. The heat transfer is difficult to predict. Heat and cooling are thermodynamic variables difficult to control. So the idea became, can you do some ablation and don't cool, don't heat the tissue. Don't cool, don't heat. But can you still ablate? And that's what Narasimhan showed you briefly, is pulsing the electrical field. It's also called electroporation, especially outside the cardiac space. But it is no heating, no cooling, no temperature change. Just the electrical field is pulsed, and this causes some membrane changes that lead to apoptosis and subsequent ablation of this tissue. So it is a non-thermal method of ablation. And this, for the first time, allows us, although present catheters don't do this with electroporation, it does allow for ablating inside the pulmonary vein. No heat, probably no stenosis. Animal data, this is some of our own work, that shows the architecture of the vein. Even though the muscle is ablated, the architecture of the vein is restored. It stays the same, making it very unlikely we will have to worry about stenosis now in patient trials. The second is many of the fellows, many of the residents, many of the practitioners may have a question. Narasimhan, Amit, Murali all said pulmonary vein is making atrial fibrillation. Maybe the question in your mind will be, what is making the pulmonary vein to make the atrium to fibrillate? And that remains to some extent a mystery, but if we put electrodes in multiple sites, somewhere in the body, there is abnormal electrical activity before the pulmonary vein abnormal electrical activity. And that somewhere is in the autonomic nervous system, at various stages in the autonomic nervous system. So in some extent, atrial fibrillation is like an autonomic epilepsy that eventually leads to downstream atrial fibrillation in its triggered form. So as a result, one of the things that is new as a thought is, can we modulate the autonomics to treat atrial fibrillation? The ultimate is cardiac transplantation. And in fact, it is very difficult to put a transplanted heart into atrial fibrillation, especially for the first 5 years. There was even a surgeon in St. Petersburg, Russia, who did auto-transplantation for treatment of atrial fibrillation. Pulled out the heart and put it back inside, and atrial fibrillation went away. No patient is going to agree to this anywhere outside St. Petersburg. But the idea became, maybe we can do with the catheter. But the difficulty with doing with the catheter is, it is a quagmire. These autonomic nerves are not one nerve, two nerves, three nerves. It's like a grid, it's like a network. But the network has a focal point. To reach the heart, it has to come from behind in the gap of the pericardial space. That's the only way it can reach the heart. So this gap gives rise to relay stations behind the atria called retroatrial ganglionated plexuses. So one of the exciting areas new in atrial fibrillation for ablation is not ablating the cardiac tissue, but trying to target these relay stations. This is also in clinical trials now in a pivotal study looking at specific catheters. They are shielded on one side. I think the catheter ablated more than this ganglia today. So I was finishing up, but the idea is to shield the catheter so esophagus is protected. And if esophagus is protected, the energy is only delivered towards these ganglia. If the energy is towards the ganglia, we are effectively getting like a denervated heart, deganglionated heart, and to see if that helps with recurrence of atrial fibrillation. So, although there is much that is new, we have to accept present treatment has limitation. Always starts like that. Our conversation with patients amongst each other has to have that acceptance, and we have to see our best bet. Some are drug approaches, some are lifestyle approaches, some are unique approaches in the ablation space itself. Non-thermal is a big one. The other one is modulating the autonomic nervous system. I'll stop there. Thank you very much for your attention.
Thank you. Thank you, Samil sir. Are there any questions?
Yes, sir. What is the? Yes. So the complications or side effects for cardiac denervation. So first thing is you have to make sure you don't get collateral damage during the ablation. And that is a big part of the design of the catheters. Assuming that doesn't happen, sinus rates go up. So typically goes up somewhere between 6 to 10% after you do the ablation. Like in post-transplant,
Yes, sir.
sinus rates will be little higher. So is it a good thing, bad thing? Don't know, but it is little higher. So don't know long term whether that will be an issue. Sometimes when you denervate the heart, blood pressure can also go down.
Good.
It's very little effect. It's not like with the renal denervation, 5-6%. Since many of these patients are prone to hypertension or have hypertension, is probably okay. But if you had a hypotensive patient to begin with, it could be an issue. Another, which is still somewhat investigational, is it appears that there is some speeding up of AV nodal conduction. So AV node conduction goes up a little bit. So older people is okay, but you worry if there is recurrence, maybe rate control will be little higher. But generally not bad. Yes, Ashish.
If is doesn't happen in the transplanted hearts in first 5 years. Did you mean as a corollary after that they are noted or something?
It's about 7 years is the data, but after 7 years you can definitely induce AFib and you definitely do see AFib. And the thought is it is renervation. This is about the same time the transplanted heart rate will start going down. So probably it is reinnervation. But theoretically, deganglionation should not reinnervate. Ganglia are not known to regenerate as present understanding. So it is one of the reasons they are targeted rather than the nerves.
Right. Just to push that further, you again said AF can be induced, but do you also mean clinical AF is seen?
Clinical AF has also been seen, but not that much because they are young hearts to begin with. But it's definitely seen. Flutter, of course, definitely occurs in post-transplant hearts. It's actually little common, and that has to do with the transplant technique, how much of cuff is left behind, time of transport of the heart, and so on.
Okay, thanks.
Any more questions? I request Dr. Parare sir to felicitate Dr. Samuel sir. Please give a round of applause. I hand over my mic to for the next session and inauguration to Rizwan sir and Tapriya sir. Thank you.
It is going to take some time for the quiz questions to be uploaded, so we are preponing the inauguration ceremony immediately.
Good afternoon, dear friends. Now we are proceeding with the inauguration ceremony for the ISEOCN 2023. I request all the delegates and guests to be seated for the next important session, that is the inauguration ceremony. Good afternoon and a warm welcome to the inaugural ceremony of the ECG conference ISEOCN 2023 at Solapur. Today we all gather here to mark the beginning of the enlightening and transformative journey in the realm of healthcare. As we come together to light this ceremonial lamp, let us symbolize the illumination of knowledge, compassion and collaboration. First and foremost, I would like to express my heartfelt gratitude to each and every one of you for joining us. Your presence here signifies your unwavering commitment to the advancement in medical science and improving patient care. The field of healthcare is relentless pursuit, and it is a dedication of physicians like yourself that propels us forward. This ECG conference stands as a testament for our collective pursuit of excellence in cardiology. It serves as a platform for sharing groundbreaking research, innovative techniques, and best practices in the field of electrocardiography. The conference aims to foster a spirit of collaboration and exchange among physicians from all the corners of the globe, enabling us to develop a deeper understanding of cardiovascular health and devise effective treatment strategies. The lighting of lamps symbolizes the illumination of knowledge and wisdom. It represents the eternal flame of curiosity that burns within each of us, driving us to explore the unknown and push the boundaries of medical science. As we kindle this flame, let us invoke the spirit of innovation and discovery that guide us throughout the conference and beyond. Furthermore, the lighting of the lamp signifies the vital role of compassion in medicine. It serves as a reminder that behind every case study, every ECG trace, and every medical breakthrough, there lies a human being, a patient in need of care and empathy. As physicians, we carry the responsibility not only to diagnose and treat, but also to offer solace and support to those who entrust us with their well-being. I extend my warm wishes to all the participants, presenters, organizers of this conference. May the coming days be filled with insightful discussions, transformative discoveries, and lasting connections. Together, let us light the path of healthier and brighter future for all. Thank you. The ECG conference for all of the physicians and cardiologists.
थैंक यू डॉक्टर रिजवान. अतिथि देवो भव कहती है भारत की धरा, स्वागत करके आपका निभा रहे हैं परंपरा. इस अवसर पर उपस्थित मान्यवर मित्रों, और आमंत्रित प्रतिनिधियों को, संयोजकों का सादर प्रणाम। हम नतमस्तक हो सिद्ध रामेश्वर की इस नगरी में आपका सहर्ष और सहृदय स्वागत करते हैं। कुछ ही क्षणों में दीप प्रज्वलन का कार्यक्रम होगा, इसलिए सभी से अनुरोध है कि आप स्थानबद्ध हो जाएं। सर्वप्रथम मैं आदरणीय डॉक्टर परले सर, जो कि इस कॉन्फ्रेंस के पेस मेकर वीकेंड से विनम्र निवेदन करता हूं कि आप आज के प्रमुख अतिथि डॉक्टर सैमुअल आशीर्वाथम सर के साथ मंच पर विराजमान हों। पश्चात मैं डॉक्टर सिंगल सर, जॉइंट ऑर्गेनाइजिंग सेक्रेटरी ISEOCN 2023, डॉक्टर सुभाष देशमुख सर, अधिष्ठाता VM मेडिकल कॉलेज सोलापुर, डॉक्टर SB गुप्ता सर, एडवाइज़र इंडियन सोसाइटी ऑफ इलेक्ट्रोकार्डियोलॉजी, डॉक्टर आशीष नाभर सर, ट्रेजरर इंडियन सोसाइटी ऑफ इलेक्ट्रोकार्डियोलॉजी, डॉक्टर केतन मेहता सर, सेक्रेटरी इंडियन सोसाइटी ऑफ इलेक्ट्रोकार्डियोलॉजी, डॉक्टर C नरसिम्हन सर, HOD इलेक्ट्रोफिजियोलॉजी डिपार्टमेंट AIG हैदराबाद, डॉक्टर जगदीश हिरेमठ सर, HOD कार्डियोलॉजी डिपार्टमेंट रूबी हॉस्पिटल पुणे, डॉक्टर CK पोंदे सर, HOD कार्डियोलॉजी डिपार्टमेंट हिंदुजा हॉस्पिटल मुंबई, और डॉक्टर अमित वोरा सर, चीफ इलेक्ट्रोफिजियोलॉजिस्ट लीलावती एंड रिलायंस हॉस्पिटल मुंबई। इन सभी प्रतिष्ठित मान्यवरों से मंच पर पधारने का आदरपूर्वक अनुग्रह करता हूँ। डॉक्टर सुधीर देशमुख सर, डॉक्टर परले सर से विनती करता हूं कि अपना मनोगत व्यक्त करें।
Good morning. I am overwhelmed. I am overwhelmed because the luminary, a towering figure in electrophysiology in the world, a great academician, a master teacher, has traveled half the globe just to attend a conference in a small town like Solapur. He had so many problems during the travel that his connecting flight to Hyderabad was missed. He himself arranged a next flight, was stranded at the Doha airport for 6 hours and landed in Mumbai at early morning 4 o'clock with no sleep, took 9 hours road journey to Solapur. And when I asked him, apologizing to him, he said, I want to draw diagrams for the arrhythmia symposium. What should I do? So that's the commitment. That's the commitment. I bow before you, sir. Let's give him a standing ovation. I am overwhelmed. I am overwhelmed because all the big names in cardiology and virtually who's who in electrophysiology in the country have taken a day out from already their stressed schedule. I know it is very difficult for them to come out on a weekend, but they have, on my request, They have come out and come to this place which doesn't have an air facility and have taught us so much. So let's give a big hand to them. I am overwhelmed because you all participants, all delegates, the organizing committee which stood behind me, and we have shown that Solapur can do it. Solapur can do it. Thank you. Thank you.
धन्यवाद सर। हम दीप प्रज्वलन की ओर अग्रसर होते हैं। माँ सरस्वती का स्मरण और चरणों में प्रार्थना कर गणेश वंदना के साथ दीप प्रज्वलित होगा। मंच पर विराजमान सभी मान्यवरों से विनम्र निवेदन करता हूँ कि आप सभी मिलकर ज्ञान यज्ञ का उद्घाटन करें।
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि।
सभी मान्यवर कृपया पुनः आसनस्थ हो जाएं। अति विशिष्ट व्यक्तियों का सम्मान भी अति विशिष्ट होता है। आज के हमारे प्रमुख मेहमान डॉक्टर सैमुअल आशीर्वाथम सर को पल्ले सर खास मेमेंटो देकर गौरवान्वित करेंगे। जोरदार तालियों के साथ अभिवादन करें। डॉक्टर सुधीर देशमुख सर, डॉक्टर एस.बी. गुप्ता सर, Dr. Jagdish Hiremat sir, Dr. C.V. Narasimhan sir और Dr. आशीष नाभर सर। डॉक्टर रुद्राक्षी सर हमारे संयोजकों का सम्मान करें। जिनकी कड़ी मेहनत और लगन से इस कॉन्फ्रेंस को ये आज दिन हुआ है, शुभ दिन, इनके लिए जोरदार तालियां। इसी के साथ ये उद्घाटन कार्य संपन्न हुआ। आप सभी का धन्यवाद। I request all dignitaries to take their seats downstage. Dr. Samuel Asirwathan sir to talk a few words about the conference, followed by his talk on PQRST in heart failure. And over to you, Dr. Rizwan.
So, first of all, thank you very much. Very nice comments. I have to say, what is remarkable is to see cardiology and rhythm management, ECG diagnosis in India at a stage where it is today is incredibly heartwarming. It is really something. Yesterday, Narasimhan and I were judging, and I didn't know who the presenters were, and I assumed they will be electrophysiologists, but they were actually medical residents having wonderful, basic but wonderful grasp of rhythm, diagnosis, pacing techniques, interaction with pacing. It's a reflection of the talent, the reflection of the hard work, and it's the reflection of the hard work of a generation of cardiologists and electrophysiologists who have stayed and worked and overcome the challenges in India, not only to give great care to patients, but despite all the limitations, just set the ground for a new generation to excel and be on par or better than anybody in the world. It is a testament to a sincere effort across a generation. Many of you are doing it, but I have seen firsthand Narasimhan, Yash, Amit, over the years, keeping to do this has really created a wonderful atmosphere, much more difficult to do than someone climbing the academic ranks in the United States. Now, for the symposia, there's kind of two. One is focus on heart failure, and second one is just concepts for rhythm management, ECGs, basics. So the first symposium, heart failure, is mostly what are the electrophysiological issues? Is ECG important in heart failure? Is rhythm management important in heart failure? Device management in heart failure? That will be the focus. The Arrhythmia Symposium really is 1.5 hours, lot of time for questions. Main requests were to have little bit detail on SVT diagnosis and wide complex tachycardia diagnosis. So basics, but we will spend time, go through those and look for some answers. So I'll start with the first presentation, ECG, just ECG in heart failure, few concepts for general cardiologists internists and students. There are a lot of issues and things you can learn from the ECG in heart failure. You can get some ideas about treatment, toxicity, even cause of the heart failure from the ECG. I want to cover 3 or 4 issues. Most common ECG manifestation of a diseased heart is left bundle branch block. Now, left bundle branch block, you heard very nice talk yesterday. One of the teaching points was usually with left bundle branch block, we see the axis is little leftward. It is not because of the left bundle branch block. It's because of the heart. If you just cut somebody's left bundle, you will get a left bundle branch block pattern. We are all familiar. QRS is wide, left bundle like pattern, but the axis will be normal. Left anterior fascicular block, you'll get left axis deviation. Left posterior fascicular block, you'll get right axis deviation. Whole left bundle axis should be normal. But many times you will see some left axis change. This suggests it's not the bundle, it's the heart that has given rise to this bundle branch block. This is a sign of left ventricular enlargement and left ventricular dysfunction. So axis along with left bundle gives you an idea, are you dealing with electrical or mechanical problem? It is usually a mechanical problem. In addition to that, yesterday we talked about golden rule of ECG, the vector, the primary vector. When wavefront comes towards an electrode, you get positive. Moves away, you get negative. But sometimes this wavefront changes direction. It's moving away, comes back, moves away again. It's like a car going and then stops and then has to turn and come again. Why? Because there is an obstacle. These obstacles are areas of fibrosis or poor conductivity, diseased myocardium. So another ECG feature of diseased myocardium is secondary vectors. That means notches, glitches, little turns in the wavefront. When we look at these notches and glitches, we can get an idea about where is the disease. This is left bundle branch block. That means right ventricle is activated first. Notice in AVR, we move away from the right. So right ventricular activation, septal activation, then left ventricular activation, moving towards the right later. The glitch is just before left ventricular activation, suggesting septal scar. So not only it is possible to get an idea from the ECG that there is scar, there is some disease, just with some basic reasoning, you can also get an idea about how many, where, how diseased is the heart beyond just the left bundle branch block and the width of the QRS. Notice the lateral low apical leads, they are positive. This is what you will expect in left bundle branch block. Because these leads are way in the apex, left bundle branch block, right is activated, so big vector towards V6. So just left bundle branch block, V6 should be good, positive. But if it is not, and you actually see notches, that suggests the muscle en route to the apex is abnormal. It is less, that is why you are not seeing the R wave. It is diseased, that's why you are seeing the notch. So looking at the ECG gives you a flavor. It doesn't take the place of MRI, but it gives you an idea what to anticipate even before you are looking at detailed imaging. Beyond the QRS, we also have to think about conduction abnormality. You will easily recognize that there is right bundle branch block with some conducted beats, then a left bundle-like pattern with some conducted beats, normalish pattern with some other conducted beats. Conduction abnormalities are a sequelae of mechanical abnormalities in most diseased hearts. The more disease the muscle has, the more you get conduction abnormalities. But if early in the course of the disease, you see a lot of conduction abnormalities, this gives you a clue to etiology. I mainly think about three conditions. If in an acute myocarditis-like picture, ventricular dysfunction, acute, hyperacute, and severe conduction abnormalities, right bundle, left bundle, fascicle block, think about giant cell carditis, giant cell myocarditis. Hyperacute presentation, emergent therapy is needed to save the heart, immunosuppressive therapy. If it is subacute, happening over time, one day one bundle, one day another, then think about sarcoidosis or think about some laminopathies. Conduction tissue is affected relatively early. If it is alternating but relatively stable over years, right bundle, left bundle, and there is a family history of cardiomyopathy, especially a maternally inherited pattern, think about myocardial myopathies like Kern-Sayre syndrome. So conduction abnormalities along with time course gives us some idea. PVCs, heart block, always think sarcoidosis. Tachycardia ECG in heart failure. A stable white complex tachycardia, is coronary disease 5 years ago. Infarct happened before. The infarct has modeled and remaining slow conduction produces a stable circuit. Patient starts getting reentrant ventricular tachycardia. So stable monomorphic VT is scar. If it is coronary disease, the event happened a while ago. The arrhythmia of acute ischemia is polymorphic VT. Polymorphic VT is ischemia happening now. And one of the principles for a general cardiologist is the extent of ischemia is not relevant to the chance of getting polymorphic VT. It is just ischemia triggering the event per se. Could be a diagonal, branch of a diagonal, could be left main, doesn't matter. Ischemia alone is enough to produce polymorphic VT. What about the P wave? I will never forget this ECG. Many of you know Dr. Abdul Jamil Tajik, former chair of cardiology, one of the founders of echocardiography. He is also in pediatrics, and he was evaluating a 6-year-old child from Dominican Republic referred for heart transplantation. Ejection fraction 6%, severe heart failure. He saw the ECG and was struck by the P waves. He called me and said, Sam, this P wave is not looking like sinus tachycardia. It doesn't look like sinus tachycardia. Could it be related to the heart failure? So I saw that child, I still remember after finishing procedures, and this is a long RP tachycardia. I'll discuss in the arrhythmia symposium. P waves are not sinus, they are opposite, they are negative in 2-3 AVF. Stable, fast but slowish tachycardias, fixed rates like this continuously is a sign of a special type of accessory pathway, type of Wolff-Parkinson-White, usually only retrograde conducting, related to the coronary sinus. Slow, so you get long RP, incessant tachycardia. P wave is the tip-off, very important, because if you ablate and you are successful, the heart may recover fully. This child now is a young adult, heart function 65%, did not need heart transplant, and has no longer any other medical therapy. This was purely recognition of P wave morphology in heart failure. More important in common day practice is you are dealing with PVCs, and in some patients, nobody exactly knows what this percentage is. It is not more than 10% of all comers with frequent PVCs, but some patients, the PVCs, by virtue of number, of location, and maybe some predisposition, you get myocardial dysfunction. Ejection fraction is down, and if you remove the PVCs, usually by ablation, then the ejection fraction improves. It can be done with drugs, but the drugs often are antiarrhythmic, often amiodarone, little difficult to keep using for long periods of time. This is a frequent referral for ablation in our practice. Burden is important, but it's not the only factor. Most of the time, very hard to predict who will get ventricular dysfunction. We can follow. Once the heart starts dilating, then it will be a downhill course. Best to try to target frequent PVCs at that time. Clue for the general cardiologist is any cardiomyopathy you can get ventricular PVCs or tachycardia. But in most cardiomyopathies, the PVCs will vary. They won't be in one place. In PVC culprit of cardiomyopathy, the PVCs tend to be in one location. One location means one pattern on the ECG. If you see the same pattern and you see ventricular function is down, this is a very good clue that eliminating the PVCs may improve the ventricular function. Few things about etiology. Many different cardiomyopathies each have their own ECG type patterns. Most of you are aware, but very important, when you couple with imaging. This is not the ECG alone, but ECG coupled with imaging. When I look at this ECG, I am struck by voltage. Voltage is relatively low. Voltage low means usually less muscle. But if you look echocardiographically and there is thickness, the thickness is not muscle. Most often these two together, low voltage, thick, on echocardiogram is amyloidosis. If it is not amyloidosis, it is a rarer spectrum of storage disorders that will need to be considered. Sometimes it's the repolarization vector. If repolarization vector is abnormal but clustered on the apical leads, one straddling the apex, that's where we are seeing the repolarization abnormality. Exercise, no exercise, not angina, something with the apex. Known forever, family history, you can think apical hypertrophic cardiomyopathy, but not so clear and happening, you should think about non-compaction. Isolated left ventricular non-compaction can be associated with ventricular dysfunction. Voltage is difficult to look at in non-compaction because it is still muscle. It is not thick muscle, so voltage doesn't go up, but it is not loss of muscle, so voltage doesn't go down, but repolarization will tell you the story. The apical leads will look abnormal, should take a close look with imaging to look for this non-compaction. Then finally, we must never forget we are physicians, we are internists. We have to look at the whole picture. This is a patient with syncope, rapid tachycardia. We look at this was a fax transmission that was sent to me. Left bundle branch block pattern, right ventricular origin, 2-3 AVF positive, we think right ventricular outflow tract tachycardia. RVOT anybody can get, can be benign, usually don't have very severe symptoms, but story was different. Lot of heart failure, chest X-ray abnormalities, other non-specific symptoms. We have to think about diseases that affect the outflow tract. One of them you heard yesterday sometimes can be affected in patients with arrhythmogenic right ventricular cardiomyopathy. Another important one is hyperthyroidism. Hyperthyroidism, you can get AFib, but you can also get VT. And the VT will be outflow tract. And this is a result of the myxedematous type material, the deposits, just like the retroorbital deposits, come around the outflow tract. Sometimes they are even audible on auscultation. That is called as the Means-Lerman scratch. You can sometimes hear. And when you treat fully, sometimes it will get better. But there is another cause, and the clue here was high ferritin level, and subsequent imaging was classical for hemochromatosis. Along with hyperthyroidism, hemochromatosis, heart failure, mostly diastolic, infiltrative type picture, the arrhythmia may give you some clue. It's a predilection for the outflow tract. So in summary, ECG tells a lot of story about heart failure. It is well more than what I described here today, but these are things every practitioner should be aware of. Analysis of bundle branch block. What does fragmentation, change, secondary vector mean? Don't forget the P wave. Don't forget repolarization. And remember relatively common syndromes, classical features that may clue you in to diagnosis. And of course, never forget the whole picture of the patient. Thank you very much for your attention.
That was our teachers of teacher, Dr. Samuel J. Asirvatham, sir. Thanks a lot, sir. I would like to call the next teachers of teacher, Dr. C. Narasimhan, sir, on stage. There's a good news for all the delegates. We are organizing a quiz program for delegates exclusively. And this is done by, a logo will be shown on the screen. You can download with your iOS device, or you need to download a Google scanner for that. And thus, you can get connected to this particular online. And the quiz will be on the prior 3 sessions. That is the ACS session, the critical care session, and the atrial fibrillation session. Next, the mic to the Master of Masters, Dr. C. Narasimhan, sir.
Thank you very much. I'm actually filling in for one of my colleagues, Dr. Vanita Arora, who is not able to make it today. And oh, okay, they projected this to me, okay. This, you want the other one? Okay, can you project? Preetham, you have given them the quiz. I thought it's heart failure they put in. Shall we finish this?
Yeah. Please scan through your iOS mobiles or a Google scanner. There are 3 prizes reserved for the winners.
Preetham,
And
Dr. Preetham is here. Oh. You can go through this. Which is the one you put it up?
the winners will not only get the trophy, they will be entitled for one lifetime membership of the ISEOCN, the national IC body.
Anyway, let them show.
Please scan. I hope most of us are doing it.
Okay.
Your participation only is through this particular step. If anybody is having any difficulty, can tell the volunteers, they will help it out. iOS gets directly scanned. For Android, it is you have to go through Google Store, Google Scanner, and through it. Enter your names once you scanned in, and you will be ready for the quiz.
This is nothing fancy, but this is a recap of some of the talks that you had heard, and just to re-emphasize the typical ECG findings. So it's pretty basic and okay. This is what, 20 seconds? Someone is maintaining the timer. Okay. This is basically to recap on some of the talks that you have heard. The first question is, which of the following is associated with atrial fibrillation? Clinical consequences of atrial fibrillation. So what are the clinical consequences of atrial fibrillation? We heard this from Dr. Muralidharan and others. Atrial fibrillation can lead to sudden death, increased risk of sudden death, increased risk of heart failure, increased risk of dementia, or is it all of the above? We'll see the answers immediately. Okay. So do we discuss this now? The thing is, all of you are aware that atrial fibrillation patients come with palpitation. But consistently it has been shown that it directly increases the mortality among patients with cardiovascular disease. It worsens the hospitalizations for repeated hospitalization for heart failure. But more importantly, because when the atrium fibrillates, the carotid pressure comes down, the venous pressure goes up, total cerebral perfusion pressure comes down. So if you cardiovert a person and then repeat the cerebral imaging, the cerebral perfusion improves in sinus rhythm. That is directly related to occurrence of dementia. Which is the most common site of trigger for paroxysmal atrial fibrillation? Is it the pulmonary veins, superior vena cava, coronary sinus, or left atrial appendage? In which cardiac condition presenting with symptomatic AF, BNP can be fallaciously low? Most often BNP tends to be elevated. Which condition here? Patient will present with atrial fibrillation, but the BNP can be fallaciously low. Move on to the next. What are the drugs used for chemical conversion to sinus rhythm? They include ibutylide, intravenous procainamide, intravenous amiodarone, or all of the above. There's a lag, does it?
Okay, now.
See, when patients come to you with atrial fibrillation, highly symptomatic, Dr. Amit Vora spoke to us about cardioversion, direct current cardioversion. Sometimes after cardioversion, there are long pauses. They are called termination pauses. How do you prevent this termination process? And some of them lead on to this torsades. Would you give intravenous magnesium prior to cardioversion? Avoid type C drugs, class 3 drugs. Consider TPI in patients with sinus node dysfunction, or all of the above. This is an important clinical situation because if you are caught off guard, patients can come for a benign cardioversion and can end up staying in ICU unnecessarily. Okay. We showed a picture of this. What is this procedure called? I think we'll skip this. Huh? We'll skip this. It's not required. We'll see. I'm sorry, you skipped that. Atrial fibrillation, patients with atrial fibrillation, he presents with dyspnea. What is the diagnosis? Acute pulmonary edema, bronchitis, amiodarone-induced ILD, pneumonia. No fever, nothing. He presents with increasing dyspnea. What is the origin of the wide QRS complexes here in V1? It's the left ventricle, it's the right ventricular apex, LV apex, or none of the above. Shall we finish discussing this, or? These are some of the ECGs which was presented by the morning speakers. 70-year-old male, non-diabetic, non-hypertensive, chronic smoker, typical chest pain, and this is the ECG. Unstable angina, Deventer sign, Brugada posterior wall MI. This is a diabetic hypertensive with rest angina and sweating, 5 hours duration. Early repolarization changes, anterior wall MI, inferior wall MI, none. It's a person with episode of syncope, diabetic, non-hypertensive, typical chest pain, and 1 episode of syncope. Is it non-STMI, infraposterior wall MI, pulmonary embolism, or none of the above? Patient presents to OP had complained of chest pain 2 days prior. It's a non-diabetic, non-hypertensive tobacco chewer. unstable angina, Wellen syndrome, acute anterior wall MI, Brugada syndrome, posterior wall MI. So, 37-year-old man presents with pneumonia and fever. There's no chest pain, but a routine ECG reveals this finding. What should we do? We call the cardiologist for a primary PCI. Be treated with ajmalin, needs an ICD, beta blockers are indicated. I'm sorry, I think none of these answers are correct. I think we'll omit past this question. This is, anyway, we'll discuss this is an asymptomatic Brugada, which was unmasked by the fever, and you just don't treat with ICD. Ajmalin will worsen the situation. You don't do beta blockers are contraindicated for this situation. So none of the answers fit in here. All these patients need is a reassurance and treat fever like a febrile seizure. They need to treat the fever adequately. And do you have any other questions you have put, Preetham? That's all. I think we'll stop with this. Thank you. Anything to be discussed here among the... Okay. So we started discussing, increasingly we are recognizing that one of the features of chronic untreated atrial fibrillation is progressive heart failure, both in HFpEF and HFrEF. It's not the rapid atrial fibrillation which causes heart failure. It's a chronic persistent atrial fibrillation with varying cycle length which causes heart failure. So most often when the patient comes to the clinic, he is completely all right, except for an elevated BNP, progressive dilatation. Second thing is, unless you do higher function testing, by detailed neurological neurocognitive testing, you won't pick up, but that is emerging as one of the causes of dementia, progressive decline in cognitive function. So the answer to this is all of the above. Yes, sudden cardiac death, I'm glad Dr. Gupta mentioned, patients with hypertension, LVH, you see an ECG, and the ECG shows LVH with STT changes. The STT changes in lateral wall indicates microvascular ischemia. These patients, when they exert, when they go into rapid ventricular response, the AF can trigger VF. And similarly, if you have an elderly person with a balanced coronary ischemia, he has a medically treated coronary disease, which is balanced, no problem. But when he develops a heart rate of 150, 160, and rapid cycle length, they fibrillate. This is the common reason how it increases. HCM, they don't tolerate patients, they don't tolerate AFib. Severe LVH due to hypertension, they don't tolerate. So contrary to popular guidelines, these are patients who will still benefit from beta blockers. Hypertension, they say don't use beta blocker. This subset of patients with STT changes, lateral wall, they still benefit from beta blockers. The commonest trigger, almost 90% of atrial fibrillation comes from pulmonary veins. Very rarely we have seen actually one of the practicing cardiologists, he presented with recurrent deglutition related atrial fibrillation coming from SVC which was ablated. So rarely it can be SVC, coronary sinus, and a small percentage from left atrial appendage. But commonest is pulmonary vein. Most common associated comorbidity associated with atrial fibrillation is hypertension. World over, it's hypertension. In India, the prevalence of valvular heart disease is slightly higher compared to the rest of the world, but hypertension is the leading cause of atrial fibrillation world over. The condition where BNP is, whenever there is a myocyte left ventricular disease, the BNP tends to go up. One condition where the myocardium is spared and it's all constriction, which is causing atrial fibrillation, is constrictive pericarditis. In this situation, you will have atrial fibrillation but you will not have a significant elevation of BNP. All the drugs are used for conversion to sinus rhythm. Procainamide is especially used in patients with WPW syndrome and pre-excited atrial fibrillation. Ibutylide is favored, but amiodarone is what we routinely use, but all the drugs can be used for conversion to sinus rhythm. Now again, post-cardioversion related, pause-related torsades can be prevented by omitting class 3 drugs prior 1 or 2 days prior to it. You ask the patient to stop the beta blocker. Stop the sotalol or amiodarone, prophylactically give magnesium. And if a person's pre-procedure ECG shows that the rates have been slow all along, be prepared to put a temporary pacing wire and then cardiovert this patient. And hence the correct answer is all of the above. This is typical of a wide area pulmonary vein isolation, but it's not there. So this is, I want to again, ever since in the last 4 years we have been doing DLCO routinely for amiodarone treated patients. The number of pickups that you have amiodarone induced ILD has significantly gone up ever since we started doing DLCO. Even this stage, you can write off. You need to send this patient probably for a transplant. When this patient comes with breathlessness and you diagnose ILD, it's end of story. But it's far easier to pick it up early on by screening tests. This is amiodarone-induced ILD, which is causing patients dyspnea. This is what you see is a long cycle followed by a short cycle and an Ashman happening. This is none of the above the correct answer. It's not a ventricular tachycardia. What you have is an aberrancy due to Ashman's, and this is none of the above is the correct answer. This is Deventers. We heard it in the morning. They presented that there's a huge area of myocardium which can be completely salvaged if you thrombolize or take and open the vessel at this stage. And this is a must-know ECG, never to forget. If a person comes like this, instead of waiting and watching, you need to consider revascularization immediately. And this is, of course, classic STT changes in a person with typical symptoms, never to forget. Loss of R wave in V2 to V3 and a Q wave is already forming. It's an anterior wall MI evolving. The importance of this is very often, again, Wellens, you would have heard this, it's not making a diagnosis. Still we see patients presenting to physicians with this kind of ECG. When the patient presents to the clinic, generally they don't have chest pain. Chest pain happens 2-3 days prior, and then they come with an ECG like this. Never ever put them on a treadmill. You can fibrillate these patients. You don't need further testing. They have a large area of viable myocardium. Straight away you should revascularize these patients, angio and revascularization. This we did discuss it. The choices are wrong, so we are going to omit this. I think we have finished everything, I suppose. There was one with posterior wall MI. Yes, you can see a typical R wave in V1 with an upright T wave and a very dominant R, V1 to V2 transition, everything suggesting this an infero-posterior MI. This patient, yes, should be considered for early revascularization. Typically, inferior wall MIs have a higher tendency for syncope, and this patient characteristically has that particular symptom. I think we'll close with that. Thank you.
Wonderful session quiz session by Dr. Narasimhan sir. Sir, I request you to stay on the stage. I would like to call the next chairpersons for the next session of Heart Failure Symposium. Dr. M.K. Inamdar sir, Dr. Arvind Gongne sir, Dr. Kuldeep Kuppalwarkar, and Dr. Vijay Patil sir. Sir will be taking on with device therapy in heart failure.
Dr. Suresh Katkar sir, kindly come on the stage.
Good afternoon, chairpersons, ladies and gentlemen. As I was saying, Dr. Parle asked me to fill in for Dr. Vanita Arora, who's going to be talking about devices in heart failure. I wouldn't talk about the LVAD and the other novel devices, but the common garden ICD and CRT is where we use routinely. All of you understand that when a person develops early LV dysfunction class 2, our main aim is to prevent LV remodeling and prevent complications with ACE inhibitors, ARNI and beta blockers. As they become symptomatic, we introduce diuretics and aldactone and keep them asymptomatic. When patients continue to be symptomatic, we introduce, go on for other definitive therapy like LVAD transplant, and somewhere in between is the role for pacing and defibrillator. Why is this so? This is important because if you take a patient who has had an acute MI, this is on, time is on x-axis. Over a period of time, we don't know why someone 20 years after an MI, he has lived quite well. There's another person who has done very well playing tennis, everything. Suddenly, as he's walking, drops down dead. This subset of patient is what you want to prevent by giving an ICD. And there is another person where whatever we do, there is progressive LV remodeling. They tend to worsen, LV dilates and go on to heart failure. So the trajectory of heart failure varies from person to person. There's only one thing that the ICD is meant to do, and that is to prevent a sudden death due to primary VF like this or a VT degenerating into VF. Despite the best medical therapy, some patients with heart failure will continue to develop this. But as a physician, your role is to identify who are the patients who are likely to develop this so that they can be prevented by giving an appropriate shock or by doing a therapy, rapid pacing called as anti-tachycardia pacing. So if you look at all the controlled trials compared to the beta blockers, ACE inhibitors, MRAs, when you offer an additional ICD that seems to protect about 50% of these patients derive benefit in terms of reduction of sudden cardiac death over 2 years. That is what the MADIT trial showed. So are there any clinical clues to the practicing clinician? There are two simple things. One is, as long as the patient's ejection fraction is preserved. In the olden days, it used to be more than 40%. Now we cutoff is 35%. The reduction of ejection fraction portends a bad prognosis in terms of sudden cardiac death, and presence of frequent PVCs and non-sustained VT, they increase the risk of sudden death. When both are present together, that is when you have a person with LV dysfunction and he has frequent non-sustained VT, the risk almost doubles, and it's almost 16-fold higher compared to either one of them alone. And that has been frequently shown in several trials following revascularization with thrombolysis. Patients with LV dysfunction have higher risk of sudden cardiac death. So broadly, when you have a person post-MI who is discharged or even cardiomyopathy, if a person has frequent non-sustained VT in addition, frequent PVCs, or very low ejection fraction, history of syncope or pre-syncope, these are clinical pointers that a patient is likely to benefit more from getting a device compared to a person with just LV dysfunction as the cutoff. Switching gears, some of these patients develop progressive dilatation of the ventricle, which results due to a left bundle branch block. All of you are aware that from the His-Purkinje system, the right and the left bundle branches start activating the right and the left ventricle simultaneously. When a person develops a left bundle branch block, the impulse goes through the normal right bundle, comes from transeptal conduction across the apex, goes and activates the lateral wall. With the result, when the right bundle activates the septum, the septal contractility passively dilates the lateral wall. And when the lateral wall depolarization comes here about 150 milliseconds later, the septum is in diastole. At this time, when the lateral wall contracts, it pushes the septum towards the right ventricle. This results in an inefficient pump as well as mitral regurgitation, which can cause further problem. I don't know whether this plays. Sorry, I did it at the last minute and this is not playing. This is a strain rate imaging showing the same phenomenon. So if you correct this by pacing the septum and the lateral wall simultaneously, more than about 1,000 patients have been randomized in each of the clinical trials, consistently have shown that it not only reduces the mortality, reduces the heart failure, and if patients are chosen at the appropriate time, you tend to have progressive positive remodeling and the LV size comes down over a period of time. So cardiac resynchronization therapy is extremely useful for patients with heart failure, systolic heart failure, who have a QRS duration of 150 millisecond or above, especially if they have a left bundle branch morphology. Among patients with QRS duration of 120 to 150 millisecond of a left bundle morphology, it's still recommended, but the benefit may not be that great. Among patients with non-left bundle branch morphology and a QRS duration of more than 120 millisecond, 150 millisecond, it's considered to be a class 2A indication. This is one subset of patient where conduction system pacing is emerging as an alternative for typical CRT, because the left ventricle is not a problem. You may have to resynchronize the right ventricle or the his bundle. Among non-LBBB patient with a QRS of 120 to 150 millisecond, very rarely these patients may improve if the PR interval is grossly prolonged, say 240 millisecond, and the patient has a diastolic MR and a very abbreviated LV filling. These patients may improve with CRT. And in patients with less than 120 milliseconds, it is not recommended. So CRT is recommended to reduce mortality in patients with a LBBB morphology if they have a EF of less than 30% and a QRS duration of more than 130 millisecond, but it reduces mortality, morbidity and hospitalization of all QRS morphology when the QRS duration exceeds 150 milliseconds. Other thing is, when you upgrade from conventional pacemaker or ICD and the patient's EF has dropped, it is better to upgrade them to a CRT-D rather than a conventional dual chamber pacemaker or an ICD. This should also be considered when you consider a person for a pacing indication. When a person comes to you with a complete AV block and the EF happens to be 30%, instead of giving a pacemaker first and upgrading later, straight away you may consider giving them a CRT-D in appropriately indicated patients. Now, all of you would have seen an occasional patient who hasn't responded. It's not because the therapy is useless, but it's because the lead that is placed is not at the latest site of discordant area. So the therapy will work only when the left ventricular lead is placed at the latest site of activation. If it is placed in a remote area, then the non-responder rates will be high. If it's placed in an appropriate area, most of the patients do very well with CRT. Similarly, if the lead is placed in a scarred area of the ventricle, despite doing a CRT, the patient may not improve. Whereas if it's in a normal healthy myocardium, most of them will do well over a period of time. And how do you recognize that it's an appropriate site? The left ventricular lead should sense the QRS at the end of the QRS so that you resynchronize both the ventricles. This is a simple electrical parameter which can be measured at the time of implantation. The other thing is, yesterday Chinmay presented this patient. Some of these patients, despite implanting the lead in the left ventricular free wall, you may not be able to adequately resynchronize. In these patients, adding an additional lead directly into the left bundle branch will help to narrow the QRS further and optimize the therapy in terms of left ventricular remodeling. So this is called as LOT CRT. This is a useful therapy, an adjunct to the conventional CRT. So in conclusion, device therapy is an adjunct to optimal medical therapy in patients with heart failure. To prevent sudden cardiac death, patients with ischemic cardiomyopathy less than 35% of EF, most of them for primary prevention, it's a useful therapy. Among patients with wide QRS and LV dysfunction, especially if the left bundle morphology, most of them will derive benefit from CRT-D rather than plain ICD. CRT is a useful therapy in this subset of patients. Thank you very much for the patient listening. Okay. Cardiac, what Dr. Vijay Garg is asking is a newer form of therapy called cardiac contractility modulation. It's a therapy where a lead is placed in the right ventricle and delivers a very high pulse of 20 MA at a very long pulse width of 20 milliseconds in depolarization phase itself. It's when the ventricle is refractory. The idea is you make all the calcium from circa release at the same time and that's sequestered at the same time. So this is the premise with which it has been used, and in small trials it has been shown some benefit, but randomized control trials haven't shown outcome data that is very beneficial. So it is still in an occasional patient, for example, who has got calcium leaks like calmadulin mutation, or some of these patients who have inefficient calcium release, it may work, but it may not work for all patients.
Is it always CRTD or CRTP also has some role?
CRTP we use for patients, we have burnt our fingers to be in a thing. We think it's very heroic to put a CRTP alone, but occasionally on the day of discharge, patient has a sudden death. So you don't know how to face the family. By and large, if a patient can afford, go for CRTD if the indication is correct. For a non-affording person, we go if the MRI doesn't show a scar. In a non-ischemic cardiomyopathy, we can get away with CRTP. The present, yes, it's become less and less frequent nowadays because the leads have become up to 2 French now, 2.9 French. Very thin leads are available and the tools have improved. Having said that, approximately about 1 to 2% in our practice, you may not get the lead. There we may try a direct conduction system pacing. And if it doesn't narrow the QRS, we can ask a surgeon to make a small thoracotomy and put the LV lead there.
Sir, left bundle pacing for a CRT, if we require a defibrillator, that can be given also for left bundle pacing and defibrillator.
Say that again, I didn't get the question.
In those who are putting CRT, in them left bundle pacing, the newer method that can replace, left bundle pacing can replace CRT, the CS lead.
Left bundle pacing we use in some patients where when we think the patient has got pure left bundle branch block related LV dysfunction. But most patients who have concomitant myocardial disease, suppose you have a person with the SCN5A mutation, family history of laminopathies, it's a progressive disease. You can pride yourself saying I have narrowed the QRS. If you know the natural history, it's going to worsen 5 years from now. So if you have appropriately selected patients with pure conduction system disease and he has come to you with LV dysfunction, you can try left bundle in lieu of CRT, but not in all patients.
Two questions. In between non-ischemic cardiomyopathies and ischemic cardiomyopathies, what is the response of CRTP or CRTD? That is one. Second, what is the role of leadless pacemaker? Are they going to come in CRTD?
Okay. So the first question is the responder rate consistently is higher in non-ischemic cardiomyopathy compared to ischemic cardiomyopathy. Ischemic cardiomyopathy have a peculiar pattern of response. They have a late response. So you put the CRT, for response to be seen, this has been documented in several clinical trials. For the first 6 to 8 months, they don't improve. After that, you see steadily the LV remodeling happens. So that's a peculiar pattern that we see in ischemic cardiomyopathy. Having said that, the non-ischemic responds better. Leadless pacing, it's still evolving. YCRT is now in current clinical trial, the phase 2, and it shows where you directly instill a pellet into the LV and you have an outside transducer which transduces the current. Still the outcome data is still, the current trials are going on in Prague and in the US. The outcome data is still yet to be published. Thank you.
Indeed, it's an academic treat to hear from stalwarts like you, sir. Chairpersons, kindly be seated for the next session. May I call Dr. C.K. Ponde, sir, for his talk on heart failure management, what is new.
Thank you very much indeed. Dr. Parale has given me a mammoth task of dealing with the pharmacological management of, and I reduced it from heart failure in general to HEP-REF. Is impossible to cover both in 10 minutes. So thanks for inviting me here to my mother town. The universal definition of heart failure is reduced ejection fraction, very simple to diagnose, an echocardiographic ejection fraction of less than 40% to all those students who are here in the background. And mid-range between 40 to 50 to 55%, above 50% is called preserved ejection fraction. There's one new terminology called improved ejection fraction. Patients with ejection fraction less than 40 who are put on guideline-directed medical therapy and improve their ejection fraction by 10 digits or above and come above 40% is called improved EF. This definition is important because so many physicians have this concept that if my patient ejection fraction improves, I should stop the therapy. That's not true. The therapy should continue indefinitely in almost all the cases. What are the sad truths about heart failure in general? The sad truths are almost 25% of adults above the age of 40 will develop heart failure at some stage in their life. And the mortality, the 5-year mortality of heart failure is higher, which is at 50%, which is higher than leukemia, colonic cancer, and even non-Hodgkin lymphoma. And very few of us understand that, particularly relatives. When a patient is admitted with acute decompensated heart failure in the ICU, all that you hear from the relatives, कुछ नहीं, थोड़ी सांस फूली थी, अभी डॉक्टर बोलने बोला है, सब कुछ ठीक है. Whereas, when you say it is cancer, the entire family, the social background, the social institutions come all together to help the patient to save his life. Is prognosis different in Indian patients? Yes, certainly. The data, this was produced long ago in 2015 from Indian continent, North India in particular, has shown that the mean age of Indian patients is 20 years younger. The in-hospital mortality, 10 times higher. And the post-discharge mortality at 1 year, 6 times higher. And that is because the Kerala Heart Failure Registry has shown us that guideline-directed medical therapy is implemented only in 25% of patients at discharge. And in those in whom it is implemented, only 25% adhere to the therapy at 1 year. That is the sad fact of Indian heart failure scenario. And the inter-CHF registry, proudly we are the part of it, 25% of Indian heart failure patients die within 1 year of diagnosis. What are the goals of therapy in heart failure? Increase in survival, yes, of course. Reduction of heart failure hospitalizations and make people feel better. Meaning, improve their quality of life, improve their performance in life, improve their productivity in life. How was the journey of randomized controlled trials in heart failure? See, if you see, it all started way back in 1986 with consensus trial. And then we have SOLD, AIRE with ramipril, we have MERIT with metoprolol, CIBIS with bisoprolol, and Copernicus with carvedilol. And then we had several trials, and then there was a long hiatus from 2009 till 2014. And then we have Paradigm. And Paradigm with the invent of sacubitril valsartan as a pillar, one of the fantastic 4 pillars of the heart failure therapy, we had entered a completely new era of heart failure with reduced ejection fraction management. Because this is the first drug which has shown reversal of ventricular remodeling in heart failure, reversal of left atrial remodeling in heart failure, reversal of left atrial reduced reservoir strain in heart failure. Our own paper, which is in publication right now, has shown that combined ARNI and SGLT2 cause reversal of remodeling to an extent where almost 1/3 of patients initially scheduled for CRT and initially scheduled for primary prevention of sudden cardiac death in non-ischemic directed cardiomyopathy escape the devices. Because at 3 months and 6 months, the ejection fraction climbs above the cutoff limit of 35%, as Dr. Narasimhan has said. And I would like him to comment at the end of my talk on this particular issue. So the journey has been really breathtaking. The paradigm trial has shown us 20% reduction in cardiovascular death, heart failure hospitalization, and even sudden cardiac death. We know now that these fundamental fantastic four pillars also cause reversal of electrical remodeling in heart failure. So now we had beta blockers, ACE, ARBs, and MRA. Now ACE, ARBs have been replaced by ARNI, and then we had dapagliflozin with DAPA-HF, empagliflozin with Emperor reduce. So now these are called the so-called Fantastic Four, and these are called paradigm shift in the management of HFrEF patients. I will show you the mortality benefits of these drugs in a while. How do I do the sequencing? In the olden days, we used to start one drug at a time, build up to the maximum dose, then add the second drug, then add the third drug, and so on. Now no more. Milton Parker and John McMurray showed this new sequencing. When you are a patient admitted in ICU with a borderline systolic blood pressure on large doses of loop diuretics, oxygen dependent. Here we are hesitant to start a drug like ARNI because we are afraid of hypotension. So initially you can start pre-discharge, beta blocker and SGLT2. Safe drugs, bisoprolol and dapagliflozin, bisoprolol and empagliflozin. No fear of hypotension, no fear of hyperkalemia. And you can start these two drugs right off before discharge. And by the first week follow-up, when the diuretics are down, when the blood pressures are shade up, and there is no fear of hyperkalemia, you can start a ARNI. Look at the number needed to treat. Look at the devices, like Dr. Narasimhan was saying. 14 devices, 5-year number needed to treat is 14, whereas beta blockers, 8, ARNI, 11. So now the mantra is 4 drugs in 4 weeks. All the students sitting at the backdrop, please remember 4 drugs in 4 weeks. That aggressive you should be in management of HFrEF. Second problem is CKD. We know 1/3 of patients with heart failure have CKD, and 25% of patients with heart failure have worsening renal function a week prior to their admission in an acute decompensated state. We had initially only RAS blockers, which improved the renal outcomes. And now we have SGLT2 as a pillar of improvement of renal dysfunction and progressive improvement in renal dysfunction in patients with HFrEF. No other drug could show us that. So CKD in heart failure increases mortality, worsens symptoms and quality of life, and increases hospitalizations. And SGLT2 inhibitors are simple to use, single dose, single day, that is once a day, no much contraindications, no fear of hypotension, no fear of hyperkalemia. So easy drugs to use. And look at this chart. If you use all the Fantastic Four, ARNI, beta blockers, MRA, SGLT2, almost 65% reduction in composite endpoint. If you are not able to use SGLT2 and use vericiguat, 45%, and so on. So lesser the number of drugs you use, lesser the relative risk reduction. Higher the number of drugs you use, mind you, whichever dosages. If you use 4 drugs in half doses, that is better than using 2 drugs in maximum dosage. This is another important message from all these trials. And despite this, the use of the drugs is miserable by us. Miserable. Even in US, ARNI was used in 2020 in only 2% of discharged patients. Now the scenario is much better. It is 25%. But in India, the figure is around 15 to 20%. So we should improve. And the strong heart failure trial has shown us that earlier you up-titrate them, the better you are in terms of 180-day mortality. Iron therapy is another pillar of therapy in heart failure with reduced ejection fraction. And anemia here is defined as not by hemoglobin, but by ferritin less than 100 or ferritin above 100, but saturation less than 20%. Victoria was another trial which showed effectiveness of vericiguat in patients with worsening heart failure who are already on guideline-directed medical therapy and who come with worsened heart failure state. And vericiguat, which is the soluble guanylate cyclase inhibitor, showed the reduction in heart failure hospitalizations. However, the mortality benefit was, the trend was there, but it didn't show statistically significant mortality benefit. Omnicative mecarilbyl, a cardiac-specific myosin activator, has also shown some promise. Yet, mortality data is pending. So I must say, past is an unsolved mystery, and the truth is a moving target. If we all remember that these 4 drugs, beta blockers, ARNI, SGLT2, and the mineralocorticoid receptor antagonists are the fantastic 4 pillars. You should use them in all patients by 4 weeks. Those with come with worsening heart failure, vericiguat is a great drug to use. And if you use all 4 of them, many patients will have many productive years to live without mortality and with good quality of life. Now, Dr. Narasimhan, I would like to ask from my side you the question that how many months you would recommend for us to use with GDMT before we consider CRT in a patient in whom it is already indicated? And in your experience with GDMT, does the CRT implants and ICD implants for primary prevention of sudden death in non-ischemic cardiomyopathy have come down?
Yes, it's always, say you up-titrate the medications. The way we do it is call the patients within 2 weeks. You see the trend, what is happening. If his heart rate is not coming down, he remains hypotensive, sodium remains low, dilutional hyponatremia. These are all patients who are not going to do very well. Second thing is, if the LV is significantly remodeled, then the QRS shows a lot of notching in the QRS. There is an axis shift leftward. These patients, I have a lower threshold because in the waiting period, you may lose these patients. So you take the help of clinical indicators like simple thing like dilutional hyponatremia, whether the patient has PAH, MR, so on and so forth, before you decide. In these patients, you tend to offer devices at the end of 6 to 8 weeks. Whereas if a person at the end of 2 or 3 weeks says that he is feeling great, everything is becoming better, heart rate is improving, blood pressure is picking up, effort tolerance is improving, I try to push it for 4 months before we reassess.
Sir, what our data shows is that if you can get down the NT-proBNP by 30% to baseline in 2 weeks, these patients invariably tend to do very well. And they titrate GDMT up titration very well without any hitches.
True.
And other patients, as you said, with change on axis, particularly extreme right or extreme left axis, notching of QRS, too broad a QRS, or a persistent deep S in V6 in the presence of LBBB, they sort of
fit in.
Go your way. Thank you.
How will you put ivabradine in patients of heart failure? Maybe the 5th pillar, if we are using judiciously to bring down the sinus rate in patients we are not able to control.
See, I think there are two very beautiful papers which have appeared, one in JACC and one in the Journal of Cardiac Pacing and Electrophysiology just recently, that not only getting sinus rate down in heart failure is important, ivabradine has, for the students, ivabradine has not shown any decrement in mortality in HyperF. It has shown improvement in heart failure hospitalizations, reduction of. So those patients who despite maximally tolerated dose of beta blockers, their resting heart rate doesn't come below 70, I would definitely add ivabradine. Or those in whom I am unable to uptitrate the beta blocker dose because of borderline blood pressure, I would definitely give ivabradine. But importantly, in those who restore, in whom you can restore sinus arrhythmia at rest, they tend to do much better. So if you can get a good heart rate variability at the end of the day, those patients tend to do much better than in those in whom you just achieve a low heart rate without heart rate variability. Electrophysiologists can have a comment on that. Yes.
The capacity to uptitrate the drugs, the inability to uptitrate the drug is a poor risk indicator.
Yes.
So if you are able to uptitrate the drugs and progressively go up on both beta blockers and ARNI, that patient is going to do well over a period of time.
There is some question.
You covered all the newer aspects.
Yes.
The Phenobarbital was drug come basically for the renal, has some very good effects on the heart failure.
Yes.
Basically, it's a mineral corticoid, of course, to people who can't tolerate for whatever reason. I think that will be what is the role in this newer model.
Some trials are in progress right now on Findarin, the non-steroidal mineral corticoreceptor antagonists in heart failure patients with CKD.
They're good result,
And
actually.
possibly we'll have some data by 2024. So,
Sir, one practical question. Whenever you start patient on ARNI, the creatinine increases, eGFR decreases. So how do you really practically approach this? Because once you go from 50 to 100, and suppose the creatinine jumps from 1.2 to say 2.3, and eGFR comes to around 30, 35.
Yeah.
How do you practically assess that?
I think there are two important tricks of the trade here. Number one, when you institute ARNI, see to it that your loop diuretics are cut down as much as possible. Confirm that your patient is euvolemic by just simply screening the inferior vena cava in your consulting room with a simple probe. If your IVC is completely collapsed and less than 10 millimeter and collapsing more than 80%, this is not a patient who should go on ARNI. You make the patient euvolemic first and then institute ARNI. Rarely fever, you will see fall in eGFR. Secondly, when you institute ARNI and SGLT2 together, the drop in eGFR in the first week is far too much robust as compared to when you sequence these drugs. And that is why the second algorithm, beta blockers, SGLT2 inhibitors first. At the end of 1 week, take up the loop diuretics almost totally, make the patient euvolemic, give another 1 week and institute ARNI. That way you will be much better off. Up to 50% increase in baseline creatinine and 30% drop in eGFR is not a big problem. Ultimately, at the end of 6 weeks, it will plateau down, and in fact, these patients, clinical trials have shown people in whom there is a drop in eGFR in the first week tend to do much better in terms of 30-day mortality as compared to those in whom there is no drop in eGFR. So it is not a side effect, it is the effect of these molecules, and I don't think one should get alarmed with it. So as I said, 50% increase in creatinine and 30% drop in eGFR at 1 week, one should not get alarmed. Make the patient euvolemic, reduce the loop diuretics, and increase their liquid intake by 200-300 ml a day, and you should be all right.
There are some few data has come in cases of acute heart failure, use of acetazolamide.
Oh yeah, that's a different ball game. I was talking about, sir, chronic heart failure with reduced ejection fraction. Acetazolamide has come in a big way. Probably it will come in guidelines as well. But it is for ADHF patients or patients with chronic heart failure who get admitted in acute decompensated phase, who were on already a good dose of loop diuretics. In them, it's an adjunct to loop diuretics, and they do much better. Yeah, I agree with you. Thank you.
There are two questions. Are you using only bisoprolol in these 4 pillars or any beta blocker? Metoprolol, carvedilol, bisoprolol?
My entire practice is probably all bisoprolol for several reasons. Number one, the CBIS data, as far as I see through the lens, is far much stronger data than any other beta blocker trials in heart failure. Number one, because CBIS was the only trial which showed reduction in all-cause mortality. CBIS was the only trial which showed 25% reduction in sudden cardiac death. CBIS was the only trial which showed the improvement in mortality and heart failure hospitalizations across all range of dosages, 1.25, 2.5, 5 and 10 milligrams. No other beta blocker trials have shown that. And also the reduction in heart rate for a given beta blocker dose, I see much better with bisoprolol. So my choice is bisoprolol. Maybe experts will disagree to this, but my choice has been bisoprolol. Secondly, when you are using ARNI, I need a margin of blood pressure. Carvedilol causes much better drop, much robust drop in blood pressure. So then your ability to uptitrate ARNI goes down. So if my beta blocker is bisoprolol, my ability to uptitrate ARNI is far much better.
How is your experience in bisoprolol and COPD patient?
Sorry?
Your experience bisoprolol and COPD patients?
It's good. In fact, that is the only bisoprolol approved for use of COPD patients. Its beta-1 selectivity is probably one of the highest beta-1 selective, yes.
Where you keep isoniazid and hydronazid in heart failure?
That is in patients with CKD with a EGFR of less than 15. So EGFR of less than 15 or 20. See, I'm telling you, CKD patients stage 4 or stage 5 with heart failure are the most difficult subsets you can ever treat. And in this group of patients, hyperkalemia is a nagging problem, volume shifts is a nagging problem, flash pulmonary edema happens all the time, and you can't give RAS blockers. There, isosorbide dinitrate hydrolysis combination will come in a big way. Yeah.
Thank you, sir.
Thank you very
A big rouse of applause for the esteemed speaker, Dr. C.K. Ponde, sir. I would like the chairmen to felicitate Dr. C.K. Ponde, sir.
If patient comes with heart failure first time and his renal parameters are deranged, do you start ARNI?
What is deranged?
Huh?
What is deranged, sir, you said? Renal parameters.
Which one?
What is deranged, you said?
No, patient comes for the first time with a heart failure and his renal parameters are deranged. So you start ARNI?
No. Certainly not. That's a dynamic state. Patients may be volume depleted or there could be a background of sepsis. Remember that 1/3 of acute decompensated heart failure patients have some intercurrent infection as a precipitating factor. And if that is causing rise in a derangement of renal parameters, neither ARNI nor SGLT2 can come straight up on the board. The only drug which can come straight up on the board is a beta blocker.
What level of creatinine you start,
I would not say creatinine. Up to 30 GFR, I am still comfortable. Below that, I am not comfortable.
Okay.
Thank you.
And question just beyond box.
Yes.
Can you use ARNI in HepPep patients?
Yes, that's another chapter. Paragon data and now recently released Paraglide data. Both have shown quite a good promise of ARNI in women in particular, up to ejection fraction of 65%, and men up to the ejection fraction of 55%. So those mid-range, 45 to 55 men and 45 to 65 women still with HepF still benefit with ARNI, yes.
One of my patient coming with recurrent LVF. With all this hidden, but once I started ARNI, it stopped almost for 2 years.
In fact, I just had Dr. Satyasham Toshniwal's one patient here, HepPep diagnosed, and she's doing very well for the last 6 months. Touch wood. Thank you.
In the short of time, we would like to proceed with felicitation of Dr. C.K. Ponde, sir. Followed by, there is an announcement to be made by the Honorary General Secretary of ISEOCN, Dr. Ketan Mehta, sir. Yes.
So friends, before you go for lunch, just quick few announcement. One on, I am Dr. Ketan Mehta, Honorary General Secretary of Indian Society of Electrocardiology. Let me ask, how many of you are life members of ISE? And so you have a huge potential. Those who are not, please do become a member. You can go to the website www.iseindia.org and you can become a life member. And if you are here today, you can submit your application form along with the documents, or you can send it to us. All the details are there on the website. www.iseindia.org. Second, those who are already members and are not receiving their, we have this quarterly journal, please do inform us, or if you have updated your address or contact details, please do let us know. That is second. And third, all the registered delegates do avail of copy of the last edition of our quarterly journal, which is available from the stall of USV. So please do collect it. I am sure it would be a useful tool, and it is a very good articles, especially in the clinical practice. So we all go for the lunch, and then next announcement for the
We all now disperse for the lunch, and we sharply reassemble at 2 p.m. for Legend of Legend talk on Arrhythmia Symposium by Dr. Samuel J. Asarvatham. Thank you.
Dr. Samuel Asirvatham, the senior faculty and the renowned electrophysiologist at Mayo Clinic. He is already on the dais for the presentation. May I call upon the chairpersons, Dr. Amit Vora sir, Dr. Okay. Chairperson Amit Vora. Yes, sir. Dr. Amit Vora sir, Dr. Ponde sir, Dr. Gupta sir, and Dr. Raja Selvaraj sir. You are requested to come on the stage. Stage, sir. Yes, sir. Okay. Okay. Sir, please take the chairs as a chairperson for the next session. And may I call upon the moderators, Dr. Yash Lokhandwala sir, Dr. Murlidharan sir, Dr. Narasimhan sir, and Dr. Geeta Subramanian sir. Sir, yeah. Sir, the moderators are requested to occupy the front seats. Yeah. Yeah. With the permission of the chairpersons, we can start the sessions.
We have a nice amount of time, 90 minutes, and going to focus on few rhythm issues that I'm targeting the general cardiologist, internist, fellow, resident. So it is a very basic talk, but some of the common errors, questions that have come up over the years related to SVT ECG diagnosis and wide complex tachycardia diagnosis. After that, if there are some EP people have more detailed questions, we'll have some time between Dr. Narasimhan, Vora, Dr. Selvaraj, all of us, Dr. Murali in the audience, Dr. Ashish, we can cover those questions if they arise. So most common time, you're called for palpitations in emergency room or to a clinic office. Syndrome will be intermittent palpitation, tachypalpitation, and when it terminates, it's completely normal. This is the syndrome of SVT. Paroxysmal and ECG will show tachycardia, narrow complex, and then back to sinus rhythm. And when you look closely at this, you will have a hard time finding the P wave. Where you may recognize is there is some abnormality that's just after the QRS. So you will quickly recognize the clinical syndrome, tachypalpitation, paroxysmal. You'll quickly recognize when you get ECG, it's a narrow complex tachycardia, it's regular, and then next job is to search for the P waves. And then P waves, little difficult to find, means the P waves are close to the QRS. And this brings to you, have to make a diagnosis of mechanism of SVT. Treatment is little different, presentations are little different, and what we mean by mechanism of SVT is distinguishing between the big three. Patient who gets intermittent tachypalpitation, regular and narrow QRS, the big three are AV node re-entry tachycardia, AV re-entry tachycardia, that means accessory pathway between A and B, accessory pathway related tachycardia, and atrial/sinus tachycardia. So should be, as any general cardiology internal looking at this, should be able to tell within few minutes of the ECG which of these three are we going to look at. So how to do that? First, we must appreciate this syndrome. This is very different from atrial fibrillation and other syndromes. Patient is completely normal except when they get tachycardia. Once it starts happening, tends to become more frequent. Many times they may have already learned some maneuver like vagal maneuver can stop some of the tachycardias. And the recognizing is important because treatment is very good. Either can be drug treatment or curative ablation is a frequent option for this syndrome. First step, after you know you're dealing with narrow QRS tachycardia, is try hard to see the P wave. Sometimes you can very easily see the P wave during the tachycardia. And that means usually the P wave is far away from the QRS. So far away from the QRS, closer to the next QRS, this is long RP tachycardia. So first step in the ECG, you'll say narrow QRS regular tachycardia. Second, you have to say, is it long RP or short RP? So for that, you have to see the P wave. If you see it clearly closer to the next QRS, that is long RP tachycardia. Long RP tachycardia is usually an atrial tachycardia. Sometimes, if patient is under severe duress, psychological issues, pregnancy, it could be sinus tachycardia. Easy to tell by looking at the P wave, does it look like sinus, 2,3 AVF positive or not? If on the other hand you have trouble seeing the P wave, usually that means the P wave is little closer to the preceding QRS. And this is a short RP tachycardia. So of the big three, long RP is atrial tachycardia, short RP is either AV node reentry or accessory pathway related tachycardia. These are reentrant tachycardias. They come back towards the atrium fairly quickly, and that's why the RP interval is short. Now, this particular most common arrhythmia can usually be recognized very quickly because not only the RP interval is short, it's very short. The R and P are essentially occurring at the same time. So this is recognized because this is a circuit that involves the AV node. Yesterday you saw some discussion about AV node. AV node is living close to the tricuspid valve. For sinus beat to reach this AV node, it has got a lot of obstacles on the way. So the wave fronts to reach the AV node are divergent. So AV node has also changed to accept these different inputs to it, and it gives rise to pathways into the AV node. So this atrial pathways into the AV node, inside the AV node, coming back out is AV node reentry. So notice, because you have these different inputs or pathways to the AV node, it's possible to get a tachycardia circuit using one input towards the AV node, another one back, and that creates this circuit. Since this circuit is involving the AV node, from this point where my arrow is, by the time it starts coming back to the atrium, the wavefront, it's also going to the ventricle. And this is why the P wave and the QRS can happen at the same time. This point in the circuit from which you go to atrium and ventricle is happening at the same time. So the shortest possible RP intervals, if you see, you say AV node reentry. What does this mean, shortest possible? It is just tagging along the QRS. So if you look at this, you may even say, where is the P wave? T wave you see, QRS you see something at the end of the QRS. This, even for medical student, narrow complex tachycardia, paroxysmal syndrome, RP is short, super short, diagnosis is AV node reentry. On the other hand, sometimes you look at a ECG and you can have to think, what can I exclude? It's not what can you diagnose, you have to think, what can I exclude? So here, during the tachycardia, it is also a regular narrow complex tachycardia. So immediately you think big three. You think atrial tach, AVNRT, pathway-related tachycardia. But atrial tach and sinus tachycardia both have long RP. But you should have no trouble in telling which one you can exclude. Look at the P wave. P wave is negative in lead 2, lead 3, AVF. Feet leads is negative. That means origin of the P wave is near the feet. Sinus node is near our head. Should be positive in 2, 3 AVF. So this you can reliably say this is not sinus tachycardia. So even if patient is anxious, even if patient is pregnant, you see during exercise, this long RP tachycardia is not sinus tachycardia. So most of the time, long RP we think is an atrial tachycardia as long as P wave does not look like sinus. Sometimes can be a little difficult because atrial tachycardias can come near that region, but most of the time this is P wave different from sinus, long RP, most of the time this is going to be an atrial tachycardia. Now why is that important? Because atrial tachycardia, unlike AV node reentry, pathway-related tachycardia, is probably not congenital. It is not there from birth. It's usually developed. It may be developmental, some cell rests, but whenever something is acquired, then we are a little more guarded about prognosis. Could there also be atrial fibrillation? Could there be another atrial tachycardia? Little bit will depend on the age of the person and monitoring to see, does always that tachycardia look the same? If it's always the same, don't see anything else, then these are also very good candidates for ablation. It can be mapped, found where the location is arising from, and ablated, and can be very satisfying results. Now, another doubt that sometimes will come, and you'll be asked as a cardiologist or on call, are you dealing with flutter, fibrillation? And used to be some old concept like maybe like fib and flutter are to actually, the one thing we can forget is it's going to be either fibrillation or flutter. There is really no fib flutter. Best way to tell the difference is look at the waves that you see, maybe like put a tracing paper over it, and then you can just move and move and move. Looks exactly the same. Not similar, but exactly the same as you trace from one side to the other. your diagnosis is flutter. Your diagnosis is flutter. If it looks kind of organized, but you're not able to do this, it is changing, it is fibrillation. Now, why do we make a distinction? It's because flutter can happen in normal hearts related to the tricuspid valve. So this is just cartoon of tricuspid valve. In the muscle between the tricuspid valve and IVC, it's a natural narrowing, as a result, slowing of the wavefront. Anytime in the heart there is a narrow passage or an isthmus, the big wavefront has to crunch to go through it. That slows conduction. And whenever you slow conduction, you can get re-entrant tachycardia. So the most common large circuit non-AV node dependent tachycardia in human atria is atrial flutter that's related to this isthmus between tricuspid valve and IVC. Although these flutters or large re-entry circuits can happen anywhere in the atrium, this is the most common, and the EKG pattern is quite recognizable. It will look like there is a pattern, and when your eye looks at the pattern, whatever seems to be the end of that flutter wave, if you draw a line to V1, draw a line from the end of what your eye sees as the flutter wave to V1, and if the terminal part is positive, for this flutter wave in V1, this is a very good chance it's cavo-tricuspid isthmus dependent. And why that is important is if all the flutters we deal with in EP, this is the most straightforward to ablate. For example, average time to ablate cavo-tricuspid isthmus flutter is about 1 hour, 15 minutes, 20 minutes. On the other hand, any other flutter we have to map, find, ablate. Lucky if we finish in 4 to 5 hours. So lucky. So this is why general cardiologists, fellows, trainees, internists should be able to recognize when it is flutter and when the flutter is the real cause of the symptoms or the rapid rates, and the pattern, if it suggests cavo-tricuspid isthmus, this is an ablatable arrhythmia. Now this is one we don't see that often. This one I think everybody looks at, you see it is irregular. So irregular, no pattern, we always think atrial fibrillation, but unlike atrial fibrillation, we are seeing some P waves. So P waves are there, but it's very irregular. Then we have to think of few diagnoses. Maybe it is a lot of PACs. Maybe it is atrial fibrillation and I'm just thinking I am seeing some P wave. Maybe it is flutter with variable block. Or this condition where discernible P waves and multifocal atrial tachycardia. Why is it important to recognize this? This is a bystander arrhythmia. Problem is not in the atrium. The problem is either some drug toxicity, but most commonly it is COPD. It is lung disease, ventilated patient, emphysema, end-stage bronchiectasis, COVID pneumonia. You see this multifocal atrial tachycardia. Very difficult to control the rates. No point in cardioverting, it will be right back. No point in using antiarrhythmic drugs, it will be right back. This is one, if the lung has to get better, if not, either patient has to live with it, or in some cases to control the rate, you may have to take a AV node ablation pacemaker type approach. Key is you will see the P waves, but it's not like flutter. You won't see the same pattern, you will see varying P waves. PACs, very common misdiagnosis. Just somebody eyeballs the telemetry and says AFib. And what you look closely, you will see that there is abrupt changes in the P wave morphology. Some of the P waves are looking different, and those are the PACs. So frequent PACs can occur in many illnesses, in sepsis, in some other inflammatory states, lupus flare, not necessarily an arrhythmia that has to be treated. In some patients, it could be forerunner of atrial fibrillation, but most of the time, patients are minimally symptomatic. It's observed as part of some other illness and just should not misdiagnose as atrial fibrillation. Even at Mayo Clinic, I have seen people, one person got cardioverted just because of frequent PACs. So it happens. Have to be alert that not all irregular looking things are atrial fibrillation. So these are some intra-atrial type arrhythmias. By looking at the regularity, searching for P waves, seeing if it's like flutter and remembering the pattern for cavo-tricuspid isthmus dependent flutter, you can usually make your diagnosis. Clearly no organization, we know this arrhythmia, atrial fibrillation. So then let's look at our next SVT category. We have some idea now, so let's say you've never really thought hard about ECG, regular narrow complex tachycardia, look for the P wave, long RP, atrial tach, sinus tach, P wave morphology will tell you which it is. Short RP tachycardia, hardly can tell P wave is different from QRS, AV node reentry. The remainder is going to be related to this type of situation. Here we look at the ECG, multiple abnormalities. R wave progression is funny, R wave is there in V1. ST changes are all over the place. Before any of those things you look at for the diagnosis, most of you would have understood. PR is short, funny looking initial part of the QRS. Diagnosis is pre-excitation. So what is this pre-excitation? It means there is an extra nodal connection between the atrium and the ventricle that conducts antegrade from atrium to ventricle. AV node, it is said human longevity, if not for the AV node, will be 7 years, even before we could have reproduced. Because even brief run of atrial fibrillation, we would have died. AV node is our protector. It makes sure to delay the current before it comes into the ventricle. What happens though, in fetal life, we actually have multiple connections between the atrium and the ventricle. For example, if we look at a fetus which is approximately at 27, 28 days, that whole AV ring is capable of conduction. And then slowly it insulates and leaves behind only the AV node. But in some people, maybe even up to 2 out of 1,000 people, there is a remaining connection, muscular connection from the atrium to the ventricle. So now during sinus rhythm, we have 2 ways to get to the ventricle, through the AV node or through this muscular extranodal bypass tract. Which one will conduct quicker? AV node's job is to slow conduction. This pathway is just muscle. It has no job to slow conduction. So the first part of the activation is through the muscle. And the muscle does not conduct normally. So the first part of the QRS doesn't look normal, and that is the delta wave. And because it is not delaying as much as it should, the PR interval is short. So this gives rise to few problems. One, anytime we have 2 connections between 2 structures, you can get a circuit. And this circuit giving rise to arrhythmias are some of the arrhythmias, SVTs, related to bypass tracts. Now when searching in the ECG to look, sometimes it can be very obvious, sometimes it's a little bit difficult. This depends on the degree of fusion. That means ventricle is actually a fusion beat when there is an accessory pathway, partly through AV node, partly through pathway. In exercising patient, anxious patient, young patient, AV node may not be that slow, so hard to see this pathway. If pathway is far away from sinus node, harder to see the pathway. So sometimes can be a little bit iffy, but watching on the monitor, checking in different states, sleep, exercise, changes that happen, usually you will be able to make this diagnosis. Sometimes you will see even during a strip that obvious diagnosis and then normal beats without doing anything, no treatment, nothing. There's just small spontaneous changes in the autonomic tone can give rise to this. This is this concept of fusion during accessory pathway pre-excitation. Now, when we look, we see the types of tachycardia that you can get. Tachycardia can be re-entrant. So, down the accessory pathway, we call antidromic tachycardia. Down the AV node, we call orthodromic tachycardia. And both produce regular tachycardia. The difference is when we go down the pathway, we will get this antidromic tachycardia that produces wide complex. So for narrow complex tachycardia, coming down the AV node, just like normal conduction, like normal teeth, orthodromic tachycardia, narrow complex, wide complex, both are regular. But atrial fibrillation doesn't require the pathway, but can conduct more rapidly than usual through the pathway. That produces the pre-excited atrial fibrillation. Things to remember about these three: regular tachycardia, if you block the AV node, tachycardia is gone. Whether it is wide complex or narrow complex, whether it is orthodromic or antidromic, if AV node is blocked by a drug, adenosine, other AV nodal blocking drug, tachycardia will stop because AV node is a necessary limb of this tachycardia. With pre-excited atrial fibrillation, the more you block the AV node, the more likely the accessory pathway will conduct, and you will paradoxically increase the rate of the tachycardia. So thing to remember when you know patient has this accessory pathway, they are having symptoms, should you block AV node or not? It's not the QRS that will tell you the difference, it's the regularity. If it's an irregular tachycardia, varying pre-excitation, you don't block. Regular tachycardia, you can just temporize. By blocking the AV node, tachycardia will stop. Now notice orthodromic reciprocating tachycardia coming down the node up through the pathway. The RP interval is short, but not as short as AV NRT. Why? Because you still have to come to the ventricle, climb back to the atrium. That takes a finite amount of time. As a result, RP is short, but the P wave is discernible, separate from the QRS. So long RP tachycardia, atrial tach, sinus tach, short RP tachycardia, but separate P wave, think accessory pathway. So this accessory pathway is conducting from ventricle to atrium, completes the loop, and you are getting this orthodromic reciprocating tachycardia. So if you are seeing a ECG, paroxysmal SVT, comes and goes, you got it on the ECG, narrow complex, short RP, but P wave is separate from QRS, you can make a very good guess that this is probably accessory pathway related tachycardia. Immediate treatment, you can just block AV node, it will stop. Drug treatment to prevent recurrence, you can give an AV nodal blocking agent, but young person, you don't want them taking medicines through their life. Excellent results with catheter ablation. Opposite circuit. Here, it's a regular wide complex tachycardia. easily can be mistaken for VT. Just like VT, it's ventricle that's getting activated first. The clues will be heart is normal, younger person, and tachycardia comes and goes. If you terminate the tachycardia, you'll see that delta wave WPW pattern. Without all of that, it's really not possible to tell from this ECG, is this VT or is this an antidromic tachycardia? It's the age, structural, and then upon termination or prior ECG showing pre-excitation will tell you this is just re-entrant tachycardia, except the pathway is conducting antigrade. That is why the QRS is wide. Orthodromic, it was down the AV node, same conduction system as before, so the tachycardia is narrow. That's the difference between these two arrhythmias. This you saw at least 3-4 times during the talks from yesterday and today. This is one you never want to miss. What are the mistakes that happen when people make this? So sometimes they don't recognize the arrhythmia. You just see irregular and you think atrial fibrillation and you think let us start and give something to slow the AV node, whatever that may be, you don't want to do, because this AV node not only is conducting some of the beats, but every beat it conducts makes it more difficult for the pathway to conduct. So if you block the AV node, now you have unbridled pathway activation. You are essentially transferring atrial fibrillation into ventricular fibrillation. That is mistake number 1 that gets made. Mistake number 2 is patient should not leave the hospital without having this treated. And treatment today means ablation of the pathway. This is a mistake. Actually, know of a case, patient had pre-excited atrial fibrillation, syncope, luckily came to emergency room, was recognized, was cardioverted, pathway was found, patient felt well, had done well all their life, so they gave appointment to heart rhythm clinic and discharged the patient. Patient died at home. So should not. This should be something that you recognize you are lucky that you found it, should make arrangements. If you are working at a place that there is nobody to do the ablation, this should be a transfer to get the ablation done. It's one of the opportunities we can prevent a catastrophe in a patient. So before we go to wide complex tachycardia, thought I will pause and maybe do some questions and get some comments from especially all the senior people in the panel and moderators. And then next part, I'll cover narrow complex tachycardia, wide complex tachycardia approach. Yes.
You showed one ECG of PAC, but I saw that cycle was longer than the normal beats. So how do you say that it's premature atrial fibrillation?
Yeah.
The cycle was, to me, was more than the.
Yes, so I think for me, this is a clear PAC. So this P wave looks different and it's early. So this is probably sinus beat, PAC, sinus beat, maybe PAC fusing there. So PACs, why do they produce irregular pattern? Is one is they're coming early, but because they came early, sinus will get suppressed. Earlier it comes, the degree of suppression varies. So it's just glancing at ECG, it looks like there is no pattern.
The second beat.
This I am not sure what this is. This might be a little different. If we look in this, it looks just like sinus peak.
Okay, yeah.
Oh, I see what you mean. That is probably just some marker on the... Sometimes PACs can also get mistaken for bradycardia. The reason is that PAC is so early, it does not conduct to the ventricle. And if you don't see this PAC, you think why the sinus node is so suppressed, it looks like sinus bradycardia. So sometimes it's a mistake that can happen that way as well. Amit, anything else we should point out, SVTs?
When you have this PAC producing pseudobradycardia, which is the drug of choice you take to suppress the PACs?
So question is, if we have PACs, maybe I'll just use this thing here. Are we able to put this up there? So, Doctor, if not, I can just explain, no problem. So, question is, if you have PACs, we want to suppress. And if we want to suppress, you have to use a drug. Now, most of the drugs that we're using, antiarrhythmic drugs, they may have an effect on the sinus node. So if sinus node is going to get suppressed by the drug, even though you got rid of the PACs, you're left with the same issue. So we have to pick a drug that, it's all right, it's okay. No, I'm answering without, it's okay. I'll give this back to you. So there, if we just look at the list of drugs, we have beta blockers, calcium channel blockers, sodium channel blockers, potassium channel blockers, and other drugs. Beta blockers and calcium channel blockers usually will suppress sinus more than the PAC. So very difficult to use. Sodium channel blockers can be tried, but all sodium channel blockers can depress automaticity in the sinus node as well. So little bit tougher to use, but can be tried. You just have to see. How I choose, is it okay to use sodium channel blockers, is I see patients' age, and when they exercise, sinus is very good. It's good to try sodium channel blocker, see if you can suppress like flecainide, propafenone, and usually can get a good result. Older person, reluctant. Potassium channel blockers are the least likely to suppress the sinus node. So of the drugs that can potentially affect automaticity but do not affect pacemaker currents in the sinus node, the best bet is potassium channel blockade. And the pure potassium channel blocker without beta blocker effects is dofetilide, ticozin or dofetilide, and that is usually the drug of choice in this situation. However, modern day electrophysiology, PACs, symptoms, monomorphic PACs, ablation is a good straightforward thing. Is that your practice also, Narasimhan?
No, we are a little more conservative. We try drug therapy one after the other.
Yeah.
And if it doesn't work, ablation is the last resort.
Yeah. Ashish. Yes, so question is, you are born with this accessory pathway. Why we get problems sometimes? What are the age-related changes? So first is, pathway can be sometimes easier to see as we get older on the ECG. Sometimes it can go away, completely go away with age as well. It depends on the AV node and the pathway degeneration itself. So as we age, if just like atrial myocardial tissue changes with age, this pathway also changes, maybe it will not conduct as well. But if AV node is getting more affected with age, then pathway activation may be clearer to see. And here, as we get older, we also get AFib, becomes a problem. In terms of why we get tachycardia only after some time, AVRT, that is tachycardia related to AV node and pathway, is not only about pathway and the AV node, it's also the intervening tissue, the atrium and the ventricle. If that tissue is normal, the circuit is too fast to maintain tachycardia. So something has to slow. And with the right amount of age, wear and tear, that slowing is little bit in AV node, little bit in pathway, but maybe the atrial component. And that allows this tachycardia to start. And that is why you notice when people start getting it, they get it more and more and more and more. All the critical elements of slowness have already started to get established. Yes. What's that?
Patient pre-excited AFib. AFib. We do the pathway ablation. Have you ever looked into what happens at the atrial fibrillation on them? Does it recur? What is happening? We just do the pathway ablation only.
No, it's okay. It's one of the early studies done by Karen Beckman and Paul Gillette was to ask this question. We have AFib and pathway. If we ablate the pathway, will the AFib go away? And in their study, it was very clear that if you ablate the pathway, the AFib is not an issue. And that is what we have taught, we have learned. However, in the older age group, it's a little different. Sometimes what happens here, they had a pathway, didn't bother them for many years. Then they get to the age group that they get AFib, and then we see AFib, oh, there is also a pathway. Some of the clues here is it's not so fast, and it's more behaving like AFib. There is hypertension, there is something else. Those patients, just ablating the pathway is unlikely to help with the AFib. Doesn't mean you have to ablate the AFib, but you should at least tell the patient probably will still be there, may need to manage one way or the other.
So I have two questions. One is, what are chances of recurrence after catheter ablation? And another is, how will we manage it if there is a recurrence at all?
Okay. So just one question for you. Are you an EP person or?
No, sir.
You're a cardiology?
I'm a physician, sir.
Very good, excellent. No, I just wanted to make sure I gauge the answer accordingly. So very important question patients will ask. If you do this ablation, what is the chance of recurrence and what is the game plan? So it really depends on the arrhythmia. So when you counsel patients for AV-NRT, for most pathways, for typical flutter, for one focus PVC, one focus PAC, atrial tachycardia, the chance of recurrence is very low, maybe less than 5%. In fact, sometimes it's even better than that. So most of the time for those arrhythmias, we say, you are born with it, it is here, we are going to ablate, it's gone. But like anything in life, sometimes catheter moved or we could not map properly something, it's in some location. Some patients it will come back, and most of the time with the second ablation, you will be done. There are always rare cases, but most of the time you can quite confidently reassure your patient for those arrhythmias. Other arrhythmias is very different. If arrhythmias change, it's multiple sites. Fibrillation, we don't know how to map fibrillation. We make guess like pulmonary vein, like that. Ventricular fibrillation, polymorphic VT. It is only a palliative type procedure. You're helping because whatever else you tried did not help much. We ablate and try to make it better. And for recurrence, we have to tell might need another ablation or might need medical therapy along with other ablation or pacemaker-based treatment. So it's really rhythm-specific, the chance of recurrence. Okay, so maybe we'll just spend some time with second most common question. Cardiologist trainee gets asked by emergency room, clinic, referral, is wide complex tachycardia, ECG, what is it? We also heard some nice discussion about this. I'll try to summarize in a simple format that's easy to kind of carry around with your mind. We talked yesterday about golden rule of EP. Remember golden rule of ECG? It is very simple one. If electrical wavefront of activation is moving towards the positive electrode, you get R wave, positive wave. If it is moving away, you get an S wave. What does it mean? We must know where the positive electrodes are. Lead 1, left arm. 2, 3 AVF, the feet. All the chest leads are positive electrodes. And then when we look, we try to understand where is this wavefront starting from. So you look at some leads like V1, it's positive. Positive means moving towards. How do you move towards the right? You have to start from the left. So origin is on the left side. Where exactly? Look at lead 1, left arm, somewhere near there is no positive at all, immediately moving away. So very close to wherever that electrode is the start of this wavefront of activation. This case, it is a pacemaker. Another day, it may be VT exit. Another day, it may be a accessory pathway. Same way of making the diagnosis. Now, we apply this when we look at wide complex tachycardia. The same intuition we apply when we look at wide complex tachycardia. First thing is, why is a tachycardia wide? Why is the narrow beat the expected in a normal heartbeat? It's because of our magical conduction system. Our special conduction system not only divides into the right and left bundle, but the bundles themselves divide into hundreds of exits to the ventricular myocardium. So that single beat, literally hundreds of areas are getting activated almost at the same time. And as a result, we can complete the whole depolarization of the ventricles within a short period of time, and that gives rise to the narrow QRS. So narrow QRS requires conduction system, normalcy, and use to be a narrow beat. If this breaks apart, either because conduction system is abnormal, bundle branch block, or the beat itself is starting from the ventricular myocardium, or there is an accessory pathway bypassing the conduction system, then the beat is no longer wide, is no longer narrow, and you get wide beats, and the tachycardia that's using this will be a wide complex tachycardia. Now, the QRS is not just wide, but a little different in each of these. In bundle branch block, because the early activation is the normal conduction system, the first part of the QRS, when it's bundle branch block, will look normal. It will be sharp, quick. Later part is all ventricular activation because the other side bundle was not working, and that looks abnormal. So the QRS is wide, but when you visually look at the QRS, first part looks okay, second part looks bad. That's a clue to bundle branch block as the mechanism of the wide complex beat. It's the exact opposite of accessory pathway. Remember delta wave? The first part is abnormal, later part conduction system catches up, so looks normal. So beginning abnormal, pathway, later part abnormal, you think bundle branch block, everything abnormal, you think ventricular myocardial source, PVC VT. So what are some of the clues? So some of you as clinicians should just remember a few simple things before you look at the ECG. Wide complex tachycardia, always think VT first. Always think VT first. The wider the QRS, the more likely it's going to be VT. This is even before you look at morphology, anything like that. Starting point should be like that. I think wide complex tachycardia is VT. I think the wider it is, the more likely it is VT. But then you look at various other things for you to recognize that maybe this particular case may not be. Second is, it's sometimes said, I believe it was Masood Akhtar who came up with this, he said the best diagnostician for wide complex tachycardia is the patient. You can ask the patient, is your wide complex tachycardia VT? And they will give you the correct answer. Except you have to ask the question slightly different. Have you had a MI, heart attack? Have you had heart disease, valve disease, or myocardial disease, cardiomyopathy? If there is structural disease, if there is prior infarction, most likely wide complex tachycardia will be VT. So once we have that in our mind, our starting point is VT. Next, structural heart disease, we are thinking VT. Then we look at 3 or 4 very simple things. One is axis. Axis is very easy to calculate. You know, we look at just lead 1 and lead AVF. If we have that scenario that lead 1 is negative, AVF is negative, this going upward and towards our right shoulder, it is very difficult to get a conducted rhythm that will produce that axis. So you see that axis, 1 negative, AVF negative, that by itself you can say this is VT. So this is that so-called northwest axis. Very, very few exceptions. Most of the exceptions are very rare forms of congenital heart disease. So just this, if you see, this is something you can make the diagnosis on. Second, very simple thing is count the P waves if you can see the P waves. Most of the time it's hard to see, but if you can recognize that there are P waves, sometimes there, sometimes not there. More QRS than P waves, VT. More QRS than P waves, it's VT. So these, if you have, you are able to see, you will recognize. And actually, we sometimes don't recognize because we don't look hard enough, have to look at little bit longer strips. Sometimes you will see 2 people arguing on the morphology, everything. Is this VT? And then you look a little longer strip, P waves, more QRS than P waves, it's VT. More subtle and not so easy to make a diagnosis is when you look at some beats that look narrower than the wide complex beats. So narrower than the wide complex beats. This can have many reasons, but if those narrower beats are always coming little earlier are the narrower beats, it's possible that what you have is fusion from conduction. So if conduction is fusing, what is it fusing with? Has to be a VT. So that is the idea. This is not as sure as the first 2. Northwest axis, more V than A, more QRS than P wave, VT. This one, you think, looks like we are dealing with VT. Not so easy to see, especially on a 12-lead ECG. Second is, you remember, those of you who are here yesterday, I made a point to say that all the chest leads are a little closer to the apex than the base of the heart. Most of our chest leads are closer to the apex than the base. What this means is, when there is origin of arrhythmia at the base, the chest leads are all positive, going towards the apex. Leads are apical, starting at the base, going to the apex, positive. You start near the apex, moving away from the apex, chest leads are all negative. How does this help? It helps because if they are all negative, even V6 is negative, starting near the apex, this is VT. Why? Because our conduction system does not go all the way to the apex. It starts activating the ventricular myocardium approximately 2/3 the distance to the apex. So has to be some R wave going to the apex, has to be some R wave in some chest leads when it is an SVT that's conducting through the bundles. Doesn't matter if it is right bundle or left bundle. Both of them don't go all the way to the apex. So already they started getting activated somewhere near the middle. So going towards the apex, you have to get some R wave. So all the chest leads are negative, you think apical VT. What if all of them are positive? Same argument. All positive means starting near the base. And if it's starting near the base, conduction system never exits to the base. It always, normal conduction system goes at least halfway. At least halfway. So means all are positive means basal activation, that is almost always VT, rarely it can be an accessory pathway. So what this means is it gives this idea that concordance, all chest leads positive, all chest leads negative, it is not the conduction system. If it is not the conduction system, it's almost always going to be VT. One exception we have to remember is younger person, pre-excitation, antidromic tachycardia. Because pathways are usually near the base, you will get this concordance that's positive. Now, up to this point, I would say it is rare that you have not already made the diagnosis. So what do I mean up to this point? You have talked to the patient. Do they have structural heart disease? You have seen how wide the QRS is. You looked at the axis. You looked for P waves and counted more QRS or more P waves. Maybe you saw some fusion beats. You looked for concordance, all positive, all negative chest leads. And by now, most of the time you can make up your mind whether this is VT or not. It's actually not common that by now you will have clarity in the diagnosis. But you can also look at a few other simple things. So one is bundle branch block has got a very specific pattern. You will have in right bundle branch block, you will have two R waves and the intervening S wave will reach the baseline, coming back and then going up. This is typical right bundle branch block. Everything else, so you see whole thing is positive, or if you see first one is very positive, S wave is tiny or not even becoming an S wave. All of those things should make you think VT. So it is not just right bundle like, is it exactly looking like right bundle branch block or not? Like this, cursory look may say, oh, looks like right bundle branch block, but not at all. Here first is very tall, S wave never reaches the baseline. This, the suspicion of VT will be very, very high. Now we talked about concordance. We said because conduction system is not at the base, it's not entering or exiting at the apex, if you're all positive means basal activation, it's not bundle branch block. If it's all negative, it's apical activation, it's not bundle branch block. But what if you don't have concordance? What does that mean? Some leads have got R wave, some chest leads, some have got S. Some lead will have R and S. Some lead will have R and S. There is no concordance. Now, it could be bundle branch block. Remember, bundle branches are exiting not at apex, not at base, somewhere in between. So, chest lead can have going towards and going away, and you get RS pattern. But VT doesn't have to be at apex, doesn't have to be at base. It can be in between also. So, if you have concordance, it's very helpful. If you don't have, you can still make the diagnosis in the vast majority of cases. There, you know some lead is going to have R and S. Because if it's all R or all S in all the leads, it's concordance, already VT. If there is RS, then you make a simple calculation. Look at all the leads that have the RS and start from the onset of the R wave and measure the time, the distance, to the deepest point of the S wave. Remember, 3 small boxes are 120 milliseconds, so if we are getting close to that, more than 100 milliseconds, from the start of the R to the end of to the nadir of the S, the deepest point of the S, start of R to deepest point of S, if you measure and it is more than 100 milliseconds, it is very likely to be VT. And the more it is, the more sure that this is going to be VT. Now you may have RS in many leads, 3 leads, 2 leads. You measure and the longest interval is what you'll use. Start of the R to the depth of the S, more than 100 in any of those which have an RS is VT. So in other words, if you see concordance, you can make the diagnosis. Concordance, VT. If you don't have concordance, you can still make the diagnosis. You look at the RS and make this measurement and see if in any of them it is more than 100, you are very likely to be dealing with VT. This is the method. Most common mistake is somebody will measure from start of the R to the end, the whole duration. That is not what we're measuring. That's always going to be more than 100. It is from start of the R to the deepest point of the S. So very easy one to diagnose, but if you use this criteria, it's not concordant because some are negative, some are positive in the chest leads. That means somewhere it will be both R and S. You find that, make this measurement more than 100, think that this is VT. One more. So by now, if you think, you are almost certain in your mind what your diagnosis is. As a general cardiologist looking at the ECG, talking to the patient, you will have a diagnosis, probably much before this point. But beyond that, some people like to look at one lead. Can you make the diagnosis of VT, SVT with one lead? The answer is yes. You can make it actually looking at any lead. But one special lead is AVR. AVR is a unique lead because the axis of the lead is the axis of the heart. So when we look at AVR, it's like in this line. And if you look at the barrel of the heart, especially the left ventricle, it is in line with AVR. So we make use of this to make the diagnosis. Now I told you when we have the bundle is conducting. So if right bundle is blocked, left bundle will conduct. If left bundle is blocked, right bundle will conduct. But always somewhere in the middle, 1/2, 2/3 the distance. Now when that breaks out into the ventricle, so imagine you're coming down the bundle, you could not come out near the base because insulated bundle. Much before the apex you come out to the ventricle. Now you have a choice. That wavefront can go back towards the base or it can now move to the apex. What does the human heart do? It always goes towards the apex. The quality and number of the Purkinje network is much better towards the apex than towards the base. In fact, when you get to the annulus, many human hearts, there is no Purkinje network. So once you break out, you go to the apex. That means from our golden rule, AVR, if you go to the apex, moving away from AVR, the initial deflection will be negative. Initial deflection will be negative. So AVR initial deflection negative is the expectation with bundle branch block. On the other hand, if you have an apical VT from the far lateral LV, you move towards AVR from the beginning. So AVR initial positive can close your eyes and say this is VT. But VT may arise from the base, near the septum, near the breakout. In other words, VT may arise in such a way that initial will be negative in AVR also. If initial positive in AVR, it's VT. If initial negative, maybe VT, maybe SVT. What's the difference? When it's conduction system, it's quick, so initial deflection is sharp. When it is VT, it is slow. So if you look at SVT, bang, quick deflection away. But slurred, notched, taking a long time, that is more consistent with VT. You always want to compare. Even if it is very funny looking type of pattern, but the conducted beats in sinus rhythm are matching the pattern, it's probably conducted arrhythmia. So always want to compare with sinus rhythm. If there is WPW there and you had antidromic tachycardia, it won't be any difficulty for you to make the diagnosis knowing the pattern in the ECG. So if I have to just summarize, it is not difficult if you take an approach. Your mind should first of all start by saying, wider the QRS, the more likely VT. You have to prove yourself wrong. Structural heart disease is VT. Then you look and see for easy diagnosis, northwest axis, more QRS than P. Maybe early beats that show fusion. Concordance, VT. Then you look little more difficult if you're still not sure. No concordance, look at RS, make the measurement, more than 100, from start of R to end of Q, you have your diagnosis. How typical is it like bundle branch, or is it different? Compare with previous ECGs. Very, very rare case that you will at least miss an obvious diagnosis. Few things I will say about few patterns when you look at VT for the general cardiologist. Yesterday I went over this very important pattern. V1 negative means starting near V1, right side. 2-3 AVF negative, a positive, strongly positive, moving towards the feet, starting from the head. Closest part to the head for a ventricle is outflow tract. This is the one VT that routinely happens in normal hearts and is generally benign. Generally benign. You don't put ICDs. You don't think of preventing sudden death. Treatment is for symptoms, either drugs or ablation. Always exceptions that the ECG will teach you. You finish the VT, get rid of the VT, and then you look the ECG in sinus rhythm. QRS looks okay, but little wider in right side leads compared to left side leads. T waves inverted in V1, V2, V3. So this is the patient who may have right ventricular cardiomyopathy. Right ventricular cardiomyopathy can affect the outflow tract. So when it affects the outflow tract, you get an outflow VT, but the resting ECG will give you clues that this may not be the benign usual type of VT from the outflow tract, and imaging at least you will want to do to see if there is evidence of right ventricular cardiomyopathy. This abnormal widening in the right-sided leads is what we are calling this epsilon wave. Another pattern I want to show you that is next in importance to understanding that this is a unique VT syndrome. And that is when you have a right bundle pattern, but initial part of the QRS looks normal. Remember, wide QRS, if initial part is normal, we think bundle branch block. Can a VT have the initial part normal? The answer is yes. These are VTs that arise from the conduction system. So this is little difficult to classify. If the conduction system itself is causing the tachycardia, is it VT or is it SVT? It's conduction system, but it is below the level of the His. So we are VTs, but they are unique because nothing is abnormal with the ventricle. The prognosis tends to be very good in most of these patients. And like outflow tract tachycardia, you can either ablate or you can use drugs, often calcium channel blockers, to control the arrhythmia as well. So sometimes called fascicular tachycardias, conduction system tachycardia. The clue will be, it looks almost like SVT with aberrancy, except maybe you saw there is more QRS than P, something else that gave you the diagnosis. So maybe we'll stop at this point, we'll do some questions, anything else that comes up, and if needed, we can show some examples based on the questions. What do you think, Amit Raj? Great.
I think that was an excellent approach to the wide QRS tachycardia, and so a couple of comments, especially for the physician community, is that we make a lot of inference from the ECG in terms of arrhythmias and many other diagnoses. It's very important to take a proper ECG. So lead placement is often a problem, and if you have an abnormally placed leads, you are going to make mistakes in terms of the recognition. So make sure that the ECG lead placement is correct, especially the precordial leads. Often you will find them either too high or too low. V1, V2 is never placed in the fourth intercostal space. That's been my example. Second is the ECG filter setting is also equally important. The default setting which the company provides is variable. Please see to it your low pass and high pass filters are set properly at 0.05 and 150. Otherwise, you are going to blunt some of the waveforms which might appear a good looking ECG but miss out on all the scarring and notching and the epsilon wave or what we are talking of. So I think keep these things in mind while you are interpreting the ECG.
So maybe a few comments about lead placement commonly in case of wide QRS tachycardia diagnosis. Is possible? Great, thank you. So we place the leads with bundle branch block. One of the things we say is right bundle is blocked, left bundle is exiting. So if we are usually having our lead placed normally for V1, you have only a small septal activation that produces a small R, and subsequent activation going all the way back to the right side gives you the big R. But if you put this lead too high, what happens is, even though it's just right bundle branch block, you have more of a vector going towards V1. So actually your first R can be as big or even bigger than the second R in typical right bundle branch block. This is one of the most common reasons why someone feels this is not typical right bundle branch block. The V1 is placed too high. Same thing when we have left bundle branch block. Right bundle exits here, so we don't have septal activation towards the right. So our rule is, in left bundle, you don't have an R wave. You don't have activation across the septum. But same problem, if V1 is placed too high, right bundle exits halfway to the apex, and you have ventricle muscle that goes towards V1, and that can produce an R wave. So R wave in V1, atypical left bundle, atypical right bundle, may be from V1 position, one of the most common leads to malposition. Any questions, including from our fellows, residents? So question is atrial flutter when there is aberration. That means bundle branch block. So same way we think about the QRS. So you think in two ways. What is the rhythm problem? What is the QRS problem? So first we focus on the QRS problem. What is the axis? What is the morphology? Is it typical? Is there concordance? RS measurement. So think about QRS separately, and we say this is fitting with VT or not. If it is fitting more with bundle branch block, then we look and see what is the SVT that's producing the fast rhythm. And then if you see lot of P waves there, all looking the same beat after beat after beat, rapid, you think this is atrial flutter. So the only thing that you cannot do for our diagnostic algorithm is measuring P waves and QRS and saying you have more QRS than P wave. We cannot do that, but because you have so many P waves from the atrial flutter. But everything else that you see in terms of QRS morphology still applies in the same way you would approach it. Ashish, did you have a question?
Maybe this calls for some explanation from your side.
Yes, so if we look bundle branch block, what is the axis? Really, another way of saying is it is not going to start at base, not going to start at apex. So if you get a VT and it is different from that, so it's a totally basal, totally apical, or AVR is first positive, all are ways of looking at the same issue. This won't help if the VT is starting on the mid-septum, but there we can look at the QRS. Is it looking sharp or looking more delayed and abnormal in the initial portion? Initial portion looking abnormal means it's not using conduction system. So either pathway, which is rare, but most of the time will be VT.
The other point for the postgraduates and the clinicians managing wide QRS tachycardia in the emergency room is that obviously we need to look at the ECG and the clinical pointers which we said, but also examination. Don't forget to look at the JVP. Sometimes the Canon waves may be seen in a rapid tachycardia, and you know that there's an AV dissociation. Flutter with aberrant conduction stable, you can give a carotid massage and see what happens to the QRS. Bring in the AV nodal blockage and you can probably see that it's supraventricular rhythm or not. So look at all the clinical aspects also in addition to the ECG. I think you did mention, but once again, this is a practical question many people ask. Wide QRS tachycardia, for whatever reasons, I mean, from what you've told, we should not have any problem now, but as a therapeutic challenge, giving adenosine, because it's such a short-acting drug, are you justified using in wide QRS tachycardia?
Yes, so question is such a short-acting drug, adenosine, you have a regular wide complex tachycardia, is there any harm in using? So most of the time there is no harm, because if it is SVT, maybe block the AV node, you will see the SVT, you will have less QRSS, you can see the flutter waves or whatever else you have missed. Even if it is VT, sometimes you'll see the VA dissociation when you're giving this adenosine. So most of the time it is not a problem. The problem is if the VT mechanism may make the person vulnerable to even transient effects from adenosine. So two situations where this can be a problem is if you have a patient who's been in VT for a long time, already some myocardial acidosis has happened, then you give adenosine and you get some hypotension. That along with the acidosis can put the person in ventricular fibrillation. The other is if this is ischemia and there is both VT and pre-existing coronary disease, sometimes adenosine can produce like a steel and can worsen the ischemia and you can get ventricular fibrillation. So not common, but we should not think it is totally a safe option. When the diagnosis you think a little bit, most of the time you will know. If you're still struggling, just better to think it is VT, treat accordingly, and then regroup, look at the ECG and sinus rhythm.
That is pre-excited tachycardia if you miss atrial fibrillation?
Yes, so definitely if you have young patient, you have very fast, irregular, you have to be thinking pre-excited atrial fibrillation. Those patients, of course, we do not want to give adenosine. Murli, any additional points? It would be great if you introduce yourself also, sir.
My name is Dr. Wasim Rashid. I'm an earlier, you can call me an early career EP. So we had a young boy with pre-excited AF. He presented to us with antidromic tachycardia, which was very incessant. Not shocks. We didn't have procainamide IV available. So the emergency physician gave him amiodarone IV because he was not getting reverted with shocks and he did not have procainamide. So he gave him IV amiodarone and he went into VF.
No, let me stop you there, first of all. So especially for trainees, you have to understand what amiodarone is doing. So amiodarone is a combination drug of beta blocker, calcium channel blocker, sodium blocker, and potassium channel blocker. So simple terms, AV node blockade is beta blocker or calcium blocker. Sodium channel blocker means you slow conduction. Potassium channel blocker means you increase refractoriness. The main benefit in AFib is improving refractoriness, increasing refractoriness. Makes it tough to maintain AFib. However, amiodarone does not do all four of these things at the same time. The temporal profile is very different. The temporal profile is very different. When you give amiodarone, the beta blocker and calcium channel blocker effect is immediate. The sodium channel blockade happens after hours, peaking at 3 days. The potassium channel blockade peaks at about 4 weeks or later. So when you give IV amiodarone, think you are giving an IV beta blocker or an IV calcium channel blocker. So for pre-excited atrial fibrillation, will you give IV beta blocker or a calcium channel blocker? The answer is no. So you do not give IV amiodarone for a patient with pre-excited AFib. If you don't have procainamide, and every time you shock the patient is coming back into the atrial fibrillation, this is a very serious condition. You have to think, can you do ablation very quickly? In the meanwhile, you could also consider a short-acting sodium channel blocker. For example, like ibutylide. Ibutylide can temporize And while you are doing that, you can then start an oral, or if you have IV preparation, a drug like flecainide that can try to do it. But never think of IV amiodarone as an IV antiarrhythmic drug. It is not. It is immediate effect is AV nodal blockade. So any condition you don't want to block AV node, don't do that unless you're really prepared to immediately shock the patient.
The situation was slightly different. He had an pre-excited AF episode earlier and a baseline ECG showing pre-excitation. We knew that he had a pre-excited AF earlier. But right now he came with an ART, antidromic reciprocating tachycardia, which was incessant. And the emergency physician gave IV amiodarone and he went into VF. So
yes, that should be no surprise to you at all. Yeah.
So that IV amiodarone caused hypotension, there was acidosis because of
yes, that's what we just discussed.
Yes.
Yeah.
We have had a wonderful session, and I think in the interest of time, we'll conclude now.
Yes. We thank you, Dr. Samuel sir, for the elaborate lecture on the arrhythmias, and that too in very simple words. I suppose everyone from the audience has now got a clear understanding of the mechanism of arrhythmias and how to approach wide complex and narrow complex tachycardias. I request Dr. Raja Selvaraj sir to again come to the stage as the chairperson, and Dr. Vora sir, Dr. Samuel sir, for the next session by Dr. Gurunath Parai sir on artificial intelligence in ECG. I call upon the stage Dr. Ponde sir as a chairperson. Yeah.
Good afternoon, everybody. May I have the first slide, please? My disclosure, I am aware that Dr. Samuel Asirwatan, the guest speaker, and his team at Mayo are pioneers in the field of AI ECG. I am also aware that I am a toddler in the field of ECG compared to stalwarts sitting in this room. Yet, I dare to talk on AI in ECG. AI in ECG is an ideal substrate which can be subjected for AI interpretation. Why? Because see, normally ECG, this is a ECG which we see, where we can see the PQRST or its minor deflections upon which we can make a diagnosis. As against this, what AI can see? AI can see 60,000 points. Each lead is 5,000 points. I have just displayed here 36 rows, but ideally there are 5,000 rows. So each lead is 5,000 rows, so 12 leads is 60,000 points AI can see, which a human eye cannot. That's what AI can see, we cannot. So that's what it can recognize patterns in this 60,000 points. What is the difference between a computer-generated interpretation versus AI? Take an example. If in a computer-generated interpretation, what we feed the computer is a formula. SV1 plus RV6 equal more than 35, we say LVH. So if an ECG is subjected to computer, it will just measure this and say if it is LVH or not. But we know there are many false positives and many false negatives. As against this, what AI does? In AI, we give it all the ECGs with proven left ventricular hypertrophy on echo and its digital equivalent on ECG. So it itself finds the algorithm, it itself finds a pattern, and itself tells us which pattern is consistent with left ventricular hypertrophy. So it trains itself. This is as against the formula which we feed to the computer. There are very many applications of AI which are coming up, and many studies have come up, some of which I will quote here. The earliest application of AI was for detecting left ventricular dysfunction. And as I said, this study has come from our research lab, that is Mayo Clinic, and where more than 50,000 ECG echocardiogram pairs were used for training AI network to identify low ejection fraction. Identifying low ejection fraction on ECG itself, 12-lead ECG, less than 35%. And they came out with a very high sensitivity and specificity, very high, more than 90% accuracy. Now, to give you an example, now this was ECG which was subjected to AI interpretation, and it said that the ejection fraction was 50%. For AI, and AI told that it was positive for low ejection fraction. So AI said it has a low ejection fraction, but actual ejection fraction was 50%. So was it a false? What did AI diagnose it wrong? 5 years later, the patient's ejection fraction dropped to 31%. Was it what you say, it is a chance, diagnosis by chance, or it was a true detection, an astrology-like prediction by AI? So that's it. So a new concept, a previvor concept has come, where AI can detect a diagnosis, a disease, before it can manifest. So that's one of the examples. This ECG, if we are shown, we ordinary physicians and cardiologists are shown and asked what is the probability of LV dysfunction, I don't think we will be able to tell. But if AI is shown this ECG, it says that probability of having low ejection fraction is 76%, and this patient has an ejection fraction of 18%. So that's how AI can see what we cannot. Now the next application is AI ECG for the detection of silent atrial fibrillation. Consider this example. This was a 65-year-old female. She came with history of CVI in 2014. Holter revealed no atrial fibrillation, so no oral anticoagulation was given. She had another CVA a few years later. Again, Holter revealed no atrial fibrillation. Few months later, she developed AF with fast ventricular rate. Just imagine if this patient would have been detected as a silent atrial fibrillation and would have been anticoagulated, this another CVA could have been averted. See this example. This was the ECG, bottom side, this was the ECG. This ECG, you have pointer? This ECG, done in 2008, showed normal sinus rhythm, and AI showed no silent AF. 5 years later, same patient, normal sinus rhythm, but AI said silent AF present, although there was normal sinus rhythm here. And this patient went on to develop 6 years later atrial fibrillation. So AI detected this atrial fibrillation much before. So if this comes into a clinical practice, and if this patient is anticoagulated, a stroke can be prevented. Now this is a large data again coming from Search Center with more than 130,000 ECGs, and they have predicted silent AF with a very high sensitivity and specificity. Now next application is AI ECG for detecting hypertrophic cardiomyopathy. Again, a large study, large number of SCM patients, and very high sensitivity and specificity for detecting hypertrophic cardiomyopathy. Now example, see this patient, if we are shown this ECG, I don't think by any stretch of imagination we will diagnose this as hypertrophic cardiomyopathy. But when AI is given this ECG, it says the chances of having hypertrophic cardiomyopathy is 72.6%. So patient had hypertrophic cardiomyopathy, underwent surgery for hypertrophic cardiomyopathy, there is myectomy. And after myectomy, when the AI was shown this ECG, it says the chances of having HCM is 2.5%. So what we can't see, AI is able to see. Now this is a female, another example, this is a female, 23-year-old female with syncope. There is nothing actually abnormal, except for juvenile T inversion. I don't think there is anything abnormal what we can detect on this ECG. But when AI was given this ECG, it said that there is 72% possibility of patient having hypertrophic cardiomyopathy. So this was the cause of a syncope in that patient. This is how AI is going to make difference in the management and prediction. Not only AI can detect hypertrophy, but it can tell you the cause of hypertrophy. Hypertrophy, you know, can be because of hypertension, can be because of aortic stenosis, can be because of hypertrophic cardiomyopathy, or it could be athlete's heart. Or it could be hypertrophy-like situation in amyloidosis. So AI can distinguish with a very high sensitivity and specificity what is the cause of hypertrophy purely on ECG. So future ECG report would be like this. Computer generated intervals will be here and AI reporting will be like this. This patient's AI estimated age is 37 years, probability of male is 98%, estimated ejection fraction is 58%, the chances of low EF, hypertrophic cardiomyopathy or silent AF are less. So this could be the future report of ECG. Now, has this been clinically validated? There have been reports. Has this been clinically validated? Yes, one large study, Eagle study, looked at 22,000 patients where AI-assisted ECG was for detection of low ejection fraction, LV dysfunction, and it was found to be better than the primary care. AI did impact in the undiagnosed cases. The second study, Beagle study, is an ongoing trial for anticoagulation in silent AF. I don't think the results are out yet. Maybe sir might be knowing more. There are challenges and limitations which I won't go into detail, but just to give you an example. Now, this is a ECG. This is an overlapping two graphs in this ECG, where you can see this. There is a blue line and overlapping red line. When blue line is shown to AI, it says there is a 99% probability of being a male. You give some vibrations or noise, introduce some noise in it, and subject the same ECG to AI, it says it is likely to be female. So little variation in the data, slight noise can totally make a difference. So you have to be very careful to what input you can give to the AI. It is very useful in some other conditions. Because of lack of time, I won't go into that. It has got approval from FDA for certain applications. Apple has got for arrhythmia, for atrial fibrillation. Medtronic has got for arrhythmia detection, and AliveCore for ambulatory ECG. There have been some FDA approval for that. Now, most of the studies which I have quoted have come from this database. You will see one of the largest database, Search Mayo Clinic, of many years and over 4 lakh patients. You will observe here there is no Indian data. And we don't have anything. Because we are very poor at data keeping. So I said, why not produce our own data? So I decided to take a baby step in AI ECG. I have electronic medical records of over 15 years, all in electronic form. I have ECG data of over more than 1 lakh patients, all in digital format. I have the clinical diagnosis of all these patients in more than 99% patients. I have echocardiography report in more than 90%, at least one echo report in more than 90% of the patients. And I have blood pressure and anthropometric data in more than 95%. So I have not as big a data as Mayo Clinic, but I have a data of 55,000 over last nearly 15 years. So I decided, why not use it? First baby step I took, and I took help of data scientist and gave him to develop algorithm. So the first baby step for 300 patients I gave to data scientist and was able to identify gender with 85% accuracy, that the patient is a male or female. So this is the first step. And with the area under curve was 93.6%. So this was the first step I took. Then I became a little bolder. Then gave more data of around 700 patients to the data scientist and developed algorithm for age prediction. Now accuracy of more than 92% was accurate. So my data could give an accuracy of 92% for estimating patient's age. I became still more bolder now. I decided that I should do something which has not been reported hence before in literature. As you know, left bundle branch block has 3.2 per 10,000, that's its prevalence. And identification of heart disease in left bundle branch LBB is not very easy. Some of them are normal, some of them have ischemic heart disease, some of them have LV dysfunction. But if we, it needs further investigations. So if AI can help me to tell a particular ECG of left bundle branch block, whether this is a near normal, a benign left bundle branch block, or whether the patient has heart disease. So I thought, why not try this? I had 317 patients of left bundle branch block who had undergone echocardiography and coronary angiography. Of 55,000 patients, 117 patients had obstructive coronary disease on coronary angiogram. 97 patients had LV dysfunction and their coronary angiogram was normal. And 103 patients, their echo was normal as well as their coronary angiogram done. And this was something done. I don't know these terms, this computer jargon, I don't know. I just gave this data to the data scientist and he came out with this result. Yes, we were able to identify with 81% accuracy in detection of heart disease in left bundle branch block. It could be LV dysfunction or it could be coronary artery disease. And area under curve was 83.7%. So this was it. Maybe this sample size was very less, around 300 patients, and maybe larger sample size might make it more accurate. Of course, this little study would not have been complete, but for the help of the data scientist, Mr. Anuj Mehra from Lupin Digital, and my company RMS engineers who did digital conversion of my over 1 lakh ECGs. I know this is a very preliminary study. It is not a large study like search study, and this trial needs to be validated with external data, some other data, then only we can move forward. Thank you.
Thank you. Thank you very much, sir, for such a nice lecture. Can you please start that mic?
Parade, sir.
In a place like this, to do this kind of a study needs tremendous amount of commitment and passion. So thank you, Parale.
Gurunath, one question. This AI has a very large database. They're very sensitive. You're not going to get over-diagnosis and some people put wrongly on anticoagulation. Will not happen because it's 85%, 90% accuracy.
So that's what there are many challenges and limitations. The type of input you give, sir will be able to tell you better on these comments. The input which you give, if you give a homogeneous input, your data analysis will be different. You have to, suppose if you give only certain type, a particular race, particular gender, particular age group, then it might come out with the outcome which is that may not be applicable to all age groups, all race. So you have what data you provide with AI, that's going to give you the results. So you have to be very careful what input you give.
That. And second thing, if this AI can detect AF in a stroke patient much earlier, will it replace the Holter of long time what we are doing today?
Maybe sir is the best person to answer this.
Holter for 7 days, 20 days or what we are doing actually. It will be a replacement for that. Much easier than.
I request Dr. Samuel sir to have comment on this.
So just generally speaking, it's very important few things that you heard. ECG, why so much focus in cardiology on ECG for AI? Why not echo? Why not so many things? It is mainly because we have data. So like here, if somebody has saved the digital ECGs, and if we know outcomes in the patient, it makes it possible to do an algorithm, create an algorithm and test it. So other types, we don't save that much for so many years. Pulse ox, other things that we have recorded, we don't save. And other things that we save, like laboratory tests, we don't have digitized type data. We have to input in some kind of spreadsheet. So that's why ECG is at center of AI in cardiology and indeed AI in medicine. But just few comments I'll make. One is it so much depends on the validation of the clinical endpoint. So you can have thousands, millions of ECGs, but if you're trying to diagnose an entity and the entity itself is subjective in its diagnosis, then it's not a good project for AI. Because your validation, what you're doing is human, and all that human error, you are burdening the algorithm. It is very difficult for it to somehow see through. So the best algorithms are hard endpoints: mortality, need for cardiac surgery, effort tolerance, ejection fraction. The more objective the endpoint can be, and the more number you have of the ECGs, the better the algorithm is going to be. Very important what was mentioned, that you need from multiple countries, you need multiple different types of data, because an algorithm only is created for a database. It cannot be extrapolated automatically to all human population. It is for that database. However, there are some improvements in AI that probably we should be aware of that make it much easier for future investigators to work in artificial intelligence in cardiology. Two of them. One is transfer learning. Transfer learning, first from Google, called BERT program, B-E-R-T. Now multiple programs are available. Transfer learning comes from translation work for AI. When we speak in one language and we want to translate to another language, first artificial intelligence has to learn the mother language. Like you want to go from English to Hindi, you must first understand English very well. What is the next sentence going to be? What's the next word going to be? It learns that pattern. And then when it was applied for other languages, surprisingly, the patterns are the same. So even though the words are different, the pattern of what type of word is likely to come is very, very similar. As a result, when learning the second language, you needed much less data. Some transfer of knowledge came from first language to the next. So if one database is already established with hundreds of thousands of data points, to learn the second disease, the second endpoint, requires less data. This is for only this last 2 to 3 years, transfer learning. Second innovation is diffusion AI. Diffusion AI has completely changed how AI you look at in cardiology. Diffusion AI uses large databases that are across countries, continents, age groups, everything, to just create patterns. So diffusion AI starts with the notion that everything is noise, and then when it starts seeing a pattern, it subtracts the noise and says, where does this particular data fit? So if you show a picture of a person you want to tell, you have history and knowledge of person's physical features all over, it just quickly picks the match and says this is the likely things. So this takes away bias. That is the beauty of diffusion AI. It takes away the bias of individual data sets. And final thing is generative AI. Generative AI is a very interesting application in cardiology. It is not predicting. Basic AI, what Apple did was very simple. Can you diagnose AFib? But you and I can diagnose AFib. There's nothing in that. Second level is what you just heard. Can you predict something that's not diagnosis but about to happen? AFib on another ECG, for example, ejection fraction. Generative AI generates the next imaging stream. That means you take the ECG and you generate the echo, the still frame and the video grab of the echocardiogram. So it is not a report, hypertrophic cardiomyopathy 72%, male 30%, ejection fraction 5%, it is an image. So this is kind of like a generated image, and it gives rise to a lot of possibilities on how we will use this. How is it different from the actual image? When can it be used in lieu of this image? So AI itself is an evolving field, and as you get into using it for creating and looking at databases anywhere in the world, have to also think about what is the best AI for the project at hand.
Just one question, could I ask, please? Yeah, here. You know, first of all, my compliments to you for such an interesting talk. Now, we have been recently a lot of talk about AI. Is it a monster that will eventually destroy the civilization? The need to curb it. You mentioned a very nice statement that it can predict 97 to 100% the sex of the individual. Imagine now we can even do fetal ECGs. And now with the fetal ECG, you can predict whether it's going to be a boy or girl. It's going to be a headache for the generations because already we are having these PNDT issues. No, these are facts which we cannot ignore. And so that's why even tomorrow, anyone can take a ECG. You cannot curb. So imagine if this thing is being done and then you can say, well, this is going to be a girl and well, you know what can be the outcome. So I don't know at what direction we are going.
Gurunath, can I add a comment?
Yes.
This is really interesting and charming, and what's going to be the future in cardiology. But at the same time, I feel that we were all lucky that we had the joy of learning and we had the joy of teaching, right? With AI coming in for the next generations, it will all probably depend on machines. And the sheer joy of learning and teaching individuals on a one-to-one basis may be lost. There's one. Second thing I want to know is what are the ethical and legal issues that US may be facing with the use of AI, particularly in the echocardiography machines that we have AI integrated now. So do you see that coming, ethical and legal issues?
So, first issue of will the joy of learning change? I don't see why that should be the case. See, it is just like any technology. We were experts with stethoscope. I remember in my medical school days, I was obsessed with the stethoscope. Everything was this. I would hang around all the wards. I would go from Vellore to Madras, look at all the things. And then echocardiography. Did it destroy our love of cardiology? No, I don't think so. It's a different love. You diagnose, you see there is a new differential diagnosis, there is new nuances. How do you apply? It changes. That's all. So same way, this is like another tool that we use and say, here is something. And like any tool, we have to validate, we have to do studies, and we understand from those studies what are the limitations. So I would not see it as a fundamental difference in the evolution of any scientific endeavor. In terms of legal issues, the FDA in the United States had a task force in 2021 looking at this issue of how will we use AI diagnostics and therapeutics in medicine. And basic way that FDA has taken is they are treating algorithms as a device. So very similar for FDA approval of device, they are using for algorithms. So they have minimum criteria. How was it validated? Was it tested at another center? And if so, you have to get FDA approval for that algorithm. So right now, very few predictive algorithms are FDA approved. The ejection fraction is approved. The potassium, very high range, is near approval. Amyloidosis and hypertrophic cardiomyopathy recently got approved. So it still has to go through the approval process. So if a physician is using, if it is approved, it's like any other approved test. You don't have any new legal liability. If it is not approved, it is like any other off-label. You have to explain why are you using this in your decision making.
Yeah, can I just make a comment? Yeah, compliments for your study. As Harari has already said that tomorrow's computers are going to know more about you than what you know about yourself. So that's already true. My questions are twofold. First of all, when you convert your analog ECGs to digital ECGs, as you have done, you said.
No. They were recorded digitally only.
So it was only digital?
Digital ECGs.
That answers my question. The second thing is, what was the accuracy of age prediction? Was there any range? I mean, when it predicted the age?
Age?
Yeah, age prediction.
93% accuracy. 93% accuracy.
Accuracy means, was there any range, or it hit the nail right on its
The data the ECG data which was, the input data was from 20 years to 67 years. That was the age group which data was, 600 ECGs odd were given.
The reason I'm asking is, in other studies on this, the age range was about plus minus 7 years.
I just wanted to ask, Dr. These 50,000 ECGs, all the ECGs were sent to the AI lab?
No, not yet. Now this is just a sample data that I have sent.
From where they got the data?
I have all these ECGs.
You have given the ECG of 300, 400 patients.
No, I have more than 1 lakh ECGs with me. I have more than 1 lakh ECG. Minimum 1 lakh, at least I think it is 1.5 lakhs, but minimum 1 lakh.
I think for study, maybe whenever we complete the data, first all the data have to be fed to the intelligence machine. Then there is a validation process, and then
there is first a test. Sir will tell better. First we have to give a test, train the model, come out with algorithm, then you have to test another give some more data, again improve upon the model, improve upon the accuracy. Sir might explain it better.
Because the data from Indian patient may be different from the data of international patient. That's what I'm asking for, whether this data has been created in India, then the testing has been done on the same data.
Yes, so the algorithm is only going to be based on the data. So if it is all Indian patients, then you can only say that algorithm, unless tested somewhere else, is for that type of cohort, like patients in India. But having said that, there isn't as much difference when we look at AI prediction of most conditions across ethnic divides. There is a difference in hypertrophic cardiomyopathy, but the others, everybody, including ourselves, we thought there will be a lot of difference. There is less. And I think the reason for this is, in the United States, there is no pure race. Everybody has, got some mixture. So because of this, I think countries which have a lot of this mixture, we are likely to see not too much difference. But if you develop with a database like Dr. Perel, then it is very important that we do a cross-test. So you'll have 3 stages for algorithm. Teaching the algorithm, so you give an endpoint. This is male, this is female, this is EF. And then you make it to learn. Way that it is learned today without generative AI is just you input the ECG, and then output layer is going to be the endpoint you say. With generative, the algorithm fights against itself to figure out which is the correct answer, teaching itself of how you can diagnose this final endpoint. So less dependent on validation. Once it is learned, then you have a test cohort. So you don't tell it the result, you say, tell me the result, and you compare with the result, and that gives you your AUC for accuracy. Then the third is to take the same algorithm, but put a completely different cohort. So then to see what is the difference. And it has to have all 3 before you say you have an algorithm that you can approach the FDA for approval.
Yes.
Thank you. Thank you very much, sir, for such a nice lecture on AI. Sir, please be on stage. I would like chairperson, I request chairperson to felicitate Dr. Parade, sir. Dr. Ponde, sir, felicitating Dr. Parade, sir. Thank you, sir. Thank you very much.
I thank all the chairpersons for the extensive sessions and the discussions regarding the AI in ECG. So it was a valuable learning for all of us. Like we have now the glimpse of what the future will be. So we'll move on to our next session for the didactic lectures. May I call upon the stage Dr. Sambhaji Raut, Dr. Mehul Rathod, Dr. Jai Bharat Bhalke sir, Dr. Bajrang Dubey sir as chairpersons for our didactic lectures. Dr. Dubey sir, Dr. Jai Bharat Bhalke sir, Dr. Mehul Rathod sir, and Dr. Sambhaji Raut sir.
I request all these doctors to come up on stage, please. Dr. Sambhaji Rao, Dr. Mehul Rathod, Dr. Bhalke, Dr. Dubey. I request Dr. Satish Godse, sir, please come on stage as a chairperson. Now there will be some quick 10 minutes lectures by Dr. Shomu Bora, Dr. Ashish Nabar, Dr. Raja Sevilraj, Dr. Rajesh Dhopeshwarkar sir. So next half an hour will be like for ECG markers for sudden cardiac death, which will be covered by Dr. Shomu Bora. I request Dr. Yatin Zok sir, as a chairperson on stage. Dr. Yatin Zok sir, please. And I request Dr. Shomu Bora sir for ECG markers of sudden cardiac death.
With permission of chair, it's an honor to be here. And after the stimulating talk on AI, I think my job is either easy or more difficult, I don't know. Before the AI takes over, let us have an intelligent way to discuss ECG markers of sudden cardiac death. So based on the current findings, the risk is depending on, the cardiac risk is based on ECG, echo, functional class status, the etiology and the genetics. And we are about to see what about the ECG. So if you see this ECG, this is the highest risk for sudden cardiac death. What does this ECG show? It's ventricular fibrillation. So no guesses on that, highest risk. Are we concerned about this patient? Yes, we are concerned, but you don't need to guess, right? So the scope of getting these markers right in sudden cardiac death would be in a normal patient or in a person who is least symptomatic. So we'll not discuss about arrhythmias, we'll not include acute ischemia, we'll not include the accessories that go with the ECGs. So we'll limit the ECG risk assessment to non-urgent settings basically. Any pattern that is not normal keeps the patient at a higher risk. That is what I would say, and I can end the talk saying this, it's done. Because anything that is not normal suggests some disease, and that means the patient is at a higher risk, right? So non-myocardial ischemia related can be HCM or cardiomyopathies or channelopathies, or coronary anomalies per se. So any change in the PQRST, ST intervals, anything is a marker. So what we would like to go in the next 7 minutes would be ECG with an abnormal echo, which may be a prior MI or a non-MI situation. In a normal echo, where the echo says everything is normal, but the patient has some symptoms or a family history. And last but not the least will be a person who has no symptoms, echo is normal, and no family history. So going into the first part, the ECG has an abnormal with an abnormal echo and a prior MI. So old MI patient in whom you have a higher risk would be patients who have wider QRS, fragmented QRS, left bundle branch block as compared to a narrow complex or a right bundle branch block, persistent ST elevation, QT prolongation, T wave inversions, or Q waves which are more in the number of leads, suggesting a higher scar burden or a higher degree of ischemia. So in this ECG, if you see, the QRS is wide, there is LBBB, the PR is prolonged, and there is a notched QRS. While in this ECG, just a prior MI, you can see that without chest pain also, you can say that this is a high risk because you have a poor R wave progression or absence of R waves, persistent ST elevation, the QT is prolonged, and there are T wave inversions. For a non-MI echo abnormality, the parameters may be slightly different, but basics is presence of scar. So a low voltage limb bleed or a strain pattern with the LVH or RVH, wider QRS signifying scar, fragmented QRS or abnormal waves, poor R wave progression or abnormal Q waves suggest high risk, presence or absence of arrhythmia definitely. So if you have a patient with biventricular dysfunction and you have this ECG with very low voltage, definitely it is a high risk because this signifies that the myocardium is not there. Or if you have a patient with LV dysfunction, you have LBBB, with that you have PR prolongation and a right axis deviation, it also signifies very high risk because that signifies a significant amount of disease. A patient with palpitations and you have a fragmented QRS, STT changes, the axis is not very clear, again signifies high risk. A patient who presents with acute symptoms and the patient has abnormal Q waves, sinus tachycardia, bundle branch block and STT changes, that again signifies high risk. So higher risk patients in structural heart disease would be very low voltage complexes, suggest less myocardium and biventricular involvement, low voltages in presence of hypertrophy, suggest fibrosis, broader QRS with significant axis shift signifies that there is a conduction or peripheral involvement, and fractionated QRS or an abnormal Q wave suggests there is scarring. So there was a study by Strauss et al. Who used the QRS score which included the Q, R, S wave amplitudes, duration and notches, and they implemented a scoring system and they said whether there is presence or absence of scar based on that scores, which correlated well with the clinical scenario on echo and even on MRI. Now in patients who are symptomatic with symptoms but the echo is normal, what we see is these clinical scenarios, WPW, long QT, Brugada, short QT, so channelopathies basically, and the presence, the initial part of a cardiomyopathy. So if you have a patient with pre-excitation, short PR, delta wave is there, the high-risk patients would be patients with a posterior or a septal pathway, multiple pathways, pre-excitation at higher heart rates, or syncope history if it is there, or age less than 35 or a male gender. Patient who, this is a ECG with a long QT, and if you have a QT prolongation of more than 480 or even 500, it is a high risk, but a presence of T wave alternance along with that signifies very high risk. Short QT less than 320 milliseconds or a Brugada type pattern type 1 rather than type 2 or 3 signify higher risk. Now a word about patients who have early repolarization kind of ST-ARP. If you have that pattern in the inferior leads, more than the lateral leads, there is a 2 millimeter more elevation after 80 millisecond, which is downward or horizontal, that is at a higher risk. So presence, the main scenario that we would see would be no symptoms, no family history and a normal echo, and this is the bulk of the population. So if you have this kind of ECG, which shows T wave inversion in an asymptomatic individual, you see that where the T wave inversion is there, how much the QRS has changed. So the criteria for abnormality in a normal echo, no symptoms, would be a QRS duration more than 110 milliseconds, which is interpreted from leads 2 or V5 in most of the studies. The QRST angle, that difference between the QRS vector versus the T wave vector is more than 100 degrees. A QTC interval which is more than 440 in males and 460 in females. Presence of left ventricular hypertrophy. Early repolarization, either 1 millimeter or 2 millimeter in height, and presence of T wave inversions which are more than 1 millimeter deep. And this is a Finnish study that was done which showed that when these patients were followed over 10 to 30 years, these abnormalities did suggest the chances of having a sudden cardiac death over a period of this time. So if you see the QRS abnormality, a duration of more than 110, the QTC interval which is high, and the T wave inversions were at the highest in the multivariate analysis. And if you see at just any one abnormality present increases the risk. What about 30 years, and what about more than one abnormality? So if you have had more than one abnormality, that is 2 abnormalities of the phi, then the risk is very high. And if you follow it over 30 years, both, even one abnormality versus any 2 abnormalities would be at high risk. So the rationale is, more the QRS duration, the chances that your risk is higher is because there is conduction delay either, or because there is a myocardial disease. The QTC abnormality signifies that there is either a genetic or a structural abnormality, and also the value of the T peak to the T end, if it is more than 100 millisecond, has been signifying a dispersion. LVH promotes fibrosis, arrhythmia, and increases ischemia, and that is why it is at risk. Abnormal QRST angle also suggests likely to be myocardial ischemia, or it may suggest an incipient cardiomyopathy. Early repolarization, especially as by Dr. Hasegre, has shown that they are associated with idiopathic VF and therefore can be at risk. T wave inversions, as already discussed by Dr. Sam, said, especially in the lateral leads, may signify the early stage of cardiomyopathies or early stage of ischemia per se. Other markers in general population would be late transition of the QRS, which increases the risk to around 2-fold, and presence of P wave abnormalities. If there are interatrial blocks, that is, the P wave is wider, or if there is the terminal negativity in V1 is more, it may signify that the patient is at risk for having atrial arrhythmia, atrial fibrillation, and heart failure and stroke. Just adding on to the last topic, role of AI in SCD prediction. Now, as already discussed, the role of our individuals would be less, and it more and more would go into the hands of the machine, saying that your risk is this much, rather than us saying that the patient is at having disease. So concluding, ECG in relation to symptoms, disease diagnosis, echo finding, and family history is very important to predict sudden cardiac death. ECG criteria of sudden cardiac death are non-specific sometimes in structural heart disease patients. Better is echo, where ejection fraction is a better criteria, or the extent of disease is a better criteria. ECG criteria of sudden cardiac death are very specific for channelopathies. ECG risk for general population is based on the number of abnormalities, primarily the QRS duration, the T wave changes, as well as the presence of a QT prolongation. I end my talk at that. Thank you.
Thank you, Dr. Shomu Bora sir, for the crisp and timely lecture on ECG markers of sudden cardiac death. It was immensely informative for us. I request Bora sir to be on stage. I request the chairpersons to felicitate Dr. Bora sir. Thank you. I request Dr. Ashish Nambar sir for his next presentation on EP study basics for physicians.
Yeah, thank you very much for the invite to the midterm ISEOCN. If we can project the slides. Yeah. So I want to discuss only a few points that may be of interest and probably need to be registered for a general physician or postgraduates in internal medicine. One is about how you do a EP study to decide whether there is a important conduction problem, in other words, a distal conduction block. Then it is about SVTs and a few closing remarks about ventricular tachycardia, risk stratification, sudden cardiac death. So electrophysiologist has two roles probably. One is to make an arrhythmia diagnosis by using non-invasive tools which must be used extensively before one decides that there is an indication for a EP study. And usually EP study in the present era would be done with an idea of requiring an ablation. Now, as I said, these extensive tools are now much more than what we had like a 24 or a 48-hour Holter previously. Today you have 7-day patch monitors, you have implantable loop recorders. So all these possibilities must be exhausted in a non-critical scenario or non-threatening scenario, and the arrhythmia diagnosis can probably be made most of the times using these tools, and the reason to do a diagnostic EP study gets lesser and lesser with time. A brief understanding, the EP study is done in the same cath lab where your interventional cardiologist does an angioplasty. The difference is that you require a computer-based EP system which essentially has a stimulator and ability to record the intracardiac electrograms and display it on the computer screen so that the interpretations are correctly made. We position catheters at different places. Usually it's right atrium across the tricuspid valve to record the conduction system at the apex of the right ventricle. And then we get an understanding of what is happening on the left side between the left atrium and the left ventricle by putting a multipolar catheter in the coronary sinus. So these are all showed up in this slide. Now these catheters are electrode catheters, unlike your interventional cardiology catheters, which are lumen-based catheters to inject the dye. So these electrode catheters, usually you record bipolar signals, and these catheters are connected to such a junction box, and then you record signals on the computer like this, and you have a surface ECG on the top which gives you some understanding, and the intracardiac electrograms verifies your diagnosis. So this is how the EP study generally runs. Let us start a little bit with the first indication of a EP study today, that is his bundle study. Now, you may have an ECG in which in this case clearly shows a right bundle branch block, left axis, normal PR. Now, if this patient is asymptomatic, you probably won't do anything. But if there is a dubious symptom of pre-syncope or a remote symptom of syncope, then you might want to clarify whether he has a distal conduction problem. If there is a delay in the AV node or a block in the AV node, these are usually physiological and they progress to a complete heart block over a great number of years. So you are less concerned. Whereas if somebody has a distal conduction problem that is in the his or infra his, then this patient is going to mature from this kind of a ECG to a complete heart block very soon. And therefore you really want to demonstrate it. So if you look at the ECG here, you can see that, let me see if I can. You can see in the bottom strip that you record with a quadrupolar signal, the signals across by placing the catheter across the tricuspid valve, you record the conduction system. So what you see in the second channel is probably a atrial signal, a his signal, and then a conducted QRS. But if you have a distal conduction problem, what you'll see is you'll see AH, and there is no QRS. So in a non-conducted P wave, if you see a H and no QRS, this is distal conduction problem. Whereas if you see A and no H or V, then that is a proximal conduction problem. So a distal conduction problem is a definite indication for giving a pacemaker. So these days, if you don't see it spontaneously like this, then you pace the atrium at higher rates and see where your AV conduction blocks. If it again blocks below the his, that is you see AH and then no QRS, then that is a distal conduction problem, and these patients would obviously need a pacemaker. So sometimes you need to clarify where that block is happening, or if the symptoms are dubious, and particularly in such a kind of a fascicular block, you might need to clarify if there is a distal conduction problem and whether there is an indication for a pacemaker. But most of the times we do EP study with a view of going ahead and doing an ablation. So there are very few reasons for that. So just some understanding of how we plan the EP studies in a patients who have supraventricular tachycardias. Now the idea of doing the EP study prior to ablation is to diagnose the mechanism of the tachycardia. Now I think Dr. Asirvatham showed you a lot of tachycardias, how they can be diagnosed on the ECG. The electrophysiological study helps us to exactly confirm that mechanism and locate where that putative target is which you should ablate to provide a cure. So therefore, you must know what are curative arrhythmias and where is the ablation palliative. So number of the supraventricular tachycardias like AVNRT or accessory pathway mediated tachycardias, these can be ablated very well. So ablation here is curative, and if somebody has a SVT and is symptomatic, you obviously can bring them to the lab to not only do an EP study but also ablate. Almost similarly, things can be said about atrial tachycardia and atrial flutter, which can be ablated quite easily. And fascicular ventricular tachycardia is one more idiopathic ventricular tachycardia which can be ablated well. So if on the ECG you already diagnose these kind of arrhythmias, you would usually bring them to the lab where an EP study would be followed by an ablation, whereas the other two indications, AF ablation, would be a little higher threshold, at least in our setting. So common AVNRT, as you understand, is a circuit between the slow and the fast pathway. What you do here is you stimulate the atrium and an extra stimulus given, usually then conducts down the slow pathway and then again conducts up by the fast pathway. So you have, when the tachycardia is going on, you have an atrial signal and a ventricular signal mapping to each other. So if you remember all the explanations that you heard about 2 talks back, you would understand that that is how we diagnose that the supraventricular tachycardia is a AVNRT, and then you proceed to do a slow pathway ablation. So here the idea of bringing to EP study is not to understand the mechanism only, but obviously you know beforehand that you would proceed and do a curative ablation. Again, accessory pathways, as you know, are located along the annuli. So most common pathways are located in the left lateral region. The second most common site are the posteroseptal sites. But how do you locate them? Obviously on the ECG, if there is a pre-excitation, you can have a good judgment of where the accessory pathway is likely to be. But if somebody has a concealed accessory pathway, meaning that doesn't conduct antegradely but only conducts during the tachycardia in a retrograde direction, then you obviously cannot localize on the ECG. So your EP study helps you to localize. Now how do you localize the tachycardias along the annulus? You have a very good method of doing that on the left side, because the coronary sinus runs parallel to the mitral annulus, and when you put your multipolar catheter there, you can easily decide whether your pathway is left lateral or left posterolateral or left posteroseptal. On the right side, you do not have any such structure where you can map the tricuspid annulus, but you use your catheter positioned at the AV conduction system at the His bundle, and then you get a rough idea whether it is right on the left, and then you do fine tuning with your ablation catheter. So just to simply show you on this ECG, so these are the electrograms that you record, and based on when you pace the ventricle, if your atrial signal in the CS1-2, that is the distalmost pole, comes early, then you know that the pathway is left lateral. So these are some of the ways in which an electrophysiologist can deduce where the pathway is, and then he can move his ablation catheter a little bit around that area and just fine tune which spot is the right spot to localize the pathway. So that is how you go ahead with the pathway ablation. This is one tachycardia that I always find interesting to bring to the lab, because typical atrial flutter can be ablated very well. So typical atrial flutter is a circuit around the tricuspid annulus. Obviously you have easily recognized beforehand by looking at this ECG, which shows a typical negative sawtooth pattern. When you bring to the lab, you position a catheter along the tricuspid annulus. So this catheter has about 10 bipoles or 20 poles, and you can localize how the circuit is moving around the tricuspid annulus. Most of the times the circuit would be moving in a counterclockwise manner like this, and this tachycardia can be easily ablated by giving RF applications in a linear manner from the tricuspid annulus to the SVC. So again, a very easy tachycardia to ablate should be brought to the cath lab much more often, because it is not only EP study that you're doing, but you are going to follow it up with the ablation. One more tachycardia that you bring to the lab with a view to ablation is atrial tachycardia or focal atrial tachycardias. Now these originate at number of typical sites in the right atrium and left atrium, and therefore when you initiate the tachycardia in this manner, for example, here you can see that the tachycardia is initiated, the electrophysiologist looks at the P wave, they have a negative P wave in 2-3 AVF, so it's coming from the inferior side. He looks at the P wave in lead V1, it is positive, so it's coming from posteriorly. So these are deductions that he already makes beforehand. And when he brings to the lab, he puts up catheter in the coronary sinus in the right atrium, and then when he sets the tachycardia, what you do is you move your catheter to the approximate side, the ablation catheter, and if you can see in the last channel here, the signal is earliest in this channel as compared to other intracardiac channels, and he knows that probably the location of the atrial tachycardia is from here. So even this is one focal atrial tachycardia which can be ablated very well. So these are the reasons why an supraventricular tachycardia is brought to the cath lab. It is hardly to make a precise diagnosis, but more often it is with a view to ablate successfully and provide a curative option. The third indication probably that I want to discuss with you is, do you do a VT induction study to risk stratify somebody as to who should get an ICD? Now actually this indication is again very uncommonly practiced, is because the guidelines are so very clear about who should get an ICD. For a secondary prevention, that is a person who has structural heart disease, and most commonly in your practice it is patients with ischemic cardiomyopathy or dilated cardiomyopathy who are at risk of getting a ventricular tachycardia. Now if these patients get a ventricular tachycardia or they are a survivor of sudden cardiac arrest and VT is documented at the time of syncope or at the time of obviously resuscitation, then it is a class 1 indication to give an ICD. You do not need an EP study anymore. Maybe once upon a time when the ICDs were evolving, EP studies were done, antiarrhythmic drugs were prescribed, then the VT studies were repeated to see if there is non-inducibility, and you kind of risk stratified patients as safe or still requiring ICD. But this logic is no more. When you have a VT in a structural heart disease, usually you would require an ICD. Similarly, for primary prevention, the guidelines are pretty clear when it comes to ischemic cardiomyopathy or dilated cardiomyopathy, that if the class of symptoms is 2 or 3 and if the ejection fraction is 35% or less, they require ICD. So the ejection fraction and the symptom class of the heart failure patient decides the indication of ICD. And how is the VT study done is that if you induce a sustained monomorphic VT, so polymorphic VT or VF during an EP study is not significant or not specific, but if you induce a sustained monomorphic VT, this could be the reason, or this patient could be at high risk of sudden cardiac arrest. When would you do that? It's very clear. In the patients with ischemic heart disease or non-ischemic cardiomyopathy, if their ejection fraction is above 35% and they have a symptom which is a little bit equivocal, whether it was a cardiac syncope. So if he has pre-syncopal symptoms or a remote syncope, or you're not sure whether that syncope is clearly arrhythmic etiology, then only in such cases you might do an EP study, demonstrate a sustained monomorphic VT like that. That just makes your argument stronger in terms of giving a ICD. But in today's times, most of the indications of the ICD are clinical, based on ejection fraction, based on heart failure symptoms, and based on how the symptoms sound to you, whether they on history taking. If they are of arrhythmic etiology, then by and large your decision is already made. There is very niche indication to do a EP study and show if VT is inducible, and then go ahead and decide an ICD indication. So I think I'll stop here. So the role of EP study is pretty limited. One is in supraventricular tachycardias, most of the time it is to do an ablation. In bradycardia situations, it may be sometimes required. Mostly when the symptoms are equivocal, you may require a EP study like a His bundle study to demonstrate a distal conduction problem, or in patients who have a syncope and a structural heart disease, you may need a EP study to induce you may need a VT inducibility study to see if a sustained monomorphic VT can be induced, and that would make your argument a little stronger for deciding an ICD indication. I think that's what you should probably take home. Thank you very much.
Thank you, sir, for the giving the basic understanding for the EP study, when to be done and which patients it is to be done. I request the chairperson to felicitate Dr. Nabar, sir. Thank you once again, Dr. Ashish Nabar, sir. May I request our next speaker, Dr. Raja Selvaraj, sir, to have a talk on pre-excitation, what it means for a physician.
All right. So we'll start off with one of the common questions that comes up in the clinic. You have a patient who has a little short-looking PR and some slurring of the QRS. And so there is a question whether there is mild pre-excitation. So let me start with how we approach this problem. And so the first is to understand what determines the degree of pre-excitation on an ECG. So if we think of an accessory pathway, which forms a bypass for the impulse to reach the ventricle from the atrium, the amount of myocardium, the ventricular myocardium that is depolarized by the accessory pathway determines the degree of pre-excitation. So this may, therefore, you can have pre-excitation which is mild because the pathway conducts very slowly and therefore is only able to depolarize a small area of the myocardium before the AV node outraces it and captures most of the myocardium. But so this can happen, for example, with an atriofascicular pathway which conducts slowly and therefore has very mild or no pre-excitation on the surface ECG. But with the atrioventricular pathways, the more common reason for pre-excitation to be mild is that the pathway is far away on the left side, so that the sinus impulse reaches the AV node much faster and takes a longer time to reach the accessory pathway, and therefore pre-excitation is mild. So whenever you have an ECG where there is a suspicion of mild pre-excitation, the first thing to see is, does this fit in with a left-sided pathway? And the best way to look for that is to look for an early transition. So you look for a tall R wave, taller than expected R wave in V1 or V2. And once you see that, you can look for negative delta waves in one end AVL, which may be there with a left lateral pathway, or in the inferior leads with a left inferior pathway. So here we can see there's a negative delta wave not looking like a physiologic Q wave. And so this is, so we can suspect that this is the left lateral pathway with left posterior pathway with mild pre-excitation. And when there is in the EP lab, and there is a suspicion of this kind of thing, we can reveal this by pacing the left atrium. So the converse, what I was saying, because the sinus node is on the right side, the left-sided pathway is far away from the sinus node and therefore pre-excitation is mild. Now when we pace from the left side close to the pathway, the amount of pre-excitation can increase because you're pacing closer to the pathway, more of it goes through the pathway, less of it goes through the AV node, and we can bring this out. Whereas if you're not in the EP lab, another way to bring it out non-invasively in the ward is to give adenosine. And adenosine works on the principle that you either block in the AV node or you slow conduction significantly in the AV node so that very little myocardium is depolarized with the AV node, allowing the pathway to capture most of the muscle, and therefore you can increase the amount of pre-excitation. But coming back to the first ECG, where there was suspicion of mild pre-excitation, and we can see here this is not a left-sided pathway, like V1 is clearly isoelectric. And so why, if it is not a left-sided pathway, is there this appearance of mild pre-excitation? So a clue can come, this is recorded in the EP lab, but we can forget the EP catheters here. If you just look at the ECG, and this is a junctional beat, because you have this beat is preceded by a sinus wave, by a P wave, this is a sinus beat. This beat is not preceded by a P wave, it's a junctional beat. And you can see this mild slurring that we see in lead 1 and like a negative in V1 is still present on the junctional beat. So this gives the clue to what the issue is here, because a normal atrioventricular pathway will show no pre-excitation with a junctional beat, because the junctional beat is originating in the AV node and therefore is not going to go through the accessory pathway. So the fact that the junctional beat originating in the AV conduction system still shows pre-excitation means that the proximal insertion of the pathway is also in the conduction system beyond the point of origin of the junctional beat. So this is a fasciculoventricular pathway. So these fasciculoventricular pathways can look like pre-excitation, but they show very mild pre-excitation. And the clue is that the amount of pre-excitation stays fixed. We were discussing how with the atrioventricular pathways, if you do a Holter or things, you can see the amount of pre-excitation keeps varying a little bit. or the patient exercises, or you give adenosine, everything changes the degree of pre-excitation. Whereas here, the amount of pre-excitation is always fixed and mild. Junctional beats will also be pre-excited. And these patients do not develop tachycardia due to this pathway because it does not result in any form of re-entry. And therefore, this is not associated with, and this is also not associated with any risk of sudden death. So when this kind of mild pre-excitation is there and you identify it as a fascicular-ventricular pathway, these patients usually do not require any treatment for this. And one way to think of this is to understand that we saw in the previous presentation with the EP that the PR interval is not, even though on the ECG it is just one interval, when we do an EP study, we know that at some point you will record a hiss. So what is before that in the PR interval is due to the conduction in the AV node, and the parts after the hiss signal are due to the conduction in the His-Purkinje system below the AV node. With an atrioventricular pathway, you have bypass of this whole, the AV nodal component itself, so that the delta wave can start right from the end of the P wave. Whereas with a fascicular-ventricular pathway, because the pathway itself starts beyond the AV node, only this distal part, this part which is contributed by the HV interval, only that results in the delta wave. That is why you have this kind of mild pre-excitation. Another interesting variant on this is an ECG like this, where there is no obvious pre-excitation. The PR interval looks normal, there doesn't appear to be slurring. But then you do an echo for this patient and then you'll say, okay, this patient does have pre-excitation. So the reason this happens is that on the echo you identify this patient as Epstein's anomaly, and you expect a right bundle branch block pattern on Epstein's anomaly, and once you know that patient has Epstein's anomaly, you expect an RBBB, but RBBB is absent. That is a way to identify that there is pre-excitation. And here what happens is there is a little slow conducting pathway on the right side in Epstein's anomaly, because the pathways are usually on the right side, and this conduction masks the conduction delay that would happen with the RBBB, and therefore the QRS looks normal. So if you have a normal looking QRS in a patient with Epstein, think of a right-sided pathway. So why we are discussing all this? Does it matter whether there is pre-excitation or no pre-excitation? The main clinical implication of the presence of pre-excitation is that when there is pre-excitation, it indicates the presence of an antegrade conducting accessory pathway. And this, as we discussed before, if there is a pathway which conducts antegrade, it means that during atrial fibrillation it can conduct rapidly, and therefore the patient has a small but finite risk of sudden death. And one way of assessing this risk in the ECG is when you see something like this on the ECG, you see pre-excited beats and then for a couple of beats there's no pre-excitation. Again, we've seen ECGs like this previously today with small changes in the RR interval. When the cycle length changes enough to encroach on the refractory period of the axillary pathway, it is not able to conduct. This tells us that the axillary pathway refractory period is long, and therefore this is not a pathway that is going to conduct rapidly during atrial fibrillation. You can also look at ECGs during treadmill testing, but that's a little more tricky because with treadmill testing, even normally the amount of pre-excitation comes down because AV nodal conduction improves with exercise. But so what you want to really look for is abrupt loss of pre-excitation, which indicates that pathway blocks because of reaching the refractory period. In the EP lab, what we do is measuring the axillary pathway effective refractory period, just to see that we have given two atrial stimuli close by, and we are seeing if this still conducts through the pathway. There is still a delta wave, so it conducts through the pathway. This tells us that when you have two atrial impulses at an interval of 200 milliseconds, both of them still conduct to the ventricle. This tells us that this pathway is likely to be a high-risk pathway. Again, we've seen this ECG multiple times, fast, broad, irregular rhythm, pre-excited atrial fibrillation. When you see this again, look for the shortest intervals and you can measure this, and this is what is called as the shortest pre-excited RR interval. And when this is less than 250 milliseconds, this is also considered a high risk for sudden death. So to summarize, when you have suspected mild pre-excitation, if it's one is that it may not be an atrioventricular pathway. It could be an atriofascicular pathway or a fascicular-ventricular pathway. If it is atrioventricular pathway, it is typically left-sided pathway, so look for the signature features of a left-sided pathway, especially an early precordial transition. adenosine may be helpful to unmask pathway conduction when it looks very mild. Whenever there is pre-excitation, whether it's symptomatic or asymptomatic, there is a small risk of sudden death. Some features like spontaneous intermittent loss of pre-excitation can give you a clue that this pathway is not at high risk, but otherwise when it is not known, but there are some other things like when there is multiple pathways, when the SPERI looks short, or when there are conditions like Epstein anomaly, the risk of sudden death is high. Unless it's clearly low, these patients should undergo EP study and ablation of the pathway, which is the best way to reduce this risk of sudden death. Thank you.
Thank you, Dr. Raja sir, for the elaborate lecture on the pre-excitation and what is to be sought on the ECG sign of pre-excitation. I request chairpersons to felicitate Dr. Raja Selvaraj sir. Thank you very much. I request our next speaker, Dr. Rajesh Dhopeshwarkar sir, for his talk on management of ventricular storm.
Thank you so much. Good afternoon, and it will be the end of last talk of this session, I can say. My talk is on management of ventricular storm, and it's a fairly simple talk, but a very difficult job to do in real life when you get patients of ventricular storm. Can I have the slides on the screen, please? Thank you. So how do we define ventricular storm or electric storm? 3 or more ventricular arrhythmia episodes, sustained ventricular arrhythmia episodes within 24 hours would define a ventricular storm. Most of these are because of monomorphic VT. Obviously, the rest will be from polymorphic VT or VF as well. And most of the patients have underlying disease. So this is a very serious disorder, and it really means very high mortality, morbidity, and a lot of trouble for us as clinicians also. So the reason behind any ventricular arrhythmia, we already know there is a substrate, there would be a trigger, and there is some autonomic influence that affects the arrhythmia. So all those things that can give rise to ventricular arrhythmias can obviously give rise to ventricular storm also in a given subset. Just let us look at the substrate. The commonest substrates that we see is ischemic cardiomyopathy, a previous scar, and non-ischemic cardiomyopathy also, which obviously there is a scar, and scar-induced reentrant VTs, we all know, is a substrate for VT and can at times be a reason for electric storm as well. These are the commonest reasons for ventricular storm. The second ones are those channelopathies which we see, which we don't see it very often, but rarely may give rise to ventricular storm as well. Long QT, acquired long QT, Brugada, or early repolarizations or CPVT, rarely we would see it. And the third one is a structurally normal heart with idiopathic ventricular tachycardias. Especially those which arise from the Purkinje system, they are more likely to give rise to sustained arrhythmias, incessant arrhythmias, and often ventricular tachycardiomyopathy. What are the triggers that as a physician we look at is, first is ischemia, obviously rule out ischemia. If ischemia is there, then it needs to be treated. Just to bring it to your attention that ischemia generally gives rise to polymorphic VT-VFs and very rarely to monomorphic VT. Although I remember there was one patient who had a sustained VT during a stress test testing, and he underwent an angiogram and his LAD had disease, so the cardiologist stented his LAD, and after 1 year he came back again with sustained VT, and this time we had to ablate the ventricular tachycardia. So there is no direct relation between ischemia and a sustained monomorphic VT, though two diseases may coexist at times. Decompensated heart failure is often a reason why people would develop arrhythmias, and treating that heart failure or improving the ventricular function or giving LV support measures also can help in treating the electric storm. Infections So many times patients come in with heart failure and then land up later on a repeat admission is because of some infection and heart failure, and arrhythmias come back again. Drugs and drug-induced long QT syndrome is another reason. Obviously, we all look for potassium, magnesium and treat them appropriately. Rarely, amiodarone-induced thyrotoxicosis may be a reason of ventricular storm, and we should keep it in mind that loading amiodarone more and more may not be an answer in such situations. So sometimes our therapies itself can precipitate electric storms. Like we implant a CRT pacemaker and then suddenly realize that the patient starts getting shocks from the device, then one thing that we need to keep in mind is if the LV pacing itself is producing it. I remember one patient who had that, where LV pacing had to be turned off in his case. And obviously inappropriate or very aggressive ICD programming, meaning short intervals where the ICD will detect and treat, and that shock itself will give rise to more and more VTs. That also may be a reason for your VT storm. Now, all VTs that come in may not be of the same risk, and some of them really can be of a bad prognosis. And what is it that brings in bad prognosis is fast VTs, VFs, polymorphic VTs, the ones which are incessant, and short coupled VTs. In a setting where the hemodynamics are bad, that makes it even worse because our ability to treat them with medicines is also less. So when we have a patient with VT storm, generally if somebody gets only one shock from an ICD, we would not admit them. But anything more than that, patients do need admission. What do? ICU admission. Then first thing, if somebody is getting incessant VT where the ICD is repeatedly shocking, then the best thing is to stop that ICD therapies, especially if the VT is hemodynamically tolerated. And the easiest thing to do is using a magnet. If you don't have a programmer at hand, use a magnet, put it on the device, at least the shocks would stop. That will itself reduce anxiety, and then we will get more time to find out other ways to treat that arrhythmia other than just shocking the patient out of the arrhythmia. Very important thing that we should know that there are some arrhythmias that will never respond to shock. So what we are talking is patient getting shock, the arrhythmia terminates and reinitiates. That is a different thing from somebody who gets a shock and the arrhythmia never terminates and in fact accelerates. Those are the arrhythmias where that arrhythmia could be just automatic tachycardias, and the commonest one is sinus tachycardia. So somebody is getting multiple shocks, then we should also look if it is just sinus tachycardia, and we really don't need to treat that. Initial assessment for hemodynamics and trigger should be done. So a lot of things that we do when the patient comes to the ICU, send his lab, look at his vitals, do an ultrasound or echo, get an history if there is any drug withdrawal or any other drug ingestion which has given rise to these VTs, and get a 12-lead ECG for that VT, get X-ray. Whenever ischemia is suspected, then obviously revascularize whenever it is needed. That's all which is done. Now, treatment for all VT storms that we get in the ICU is based on these four modalities. Essentially, these four things which will form the treatment. One is medical therapy, which is antiarrhythmics. Second is sedation or bringing down the sympathetic drive down. Although not all VT storms are because of sympathetic drive, there are some VTs, VFs which may be induced because of increased parasympathetic tone as well. The third thing is improving hemodynamics as much as we can, without using any drugs that can increase the sympathetic stimulation or myocardial stimulation. Like LV support measures like balloon pump, Impella, ECMO, all of them are very useful, especially if the ventricle is very bad, and we have very little role in using any other drugs also. And the last and not the least is autonomic modulation using sympathectomy. I'll just give you an overview of antiarrhythmic drugs. It's not really detailing everything, but we all know that amiodarone forms the main drug in treating VT storms, especially with those with structural heart disease. So anybody who has structural heart disease, amiodarone is the drug. So what is it so special about amiodarone? Is although it is a class 3 drug and can prolong QT, it very rarely can give rise to long QT induced torsades. So torsades or pro-arrhythmic effect of amiodarone is very rare, and it's relatively safe in anybody who has structural heart disease. We should also know that it is not just only one loading of 150 amiodarone and an infusion of 900 that suffices. So many times you have to go give combined IV plus oral and followed by oral continuous loading until and unless the patient becomes arrhythmia free. And we may give as much as 10 to 20 gram of amiodarone until the tissue myocardial levels of amiodarone are sufficient to suppress the arrhythmia, provided amiodarone is tolerated by the hemodynamics as well. The next commonly used drug, IV drug, is lidocaine that we use it. Very useful in an ischemic subset, less useful in a non-ischemic subset. An oral analog mexiletine now that is available can also be used in patients who have ventricular dysfunction. The third drug in our disposal is sotalol. Sotalol should not be used in people who have structural heart disease until and unless they have an ICD, and should not be combined with other drugs that can give rise to QT prolongation. All these drugs actually, if there is renal dysfunction, then we should be very, very careful because they can give rise to long QT induced torsades more so. Phenytoin is something like lidocaine and mexiletine and very less used, but we have found it to be very useful in VT storms, giving bolus of phenytoin 1 gram and then continuing it. Works in 50% of the times, but a good add-on drug to amiodarone. Quinidine also is very useful in some scenario. And ranolazine, which is used as an anti-ischemia drug, can be used as an add-on drug for treating ventricular arrhythmias. Sedation, we all know, stellate ganglion block is the very important tool, especially if the ventriculars are bad, hemodynamics are bad, then stellate ganglion block is also very good. And finally, definitive treatments like ablation and heart transplant, which become the mainstay in treating ventricular arrhythmia storms. Very interesting thing that stereotactic cardio ablation therapy, radio ablation therapy, which may become the future of ablations, whereas you just send a patient into an ablation room, get whatever ablation you want to do, and patient comes off in 15 minutes. So that is a possibility. Now the last but not the least is ICD programming, is using magnet to deactivate, then using shock-free therapies, because shocks sometimes perpetuate more and more shocks. So using more and more anti-tachycardia pacing to terminate ventricular arrhythmias, or sometimes prolonging the detection interval so that non-sustained VTs are not detected and over-treatment is avoided. Inappropriate shock should be appropriately managed by programming the ICDs using SVT discrimination. If somebody has atrial fibrillation and has incessant ventricular arrhythmias, then the best thing is incessant fast rates and shocks, then the best thing to do is AV node ablation. Obviously, lead fractures, external interference should also be looked at. For a post-CRT VT storm, turning off the LV lead is good. ICD shock can itself induce a lot of problems. I know of a Pakistani patient in Canada who said, just take my ICD off, and we had to really explant that ICD. So one important thing is that somebody in VT storm never implant an ICD. ICD is not a treatment for VT storm. Also, we should not implant an ICD if the expected survival is very low. And finally, terminally ill patients who continually get shocks, whereas there is no definitive treatment and only palliation is concerned, and just deactivating the ICD is important. We do it in a stepwise manner in an appropriate way so that only the necessary treatment is done and aggression of the treatment is appropriate according to the patient. Patients with long QT induced torsades, we should treat hypokalemia, hypomagnesemia, and see that they don't develop bradycardia. If necessary, atrial pacing, overdrive pacing is also useful in that particular setting. Thank you so much. I think I'm right on time. I have a few cases which I can show you just in a minute. So this is a 17-year-old boy who came in with a EF of 15% and a right bundle left axis type of ventricular tachycardia. Obviously with that ejection fraction, we took him for ablation in a fluoroscopic ablation. It was a VT and his ejection fraction remarkably improved. The site of the VT was near the posteromedial papillary muscle. So very common source of arrhythmias which may become incessant sometimes. Here is an old lady who came in with syncope, and her ECG done showed something like torsade, short runs of torsade. She was on beta blockers, on chloroquine, and her potassium was also low. So just correcting that could treat her drug-induced torsades. We so many times get patients with VT storms where there is a scar and it can be appropriately ablated in addition to ICD, which obviously is necessary. Ablation treats the re-entered arrhythmias. Sometimes the scars may be epicardial, especially if it is a non-ischemic cardiomyopathy, where you go in the pericardial space and ablate. And this is another example of non-ischemic cardiomyopathy, which came into a surprise for us because the echo reported outside was normal and it looked like some kind of papillary muscle VT, but it didn't look very much like an idiopathic VT because of the irregularity and the white QRS. We got an MRI done and there was an apical aneurysm, and just next to that aneurysm there was a substrate which we could ablate. So we have interesting papers which have come in from a multi-center study. Dr. Lokhandwala sir also has been one of the co-authors, where it has been found that bilateral sympathectomy is much better than unilateral sympathectomy in treating arrhythmias, in addition to so 88% reduction in ICD shocks. So very useful tool where ventricle is bad, where ablation is not possible. So ablation is possible in a smaller subset of patients where the ventricular function is a little preserved. Otherwise, sympathetic denervation I think is something which we should try. And renal denervation also has been told in some case reports of some interesting things that may come. We should judge which treatment is good for what and then treat patients accordingly. Thank you so much again. It's really a pleasure to be here.
Thank you, sir, for an interesting lecture on the ventricular storm. I request chairpersons to felicitate Dr. Dopeshwarkar, sir. Thank you, sir. With this lecture, we conclude the didactic lectures. Now we'll be having few intruding ECGs from the masters. For that session, may I call upon the stage Dr. Ashish Nabar, sir, Dr. Amuthan, sir, Dr. Ajay Mahajan, sir, as chairpersons. So we'll Dr. Samuel, sir. So we'll be starting the intruding ECG presentation with Nabar, sir.
So I'll present two ECGs, one on behalf of Dr. Lokhandwala, and understanding that we are a little late in the schedule, I'll try and keep it very short, just to impart some concepts here. Correct. So this is a patient about, I think, 63-year-old who has, look at the ECG on the right side, shows a broad QRS tachycardia, and by now you have learned to recognize this as VT. I'll just outline what makes it a VT. It is a right bundle branch block type of tachycardia with a monophasic complex there. So monophasic or biphasic complex is in favor of VT, triphasic complex suggests SVT with aberrancy. The other important concept that was given to you in Dr. Asirvatam's talk is to look at the V4 to V6, which are almost placed at the apex. So there is a negative, predominantly negative QRS in V4 to V6, or rather a QS pattern. So the forces are moving away from the apex, and if you look at the axis, which is negative in 1 and negative in AVF, that's obviously a northwest axis. So there is hardly a discussion, despite being a fast tachycardia where you will find all the difficulties in locating a P wave, even in the QRS with the most, in the lead with the most the smallest QRS, it gets a little difficult to look at the P wave, and there could be debate. But if you see monophasic R, negative QS in V6 and a northwest axis, there is no discussion about this being a VT. Being right bundle branch block, the next step you must take is to find out where this VT is coming from. So a right bundle branch block type of pattern in V1 suggests that it is a left ventricular origin of the VT, And probably the most common etiology in your mind in this setting, the monomorphic VT is always a scar VT. And then you are trying to say what is the etiology of this scar, and the most common etiology of the scar is an previous myocardial infarction. So you start looking after conversion of this patient to sinus rhythm, you look at the sinus rhythm ECG. And I am sure most of us will be tempted by the fact that there is Q in 1 AVL, there is QS or Q in V4 to V6, and there is a little prominence of R in V1. And I think most of us will unhesitantly consider this as an infraposterolateral infarct, and the morphology of the VT does suggest an origin in that region. So you'd probably call it a post-infarct VT. Surprisingly, the coronary angiogram was normal. So obviously there are other reasons to have a scar in the heart, and that is nowadays very much clarified by doing a contrast enhanced cardiac MRI. So this is not an ischemic heart disease or a post-infarct scar VT, but if you look at these gadolinium enhanced MRI images, which are very beautifully done by my colleagues in Jupiter Hospital, you can see that there is a scar on the epicardial surface, almost a circumferential scar. This arrow shows you that, epicardial scar. And this VT then originates because of this kind of a scar. The larger the scar, more the chance of getting a VT, and the scar VT is always a monomorphic VT. So this epicardial scar is usually in some form of a previous insult. Sarcoidosis usually has a mid-myocardial scar. The epicardial scar many times is some form of a cardiomyopathy, either a laminin cardiomyopathy or those indications. So the second thing you look for is whether there is any lymph nodes that can be biopsied to make a histological diagnosis, and the T1, T2 mapping nowadays tells you whether there is an active inflammation. So these all were negative. In this patient, there was also thrombus in the left atrial appendage. So this was done because the MRI suggested that. Tomorrow, if you want to consider ablation in this patient, the endocardial ablation is not going to be successful. You will have to do an epicardial ablation like one of the case I think Dr. Dopeshwarkar showed. But primarily, this patient would require an ICD. The point I wanted to emphasize while bringing this case was that the QR pattern very typically suggests an infraposterolateral infarct, but one must remember that there are other causes of scar, and those are best brought out by doing a cardiac MRI. We move on to the next case. This is a young lady who presented in a hemodynamically unstable scenario with a low blood pressure to the emergency services. She has a past history of recurrent palpitations which stop in 15 minutes to half an hour, but these she never thought were significant to record an event ECG. But this time she came because she was really uncomfortable, and what you can see here is that if you concentrate on the rhythm strip at the bottom, you can see that there are some broad QRS complexes and some narrow QRS complexes that come in a set of 4 to 5 beats together. The broad QRS complexes you can trace into the other leads also. They have a little slurred onset to them. They are fast obviously, and it is irregular. So I think umpteen number of times you have heard today what fast, broad and irregular means. The question is there are also narrow QRS complexes in between, and then again sometimes broad QRS complexes. Most of the ECGs that were shown to you today as pre-excited atrial fibrillation, from left to right, the whole ECG had only pre-excited beats, and therefore the understanding was that once the AFib is there in a person who has a overt axillary pathway, it would look like a pre-excited AFib all through. Here you can further learn that when the RR interval is short, then the AV node is refractory and major part of the ventricular activation is by the pathway, so they are broad. And when the RR is a little longish, you can see that those AF beats are conducted down by the AV node. So this can get a little confusing. People can diagnose it as a VT, but if you carefully look at the fast, broad, irregular definition, and you can even localize the pathway, the delta wavish onset at the origin is negative in 2,3 AVF, so it's a posteriorly located pathway. Unfortunately, you don't have any pre-excited beat in V1, V2, so it's a little difficult to say the side maybe, but you can make a diagnosis of a pre-excited AFib here certainly. That's the cause of her being unstable. again amply stressed earlier, the best way would be to cardiovert and restore the sinus rhythm, which was promptly done, and you can say that it is no-brainer now that there is a clearly a short PR interval and a delta wave and a broad QRS fitting into all definitions of an axillary pathway. The 2,3 AVF in the delta waves are negative in this, so it's a posterior pathway, and here you can clearly identify that the delta wave is negative in V1, so it is a right side pathway. Transition happens in V2, so it's a right posteroseptal pathway. So you can go so far off when you read the ECGs carefully. I think these are the two ECGs that I wanted to present.
Thank you. Thank you, sir. I request Nabar sir to join us as a chairperson. I request Dr. Amit Vora sir for his intruding ECG presentations.
Okay, can we have the slide? So this is truly a unique ECG, because when I saw, I was also a little perplexed and would like to share it with you. Just a month-old baby girl, she had a premature delivery at 8 months of amenorrhea, and was on the second day when BCG vaccine was being given, found to have bradycardia. And we have this, it's an old ECG, single lead running across lead 1, lead 2, 3, AVR, AVL, AVF is here, V1 is here. So it's a single lead strip. You may not be able to see it well, and therefore I like to blow it. So the heart rate was just about 60. And the child didn't have any history whatsoever, 1 month old, incidentally noticed to have bradycardia. I'll blow up the long lead 2, and these are the kind of complexes which I see. There looks to be a PQRS, then there's funny thing happening here, PQRS, funny thing, PQRS, funny. This is a kind of ECG pattern which we are seeing. Anybody can make a wild guess. If I were to ask you, is this like a ventricular ectopic and a bigeminy pattern being seen? Is this a sinus bradycardia? Is this some kind of alternate pre-excitation? Is it a QT, U prolongation? What is it? Sorry? Somebody said long QT? Okay, so where does the QT interval end? It begins here. Does it end here, or does it end after the? So the second part is the U wave. So this is the T wave and this is the U wave. This is the T wave. So the T wave is bifid. That is what you want to say? No. Sorry. So in this, the first one is a P wave and the second one is a T wave. Very good, very smart. So you have a situation where you have P wave, if you time it, the PP interval times very well, and you have 2:1 AV block kind of a situation. So now tell me, why is there a 2:1 AV block? It is falling in the refractory period of the ventricles because the QT interval is prolonged. So this is so to say, it could be a physiological AV block because of a QT prolongation. The P wave is falling in the refractory period of the ventricles. Excellent, very good. So the QT interval, if you measure, is 520 milliseconds. The RR interval is 0.8 seconds, and by Bayesian formula also, the QT interval is very long. I think you've done brilliantly well. So tell me, how do I manage this child? What do I do? Bradycardia, 2:1 AV block, QT prolongation, likely to be a congenital long QT. In congenital long QT syndrome, which is the drug of choice? Beta blocker. Can I give beta blocker? There is 2:1 AV block. Yes? You are very brave, braver than me. Yes, I did give beta blockers, and next day on beta blocker, I find that there is a 1:1 AV conduction now. And why is there 1:1 AV conduction? Because? Sorry? I think you answered very well. Why don't you get up and say it loudly? What is reduced? QTC is not reduced. Beta blockers don't reduce the QT interval. What has it done? What has the beta blocker done? Beta blocker has slowed down the sinus rate. Because it has slowed down the sinus rate, the P wave now is falling outside the refractory period of the ventricle. Now the ventricles are not refractory and able to conduct. So paradoxically, beta blocker helped to improve the 2-to-1 AV conduction to 1-to-1 AV conduction by slowing the sinus rate, and the QT interval remains the same. So the logic of giving beta blockers in long QT syndrome is not to shorten the QT. The QT does not shorten with beta blockers. The QT measurement might appear fallaciously low, and therefore you should not look at the QT interval alone. What you should look at the corrected QT interval. The corrected QT interval continued to be prolonged, and this child continued to have congenital long QT syndrome, but did very well for many years. Thank you.
Thank you, sir. I request Dr. Raja Selvaraj, sir, for his intruding ECG presentation.
Okay, so this is an ECG recorded in a patient with a Medtronic pacemaker. So with just that much details, let's just start looking into how to approach an ECG. So I'm just going to quickly go into how to approach such an ECG and look at the things. So broadly, we can see there's a rhythm strip running at the bottom, so it's easy to look at the rhythm strip, and we can broadly see that there is a fairly regular and normal looking pattern at the beginning and the end of the tracing, and there is some abnormal looking region in the middle of the tracing. So in such cases, it's best not to jump directly to the abnormality, but first look at the normal looking pattern and understand first what is happening. And we see here there is sinus rhythm, there are P waves occurring at a expected sinus rate. Here the rate is little faster than 100. And there is every A sense is P wave is followed by a pacing spike with ventricular capture. So we judge that this is sinus rhythm at a rate of around 100. AV conduction, you cannot assess. The only thing you can say is that probably native conduction takes longer than 140 milliseconds so that the device is pacing. And so this device is a dual chamber pacemaker because there is atrial tracking. And we cannot tell at this point whether it's a VDD or DDD mode. And once it's a dual chamber pacemaker, for each chamber you think whether sensing is normal and is pacing normal. So here we can say atrial sensing is normal, but you cannot assess atrial pacing. Ventricular sensing you cannot assess, but ventricular pacing is normal. And we don't know the lower rate, and the sensed AV delay is 140 or less. So now, and if we zoom out and also look at what is the ventricular lead position, this is consistent with the lead position in the RV apex. So now we come to the central portion, knowing all these things, and what we see is there's one P wave which is not followed by ventricular pacing for a gap, and then you see two pacing spikes. So the first one is clearly an atrial pacing spike with atrial capture, and then there is a ventricular pacing spike at a short interval. So this tells us a few things. Now we said initially that we were not sure of AV conduction. Now it's clear that there is AV block, there is no intrinsic AV conduction. Also shows us that when atrial pacing is also normal, that you are able to, that an atrial pacing spike is able to capture. But now we need to find out what is the cause of this abnormality. Is it real? Is it a true abnormality or not? Now, what are the possible differential diagnoses here? So one possibility, as soon as we see this, is atrial undersensing, that it's likely that it's a P wave that is not sensed. And the only way we can judge here that that is not the case is when we measure out this escape interval. This escape interval comes out here to around 65 beats a minute, which is not a programmable rate in a Medtronic pacemaker. So that was the only thing against an atrial undersensing. The other issues here, this sort of whenever you see an atrial pacing spike and then a very short AV delay, one thing that immediately comes to mind is ventricular safety pacing. But here we can say this is not ventricular safety pacing because this interval, if we measure that, is 80 milliseconds. It's not the 110 milliseconds that we expect. So the other possibility when we see 80 milliseconds is managed ventricular pacing, just that we have to know some of these algorithms and the common patterns. Managed ventricular pacing is an algorithm in the Medtronic devices where the device shifts between an AAI and a DDD mode. And what can happen is when it is in a DDD mode like this, it performs a conduction check once in a while, where it does not track one of the P waves and just waits to see whether this P wave gets conducted intrinsically or not. If the P wave is conducted, it's a successful conduction check and the device switches to a AAI mode. If it fails, it paces the atrium and gives a rescue pacing. Now the issue, again, this rescue pacing occurs with an AV delay of 80 milliseconds, so all that fits in. The only issue is that after this P wave, we would not have expected atrial pacing to come in so close. So even though the pattern looks like a failed conduction check in an MVP mode, this interval of ascends to apace suggests that that is not the case. So the last possibility here is what is called as a blanked flutter search, where the device thinks, could this be actually an atrial flutter going on? And the device is not seeing alternate P waves because they fall into the P VAR. So to uncover this possibility, it extends the P VAR for one beat. And because of this extension of P VAR, one P wave is not seen. So if it is a 2:1 flutter, the next P wave would have come out here and it would identify that this is a blank flutter and it will appropriately mode switch. But here it finds there is no P wave there, then it paces the atrium and continues back in the thing. So this one again has an AV delay of 80 milliseconds, and in discussion with the technical team we found that this is actually a blank flutter search. So just the reason to present this ECG is just to take you through a systematic approach to a pacemaker ECG, and often you need to differentiate whether it's a true abnormality, because is that really atrial undersensing, do you need to increase the sensitivity, or whether this is an apparent abnormality just because of various algorithms. And there are a lot of algorithms, but at least some of the common algorithms like ventricular safety pacing, crosstalk mechanisms, MVP, we need to be aware because these can mimic abnormalities on the paced ECG. Thank you.
Thank you, sir, for the very interesting pacemaker ECG. May I call upon the stage Dr. Joy Thomas, sir, for the next interesting ECG presentation.
Good evening. I would like to thank the organizers for this opportunity to be here. Mine is a very intriguing ECG. I just have one slide here, and I would like you to participate in and help me to diagnose this. See, this is an ECG of a 44-year-old male with giddiness. As you can see, there are long pauses in this ECG. This is taken from a rhythm strip from a Holter. And obviously, the treatment is very well clear. The patient needs a pacemaker. But this is an intriguing ECG, so I would like you to help me. Can somebody help me with the diagnosis? Let's start with seeing that there are no P waves before the QRS, so probably the sinus is sleeping. There is a sinus pause. Could it be a sinus arrest or a sinus pause? Between a sinus arrest and a sinus pause, there are certain differentiating features. One is, I've already measured this. I'm sorry I don't have the measurement on the slide here, but there are no multiples of intervals between the QRS to define it as one of sinus arrest. Sinus pause doesn't follow any multiples. So this looks like a sinus pause. And what is one thing which is striking about this entire rhythm strip? Can you help me? Group beatings are there? Do you see group beatings? So when you see group beatings, what is the first thing that comes to our mind? Yeah, Venki back. So if you think along that, if you look at the first beat that comes, leave the first three complexes. Let's go to the second three complexes. There's a long pause. In that baseline, I don't see any P waves. Then you have a narrow QRS complex, which is followed by what looks like a T wave. But look carefully at that QRS complex and the other QRS complex is what you see. There is something which is sitting just prior to the T wave, which is probably a retrograde P wave, is it not? So there is a junctional beat, that is a QRS, which is giving rise to a ventricular atrial beat, and a P wave which is negative. And then after that, the next beat, again you don't see any P wave. So what could be the cause for that? If you look at all the complexes, you see there are three beats, most of it. There are some beats which have only two, but most of it have got three complexes, and the pattern is repeated. You have got first initially a QRS, then a P wave, then a QRS again, and then a P wave. And you look at the interval between the QRS and the P wave, there is a variation in that also. The first the QRS to P wave or retrograde P is shorter than the second one. The second one is longer. So what possibly happens is the ventricular activation goes up. There is a VA which is happening, activates the atrium, and then after the atrium is activated, there is a little delay in the ventricular activation which comes through probably because of refractoriness, and then the next ventricular to atrial thing is shorter because one of the things which was refractory earlier had recovered what is called peeling of refractoriness to give a shorter V to A. And this again causes a very short P to V, and because of the short P QRS interval in the last beat, there is no more retrograde P waves because they are completely blocked because of absolute refractory period in the ventricular atrial thing. So this is my thing. I would like if anybody has a different thing, I would like to hear that. Among the triple complexes that you see in this ECG, if you look at the one after the longest pause, you see that's only a single pause. In that, there is no VA at all. Again, the next complex, there are only two complexes. There is a VA in the first, after that again a VA, but those two VAs are of the same duration, and that gets blocked in the third beat, so there's no third complex. So my thing would be, diagnosis would be like this: sinus pause, junctional escape beats, retrograde VA with Wenke back, and AV reentry occurring all in a group fashion in this particular ECG. This patient, of course, received a dual chamber pacemaker because of his young age and the need for rate responsiveness in him. Any difference of opinion? Dr. Amit? Yes.
AV re-entry happening with a relatively normal PR as I can see. So I'm not certain about the AV conduction disease in this patient. Sinus node dysfunction definitely is there. Did you pace the atrium at a higher rate and check one-to-one AV conduction?
Whenever I decide about whether the patient needs an atrial pacing alone or whether he needs a dual chamber.
Correct.
So I go pace the thing with the ordinary, temporary pacing thing. We go up to 140, 150 or so.
Yes.
If he robustly conducts 1-to-1 up to 140 or 150, I think he can go for an atrial pacing. That is a atrial-based pacemaker, and with a rate response.
So in this patient, what was the one-to-one AV conduction?
It was about 140, more than
about
140.
140. So clearly it was only sinus node dysfunction. There was no AV conduction.
There was no AV conduction. What we see here is the retrograde problem.
Correct. So I think this is an important message that retrograde VA conduction does not necessarily reflect antegrade AV conduction.
Absolutely.
Many of us will not have a retrograde VA conduction at all, but we have a brisk and normal AV conduction. So retrograde VA conduction or VA Venkeback may not be necessarily pathological or disease.
I think, Dr. Amit, if you look at the last beat in those complexes, the last beat has got a P to QRS, which is quite narrow. It's almost normal. So that also gives us an idea that the AV conduction is quite good. Well, yeah, good question. Yeah, good question. So, yeah, see, like I said, this man is a young man, 44, and I thought we should give him a dual chamber pacing because from 44 to the age of 80 or so, there's quite a number of decades left. So I didn't want to take a risk, number one. Number two is, as you all know, that once we give a pacemaker, this case was done about more than a decade ago. We used to have lifetime warranty available for patients by some companies. Once they put a pacemaker, then throughout their life, the replacement is guaranteed. That is, they get the pace generator free of cost. So I wanted to ensure that and not to take a chance with AV conduction. I knew it was good, just for the reasons what Dr. Amit told just now, and for this last beat on the triple complex. That's quite a narrow PQRS. Yes. So we do not know what will happen in 40 years of claim. Thank you very much.
Thank you, sir. I invite our next speaker, Dr. Shomu Bora, for his EC discussion.
Again, good evening. So based on Dr. Sam's lecture, I would just keep this single slide and ask you, this is a 59-year-old gentleman with palpitations, old MI, severe LV dysfunction with baseline LBBB, and this is the tachycardia which the patient presents with. So the most appropriate statement seeing this tachycardia looks like an SVT. You would like to give adenosine because the patient has LV dysfunction, maybe amiodarone or cardiovert also. However, will require a CRTD because the patient has LV dysfunction and LBBB. The second so how many of you would agree with the first statement? So we'll go to all the four. Looks SVT, and the next step would you do is terminate it, obviously, but then instead of a CRTD, you would choose ablation rather than a CRTD. The third would be it looks like a VT, you cardiovert the patient and you then give a CRTD. And lastly would be, it looks like a VT, you first terminate it and then do an ablation and then give an ECD. So what would you agree on based on this ECG? I'm just showing this, I'll tell you the next. So the baseline was this. So the first is to diagnose the tachycardia. Based on whatever the information is, that is what I want to highlight. So how many of you think it's a narrow complex tachycardia? I think most of you should agree it's a narrow complex tachycardia. The QRS duration is not more than 120 milliseconds, and if you apply that, the next step of a regular narrow complex tachycardia is what? To see for the P waves, right? And to see for whether it is short RP or long RP, right? So where do you see P waves here? Somebody will have to. So see the P waves. The best P waves are seen in V1 and lead 2, right? So see the lead V1 and lead 2 most of the times you will find there, right? So here if you see P waves, the P wave is here. The next is not seen, the P wave is here, then it is here, the P wave is here. So are the P's more than the QRS or P's are less than the QRS? If the P's waves are less than the QRS, the diagnosis is a VT, it's not an SVT, it's a VT, right? So how can it be narrow?
Shomu, you'll have to take it on yourself to answer also, for sake of time.
Yeah. So the narrow, if it is an upper septal VT or it is a junctional with VA block or AVNRT with VA block, can have a narrow complex tachycardia which is with a VA dissociation. And lastly, if you have a baseline bundle branch block and you have a tachycardia which is narrower than that, it cannot be SVT with aberrancy. You have to, because any SVT with aberrancy will follow that bundle branch block. So it is very important to understand that any baseline bundle branch block, any SVT with aberrancy will have a same bundle branch block. It will be broad only. So anything narrow is a VT unless proved otherwise. Okay, that's it.
This is in textbook. It is a very well mentioned criteria of if the QRS during the tachycardia is narrow than that during sinus rhythm, it is definitely a VT. But after a long time, I have seen such a ECG. Makes it interesting, truly intriguing.
Thank you all the speakers and all the dignitaries for the storming ECG presentations. Now I will invite for our next session chairpersons Dr. Amuthan, Dr. Arvind Gongne, Dr. Ashish Purohit and Dr. Durairaj Selvaraj. Please come over the dais for chairing the next session. The next session will be debate on whether treadmill stress testing is obsolete or not.
Now we have a very interesting session on the question of treadmill stress testing is absolute or not. Only last week I had a patient for whom I did an echo and suggested treadmill. So one of the physicians who referred the case simply questioned me, why don't you suggest coronary angiogram? So now we have an interesting session on this. So first we will invite Dr. C.K. Pandey. Pandeyji? Yes. Now you are going to say that treadmill test is absolute.
I thought Dr. Amuthan is going to invite both of us on the stage, and just like two boxers, when they start the boxing match, before that, he says a whistle and does this. He's going to do that. And I thought Jagdish is there for that, but he's still loading his slides, I think. So, is treadmill tests obsolete in today's era? So, well, to me it seems so, but Parale has given me, both of us, an impossible task of proving our point of such an established test, which we have been using for donkey's years, year after year, day after day, in 8 minutes, which is mission impossible. So let me go through this slide as quickly as Tom Cruise. So what's a debate? It was described by Protagoras in ancient Greece and Shastrastra from India as an argument or a discussion to resolve an issue. But today I redefine this as not like this. Today we define it as agree to disagree. And we certainly don't want to fight like this, Jagdish. Yes, neither like this. The key point is, stress testing is not designed to detect any coronary artery disease, but designed to detect obstructive coronary artery disease, which is defined as more than 50% left main stenosis or more than 70% stenosis of a large epicardial coronary artery. Look at this study done long ago. 147 studies, 25,000 patients. Sensitivity, 68%. Specificity, barely 77%. And look at the false positives. Female gender, resting ST segment abnormalities, left ventricular hypertrophy on echo, bundle branch block, underlying undiagnosed mitral valve prolapse, drugs like digoxin, potassium level less than 3.5, blood sugar more than 250 to 300, anemia, hemoglobin less than 9. So many reasons of false positive stress test. To add to that, Bayes theorem, which says, Bayes' work back in 1700, my friend 1700 told us that what drives our stress test is the pre-test probability of a disease. So positive stress test in 4th minute in a 20-year-old woman will not mean the same as it means in a 70-year-old man who's a smoker, diabetic, hypertensive, chronic kidney disease and dyslipidemic. Alright? So now, Let me see first patient. 55-year-old man with diabetes, hypertension, dyslipidemia, 50 pack year of smoking and typical angina. Second patient, 62-year-old female with right-sided, my friends, right-sided chest pain on exertion for 3 days. And third patient, a 25-year-old male with a single episode of chest pain after eating a spicy meal. Now, when I do a stress test in the first patient, pre-test probability 95%. With a positive test, it becomes 99%. Only 4% gain. With a negative test, it still stays 90%. So no point in doing stress test in that man. Third patient, young man with a single episode of chest pain after a spicy meal. Pre-test probability 3%. Post-test, even if the test is positive, your probability of coronary artery disease is 10%. And with a negative test, it is just 1%. So my friends, the real gain is an intermediate probability of patients where the pre-test probability is 45. With a positive, it becomes 87. Negative, it becomes 10%. So the key point is the determination of your pre-test probability is the key point in interpreting a test. Do we do that every day? No, not really. I don't think any cardiologist reports like this. Anyway, so these are the intermediate probability of stress test where the stress test is appropriate. But note that most of the asymptomatic folks are all at low risk. So even this beautiful article in Indian Heart Journal by Dr. Prem shows that it is not advisable to include stress test as a part of routine health package. Because most of the patients coming for health package are asymptomatic, apparently middle-aged, healthy individuals in whom the pre-test probability is relatively low. And therefore, even with a positive test, the post-test probability of coronary artery disease will become moderate, not intense. Then there are false negatives. For example, even with multi-vessel proven coronary artery disease, let us say I take 100 patients, proven triple vessel disease, only 80 will have positive stress. 20 will have a blissful negative test. And specificity even worse, 66%. Look at this, in a single vessel coronary artery disease, the sensitivity bogs down to 50% and specificity, don't even talk about it. In single vessel and double vessel coronary artery disease, you can't even talk about specificity of a test, stress test. So my friends, exercise stress test is a science, but the interpretation is an art. And most of us have forgotten that art. Are there other tests which are with better sensitivity? Yes, of course. You have exercise echo, you have dobutamine echo, you have pharmacological stress perfusion, you have CT perfusion, about which, where is Uday? Uday is going to talk about it in a while. And one of the wonderful tests to do. Currently, I am most happy with dobutamine stress echo or a pharmacological stress perfusion like adenosine. All right? So now, having said that, my two choices are these two tests. Are they widely available? Well, no. Absolutely, yes. Are they affordable to a common man? Well, some are not, like dobutamine stress test, affordable. Pharmacological perfusion, affordable. But CT perfusion, MRI perfusion, probably not. And this is another data which shows that results in patients who had a non-invasive positive test, abnormal non-invasive positive test. So if you take a stress ECG, 37,000 patients had a positive test. Only 45% of them had obstructive coronary artery disease. So the strike rate is very poor. But look at that for coronary CT angiogram, 70%. And most of other tests is only 45%. So remember, in a test, in a large cohort of patients with varying pre-test probability of underlying coronary artery disease, any non-invasive test has a poor positive predictive value. That is the bottom line, my friends. And therefore, I am saying that when better tests are available, like CT angiography, CT perfusion, why not? So thus, when you say, this is a very old article, available evidence suggests that there remain appreciable number of patients with documented coronary artery disease in whom ECG abnormalities are detected despite relatively intense, no ECG abnormalities are detected despite intense level of exercise. False negatives. And therefore they concluded that in patients with typical angina or with chest pain, which clearly does not resemble angina, stress testing appears to be superfluous. This was the last study done way back, and we are discussing that today again. Sad truth, my friend, is all experts sitting in this room, I fall into the same category, humbly, right? We report the stress test as either positive or negative, but virtually none of us report the probability of that positive test to predict presence of significant CAD, taking into account pre-test probability in every patient. Probably underlying significant CAD despite a negative test. So, suppose I get a high-risk patient and a negative test. I must say, despite the test being negative, there is a 90% chance that this patient will have significant coronary artery disease because the pre-test probability is high. Or otherwise, even if the test is positive, she is a young 20-year-old woman coming for routine health checkup. Despite a positive test, her chance of coronary artery disease is dismally small. Do we report like that? No. So ladies and gentlemen, let us pull up our socks and start reporting stress tests in a better manner. Till that time, I will retreat one step back and say that I rest my case here and invite none other than Jagdish. Jagdish physically can always dominate me, I know. Please.
Thank you, Dr. Ponde, for inviting Dr. Jagdish Hirmat for the counter.
I know I can physically dominate him, but he's always mentally dominated me. So, we've heard all these pre-test, post-test probability, very old studies. That is not here we are to discuss anything. Despite all this, are we doing treadmill tests or not? Answer is yes. So it's not obsolete. My statements start with a statement like this. So this is how we do. Okay, this is how we too looked when we were in our 20s, 1981. When we were in 40s, we started looking like this. Today, we look like this. There must be a reason why it lasted. Because every year there is a phone call from the likes of Pondit that your husband is no good. But still it has lasted for so many years. And so is the treadmill. It's been around for several decades. It's installed in every cardiology department, small or large, every modern day. It is still installed. And it's not obsolete for no reason. Every conference this debate takes place and people keep telling it is no good, but still we do it. And that's what the debate is. It's not debating whether treadmill is good or not, whether it is obsolete or not. No, it is still that we are using it. All of us are using it. Now, what can be debated is the significance of TMT in the final diagnosis, whether you do a stress test in a lady and whether it is this or that, that can be debated. But you cannot, what you cannot debate is its value as a screening test. And that's what all of us are doing it, I'm sure, all these days. It's exceptionally useful, unquestionable in evaluation of, or let's say initial evaluation of exertional symptoms. Cardiac neurotics, it's an excellent test. Rather than doing an expensive CT angio, if somebody does 11 minutes on the treadmill, reaches a heart rate of 175 negative, I think even the cardiologist is convinced that there is nothing. Evaluation of non-classical anginal symptoms. You do an angioplasty, you do a stress test after 6 months, and you keep repeating. It's a wonderful way of following up the patient. There is no need of doing exceptionally high-fi tests. There are many patients who are chronic coronary syndromes now on the COMPASS type of treatment. And then this best way to follow them on medication, whether the medication are protecting these patients or not. It's an excellent functional evaluation. And utilizing its negative predictive value is reasonably good. Suppose a lady does a negative stress test. It may be a false positives, all right. But if its stress test is negative, it means it is a reasonably good predictive value. Of course, there are non-ischemic uses like valvular heart disease, manifest accessory pathways, whether it is risky or not, or in place of a 6-minute walk test also, we have been using it at a fixed treadmill speed. A 50-year-old man complains of classical angina. He is quickly diagnosed as acute coronary syndrome and subjected to coronary angiography. And it's a mild lesion. Now he needs either a FFR or later on a thallium or whatever. If his TMT was performed before, this dilemma would not have occurred at all. Then what are the options of such a simple, easily done test? What are the options which were discussed? TMT, myocardial perfusion imaging, dobutamine, MUGA studies, stress MRIs, FFR and its components. Now for these top 4 ones, think of the effectivity, ease of performance, accessibility, cost effectivity. Remarkable difference as compared to the treadmill test. There is no radioactive drugs, there is no intervention used, ability to repeatedly perform it every year or 6 months or so. And all these tests have to be performed very well. What is the experience nationwide? How many people are really doing it? How many are doing it really well? Compared to a TMT, where a junior most houseman also does exceptionally good treadmill stress test. So it was thought, I think sometime back in the history, I forget whether it was Roman or not, they said if there is no bread, they can have cake. That was the thinking of a Roman this thing. And the Pundes of this year, they are also doing the same thing. If they don't do treadmills, do thallium stress tests. It's saying the same thing. So evaluation of exertional symptoms for me is simple. In a man, if the stress test is positive, subject him for angiography. If it is negative, I put a full stop there. If it's a woman, positive TMT, I can think of other options, maybe a CT angio. And if it is negative, again, I'd put a full stop. This simple formula has worked for me, and I'm sure many of you, including Dr. Ponde, for a long time. The TMT yields can improve, like today's smart TMT can improve if there is a wireless connection, if the temperature of the rooms are measured and rather friendly, bigger friendly rooms with temperature control, and convenience should not override science. That means patient has come, so do it now, if beta blockers are not withdrawn, or shortcuts like 85% targets are achieved. If these are not done, then TMT can be a wonderful test. So my approach today about TMT is use it as a screening tool, unequivocal significance ischemia on exertion subject to catheter angiography, mild positive unequivocal subject C2 angiography. It's good for the CSC score as well. And like AI or a chat GPT are advances, they are tools, they are not creatures. They can do tasks but not jobs is what is said about it. And same is true about TMT. It's crude, but it's a tool which helps to do a good job, well done. Thank you very much.
Thank you, sir. After the powerful comments by Jagdish, I now request Dr. Ponde for his rebuttal. Only 2 minutes.
Yes. So this was my last slide. Yes. And all that I say, that in spite of pitfalls and limitations, stress test is still widely available, cost effective, safe, and the most important diagnostics tool for evaluation of ischemia. So I agree with Jagdish, and I already said we will agree to disagree. Thank you.
Now expert comments.
Thank you, both of you. As you could see in the last slide, probably both of them have matched the 2 sides of the coin, and probably it is going to stay on, and the debate is also going to stay on. Understanding the limitations and indications, probably the results also we would take it accordingly, and may the test survive. Thank you.
So now you all must be knowing that why big B is big B. And as very well said by Dr. Hiremak that the stress test will be there. And he very well pointed out that what additional we can do to get the better prediction. Thank you.
This is one of the important tests for non-cardiologists, that is internists like me who are practicing to pick up the cases where ECG is normal, echo is normal, still patients complains of chest pain when he takes food or some unusual exertion, complaints of pain. This is the only test available to send the patient for coronary angiogram, number one. Number two, all patients who underwent CAPG, when they go for checkup, it is a must in every hospital. So it shows its importance. So stress test still has got importance in clinical practice.
So the final comment after hearing all the experts is that treadmill exercise just stands on today. Thank you for your attention.
Thank you all the chairpersons, thank you all the dignitaries, and especially thank you both the boxers, as Dr. Ponde sir said. Now I move upon to the next session on panel discussion, amiodarone use and abuse. I would like to invite Dr. Shailaja Pillai, Dr. Girish Borawke, Dr. C.P. Pawar, and Dr. Sachin Shirke sir to chair the session. I invite Dr. Pradeep Singhal sir to chair the session. I also would like to invite Dr. Page sir to chair the session. Now I request Dr. Amit Vora sir to come up on the dais as a panelist.
Shomu? Shomu is here. I think, so this is, I guess I'll ask the chairpersons that the question of amiodarone use and abuse is what we are going to have a panel discussion on. And if there are any particular questions which you wish that we need to bring out, you can please ask. But let me start off in terms of amiodarone use and abuse. I think this is the most widely used drug in India and most widely abused drug in India also. So Shomu, tell us in terms of indications of use of amiodarone, according to you, which is the strongest reason, arrhythmia, for which you would use amiodarone? Sorry?
Misuse, I think the most common indication is nobody understands the arrhythmia and you give the drug because you're not able to diagnose. Any PVC, any atrial arrhythmia, any fast tachycardia which does not respond to any other drug, you give amiodarone and hope you will respond. So that is misuse.
So I have an interesting story to tell. I mean, sometimes I and my wife are driving. I'm driving. She's in the car with me, and suddenly a call comes up from the ICU saying that such and such person is an arrhythmia. So she answers. She's a gynecologist. She answers on my behalf. Give amiodarone. And that I think is the sum of it, that amiodarone is the antiarrhythmic drug you can prescribe anytime, anywhere.
I have seen amiodarone given for a patient with complete heart block having torsades because of bradycardia, amiodarone. Means, because you think that you have a tachycardia, you give amiodarone. So anything amiodarone will work, and
So
that
now
is the misuse.
let's go systemic. Which is the strongest indication for the use of amiodarone?
Means-
Arrhythmia. Which arrhythmia can be treated only with amiodarone, or amiodarone is the first drug of choice?
So patients with LV dysfunction, structural heart disease, who have ventricular tachycardia, which is monomorphic, not even polymorphic, I'll keep that at the highest risk. Means, and those patients will not tolerate other drugs. So patients who do not tolerate other drugs, in which you have no other choice, amiodarone would be the only choice that I can give.
So ventricular tachycardia, monomorphic ventricular tachycardia, and monomorphic ventricular tachycardia in a setting of structural heart disease. So there is either cardiomyopathy, LV dysfunction, and you have a tachycardia, probably amiodarone becomes the drug of choice.
And heart failure to add on, if it is there, more likely that I will possibly give that only.
Which supraventricular arrhythmia in your practice you think amiodarone should be used or can be used, or is one of the first drugs to be used?
So let it put that way, that a narrow complex regular tachycardia, I would never want to give amiodarone because adenosine works most of the times. Second are atrial flutters, atrial fibrillation and MAT. So in that scenario, if you have an atrial fibrillation with no structural heart disease, no congestive heart failure, ibutylide, all these will work well, pill in the pocket. So only place where I'll give would be patients who are in CHF. The heart rate is very fast. You have no other option because the patient has LV dysfunction. The patient is in failure. Either I cardiovert or I give amiodarone in such a situation.
So in atrial arrhythmias, okay. So in atrial arrhythmias, it is generally for atrial flutter fibrillation that amiodarone can be used, and generally you will use it also in people who have structural heart disease and LV dysfunction, because even for atrial arrhythmias, you have better first drug of choice if you have a normal heart or a normal LV function. So class 1C antiarrhythmic drugs is the first drug of choice. Amiodarone would be reserved for people with failed class 1C antiarrhythmic drugs or those who have structural heart disease and LV dysfunction. So what Ashish was pointing to is that we should decide amiodarone use, when would you use intravenous and when you use as an oral maintenance dose of oral amiodarone. So how would you, so in a ICU setting, when you have a ventricular tachycardia come up, how do you decide amiodarone, how would you give amiodarone for a ventricular tachycardia, monomorphic ventricular tachycardia?
So if the patient has never received prior medication of amiodarone, he is not on a maintenance, you have to load the amiodarone. So ideally 150 milligram is the loading dose immediately. It has to be given over time, that is 10 minutes. Now most of us would tell 150 in 10 cc of saline and you just give it slowly. But remember that concentration can cause significant thrombophlebitis, especially if the patient is receiving other drugs like heparin even, or antibiotics. That combination within the same vein would be a difficult task. So I would actually want to give it in 100 cc and in a separate vein rather than give it in the same vein flown over a period of 10 minutes. And once that is done, 150 milligram, once it is loaded, you start a maintenance. And that maintenance typically you give at 1 milligram per minute, and that is 360 over 6 hours, and the rest 640 over the rest next 18 hours. So typically we'll give 1050 milligrams over 24 hours is in the general rule. And what we do is, most people give a syringe, right, 50 cc syringe, 2 ml per hour. But because the concentration is very high, it is better to give actually into a 500 ml, that 1 gram, and give it over that period of time rather than otherwise.
So
it
practically,
prevents it prevents thrombophlebitis.
Practically, this is very important that amiodarone is a very irritant drug, so causes lot of thrombophlebitis. So giving it in a peripheral vein is a problem. You should use a larger bore vein and a larger cannula to give to avoid thrombophlebitis. And as Shomu said, if you dilute it and give it slowly, it would be a good choice. And I guess if you have a situation where you are likely to use amiodarone for next couple of days, not only just a short bolus over a period of few hours or one day, it might be better to take a central vein and then give amiodarone infusion over a longer period of time. So in a day, maximum dose of amiodarone could turn out to be 1.2 grams or so.
So the recommended is around 1, but actually people have gone up to 2.4 grams per day, and it has not shown to be of it has not caused more toxicity. The problem is when you give that much dose, it causes more of irritation and thrombophlebitis, and also it can cause more of hypotension and bradycardia. So the side effects increase, and the advantage of giving 2.5 is not higher, 2.4 is not higher as compared to 1.1 or 1.5.
So I think this is again important that intravenously probably you can restrict yourself to 1.2 to 1.5 grams. The additional 1 gram could be given orally so that it will start acting slowly, because hypotension and bradycardia are significant problems when you give a larger dose of amiodarone in a shorter period of time. So in terms of amiodaronization, I think this is a concept which all of us need to kind of revisit. Amiodarone is a drug slow to act, slow to build, and in an adult generally you will have to give 6 to 8 grams of amiodarone for it to have a good cellular effect on the myocardial cells, and therefore 6 to 8 grams generally will be able to give only over a period of 3, 4, 5, 6 days, and therefore during this period you might get breakthroughs of the arrhythmia which should be treated by additional boluses, and you will have to then, after 6-8 grams of amiodarone has gone, yet the arrhythmia is not under control, then you can truly say that it is drug refractory to amiodarone and you might have to add additional drugs.
So I would just keep that way, that if you are giving amiodarone, what are the other drugs that you would want to prevent arrhythmia from coming? So amiodarone in combination with either beta blockers or lignocaine or mexiletine, what would you prefer in an acute setting?
So I think co-medications help to improve the efficacy of arrhythmia control, especially now we are talking of a ventricular arrhythmia control. Most often for monomorphic VT, lignocaine is not a very effective drug. However, lignocaine can be effective in certain clinical setting. If the setting is of ischemia, LV dysfunction, and there are a lot of PVCs happening, couplets, triplets happening, it's a membrane stabilizing agent, so it helps to quieten the PVC burden overall. But the effect on monomorphic VT by itself of lignocaine is very weak. But yes, it is one of the first drug to be added on to amiodarone intravenously, because the QT prolonging effect of amiodarone is not there with lignocaine, and therefore it helps very well to use as a combination. Amiodarone lignocaine as a combination is often used in the acute setting. Beta blocker is relatively underutilized in the acute setting, should be also one of the preferred modality to get the overall rate under control. Even in ventricular tachycardia it does help. So beta blockers don't terminate the ventricular tachycardia of a structural heart disease and LV dysfunction scar VT, but in the long run it definitely helps to prevent recurrences of arrhythmia and has a greater impact in terms of LV function and arrhythmia reduction in the long run. So a combination of amiodarone, beta blocker, lignocaine becomes a good choice in a stormy arrhythmic situation in the critical care. But the whole problem is that many of them are hypotensive or borderline blood pressure is low, and then giving the beta blocker becomes a challenge, and amiodarone lignocaine is a common drug that is to be used. I think from our chairpersons, if there are any questions which we need to focus or answer in terms of use and abuse of amiodarone. So I think in terms of abuse of amiodarone, what I see is that there are PVCs in an ECG and amiodarone is prescribed. How logical or illogical is that?
Excuse me, sir. So here.
Sorry.
We have Dr. Professor Vijay Garg sir with us.
Yes.
Can I ask few questions regarding the side effects? Which are the common side effects and which are the danger side effect of amiodarone?
So the side effects of amiodarone, again, we will say that in the acute setting, when it's used intravenously, and most of them we have discussed in terms of bradycardia, hypotension, prolongation of the QT. Fortunately, amiodarone, as far as prolongation of the QT and torsade is concerned, is not a very common thing to happen as opposed to sotalol and ibutalide and those drugs. And the precise reason being that in terms of, as Sam also pointed out, amiodarone is not only a class 3 antiarrhythmic drug. Actually, Dr. Martin Green, under whom I trained when I went to Canada, that is now almost 30 years ago, he asked me the first question in his round that amiodarone, which class of drug is it? And I said class 3 antiarrhythmic drug. He said no, practically it is a class 10 antiarrhythmic drug. Reason being that it has class 1 action, it has class 2 action, it has class 3 action, and it has got class 4 action. 4 plus 3 plus 2 plus 1, class 10 antiarrhythmic drug. So it's a very powerful antiarrhythmic drug. It has got all the channel blocking effect, and in fact that acts in its favor in terms of not having so much of torsade. Because of beta blocking property also, it helps to prevent having torsades more frequently. Having said that, I think potassium, magnesium, metabolic parameters, all these need to be taken care of. So this is the acute side effects which we were talking of. In terms of chronic use of amiodarone, oral amiodarone when it is used for long term, I think the side effects which we are worried about is thyroid, liver, lung, corneal deposits and skin pigmentation. So these are the common things which we look for. So as far as thyroid is concerned, I think the general dictum is that you should be monitoring thyroid function, preferably at baseline when you are starting a maintenance amiodarone, which you are likely to use for a long time. And then every 6 monthly, you should monitor the thyroid function test. Hypothyroidism is common. It probably occurs in 10 to 20% of patients on a long-term use of amiodarone. If the amiodarone use is very important and cannot be replaced by any other drug, the best thing to do in a hypothyroidism is to cut down the dose of amiodarone. So the maintenance dose of amiodarone generally is 200 milligram a day, but we have found that 100 milligram per day also works very effective in many arrhythmias, be it ventricular tachycardia or even atrial fibrillation. And in some situations we have gone as low as 50 milligram a day, and it works well in our probably weight group of our patients. So cut down the dose of amiodarone is possible, and replace thyroid supplement. You can give thyroid supplement. That is as far as hypothyroidism is concerned, and follow them regularly. You might want to do thyroid antibodies because occult thyroiditis may get provoked with the presence of amiodarone. If that were the case, then maybe you'll have to cut down the amiodarone. The problem lies if you have hyperthyroidism. Hyperthyroidism is a major challenge. Probably 1 to 2% of patients only will develop hyperthyroidism. If that were to happen, the best dictum would be to stop amiodarone and use an alternative strategy to correct the hyperthyroidism. And often these people have underlying Graves' disease, and you will have to work them up more aggressively to find out how to control it, and anti-thyroid drugs also may be required. Ajit, you had some comment to make?
Yeah, just wanted to comment about the amiodarone abuse. I think there are 3 reasons for it. First of all, even if you use it in PVCs or atrial ectopics, it will suppress it. So physicians are happy with it. Second reason is unfamiliarity with the drugs which can substitute amiodarone, like propafenone or flecainide or sotalol, because as physicians, they don't use it. So
amiodarone is available for 4 decades, and these drugs are recent.
That's something which people should become familiar with. And the third thing is, amiodarone will not kill a patient acutely. Like for example, a 1C agent or a class 3, you can kill the patient acutely if you use it in presence of structural heart disease or whatever. So these are the 3 main reasons as to why amiodarone is overused. And I think one should become familiar with class 1C agents and class 3 agents like sotalol in proper indications.
So what about amiodarone indication in CPR before?
So let me complete your earlier answer about side effects. We talked about thyroid. The other thing is liver function and lung function. I think what we are more worried is about the lung function, because many years and decades of use of amiodarone can lead to development of lung fibrosis. Hypersensitive pneumonitis can occur also in the acute setting. So be aware when you are using IV amiodarone and the oxygen levels of the person is going down, which is otherwise unexplained, it might be hypersensitive pneumonitis happening because of amiodarone. In terms of lung fibrosis, I think the best way to look for it is to get a pulmonary function test every 6 monthly. That does help, and not a regular PFT, but DLCO to look at the diffusion capacity is important to be able to say whether lung fibrosis is setting in. In some situation, you might require intermittently an HRCT chest. On a regular follow-up, maybe a 6-minute walk test or X-ray test can be done. Shomu?
So, I'll just keep that way. If your maintenance dose is more than 400 milligram for more than 1 year, then the chances of your having complications are nearly 5 to 15%. But if it is less than 400, say 200, the chances are nearly 1 to 2% in each of them. So first is to decrease your maintenance dose. As effective dose, the least possible is more important. And regarding the liver, many a time questions is asked, patient is having raised SGPT, SGOT, especially in acute setting, can we give amiodarone? So only if amiodarone is causing a raised SGPT, SGOT, you need to hold it. But if there is a pre-existing SGOT, SGPT which is higher because of other reasons, you can actually give amiodarone and monitor and see whether it is increasing or not, so as to decrease the initial condition which has already raised it. So that important aspect you need to also understand. That is for maintenance phase, sir. That is for maintenance phase. Acutely, because of heart failure itself, the SGOT, SGPT can increase.
So on a long-term maintenance dose of amiodarone, up to 2 times of liver enzyme elevation you might accept. More than 3 times is definitely a no. You need to probably cut down or stop the drug. But generally speaking, if you see a rising liver enzyme trend, it is a good idea for you to cut down the dose to the bare minimum, which is most effective. As far as corneal deposits are concerned, I think we did a study in rheumatic atrial fibrillation and use of amiodarone, and we didn't actually find many people having affection of their vision. So actually we have given up doing slit lamp examination for amiodarone, which was in the past recommended, because though there might be some corneal deposits, it is never a clinical problem in terms of visual acuity diminution. And the last thing is that some people do complain of skin rashes coming up, especially photosensitivity and exposure to sun. So these are the common side effects which you should keep on monitoring. The other question which you asked is in acute CPR situation, when you are reviving a person with a VT, VF and arrest, I think bolus of 150 milligram amiodarone and a repeat bolus also can be given, and then if your arrhythmia is continuing, you might use it for a longer period of time. Very important. So I think this is another important, the drug reactions, what are the potential issues. Now the common drug which you often use is digoxin with amiodarone, especially when it's used for atrial fibrillation, and what is most important is that you need to cut down the digoxin dose to half, because it increases digoxin half-life, amiodarone digoxin. So digoxin dose should be halved, reduced, and maybe even consider to stop it, because the rate control effect with amiodarone itself in a atrial fibrillation patient is going to be there. In a heart failure patient also you need to be very careful using these drugs, because the side effect profile is high. And yes, as far as vitamin K antagonist oral anticoagulation is concerned, it potentiates the action, and therefore your INRs might start misbehaving. So doing INRs more frequently, having a steady dose of amiodarone on board is something which is most important. I think as far as atrial fibrillation, one thing I would say, is that many times I see people prescribing amiodarone. The reason for giving amiodarone is to get sinus rhythm. The patient does not come in sinus rhythm, but he is always forgotten, and the amiodarone is there in the prescription for years altogether. The amiodarone is being given to restore sinus rhythm. If amiodarone has not by itself helped to get back to sinus rhythm, and that is, 25% of patients only on oral amiodarone will come to sinus rhythm over a period of few weeks or few months. 75% of patients on oral amiodarone will not come into sinus rhythm. These patients should be subjected to electric cardioversion. That is the value and role of amiodarone for in that given patient, rather than using as a AV nodal blocking drug or just as a rate control drug. For rate control in AF, use calcium channel blockers and beta blockers. Yeah,
I mean, just a quick question, because I think, many times we have seen that even after stopping amiodarone, you find that the pulmonary fibrosis or the lung lesions continue to progress, which is, very alarming. So what do you do in such case? And you have mentioned that you have to monitor INR, but many times now we are using NOACs. INR is not the monitoring. So what do you do in such cases?
So I think as far as the lung fibrosis is concerned, you need to pick it up before it develops or in the early phases, because it's an irreversible process. So if a lung fibrosis has happened on amiodarone, the fibrosis is not going to reverse after stopping the amiodarone. Yeah, it becomes a progressive, fibrosis is a progressive disease, unfortunately. So it may arrest the progression to an extent, but it will not reverse for sure. So the best would be to pick it up, nip it in its bud when the early phases, when it's just about to start, and then it will probably not progress. As far as NOACs are concerned, NOACs also have some interaction with amiodarone, and therefore you need to be careful. But the recommendation generally is to use a lower dose of amiodarone maintenance, but not cut down on the appropriate dose of NOAC that may be required in a given patient. The defibrillation threshold increases with amiodarone. I think this is something which you need to, you have been giving amiodarone to a given patient in a critical care situation. Patient comes with arrhythmia situation where you need to give a shock. Now in such situations, you need to understand the patient may have cardiomyopathy, heart failure on amiodarone. There might be electrolyte metabolic issues. Your electric cardioversion defibrillation might not be effective. The defibrillation threshold tends to rise with amiodarone. Amiodarone makes shocks sometimes ineffective. So when you have a chronic amiodarone use in a given subset, you might face a situation where the shock is ineffective. Be aware of that. We are talking of ICD, and ICDs probably also have a higher defibrillation threshold happening with amiodarone. I think the music is ringing for a long time, so the chairpersons can please conclude.
Thank you, sir. Thank you, Dr. Amit Vora, sir, Dr. Vijay Garg, sir, Dr. Shomu Vora, sir. It was indeed a very interesting discussion which got all of us so engaged into it. Thank you all the chairpersons. So we move on to the next session, which is named How to Proceed Symposium. Again, a very relevant and a very interesting set of discussion. So now I request the panelists to please come on the dais. Dr. S.B. Gupta sir, Dr. Panchanan Sahu sir, Dr. Shomu Bohra sir, Dr. Ajay Mahajan sir, Dr. V. Amuthan sir, Dr. C.K. Ponde sir, Dr. Jagdish Hiremat sir, to please chair the dais. And yes. And with a round of applause, let us welcome Dr. Parale sir to be the speaker for this session.
So we'll proceed straight away because we are running short of time. So this is a The question for Dr. Shomu Bora. A 50-year-old diabetic asymptomatic presents with left bundle branch block is asymptomatic in your OPD. How will you proceed?
So the first thing that I would see is whether the patient has structural heart disease or not, and that is the only thing. So asymptomatic, once you say, is it a relative term, whether he has decreased his activity, something of that sort, are the leading questions sometimes we ask.
No, he comes for a routine checkup for maybe for insurance purpose.
Yeah, so then I would definitely, in a LBBB setting, in a 50-year-old diabetic, I would definitely do a echocardiogram. The next step would be that.
If it is normal?
If echo is normal, I will leave at that and I will just ask them to report if there are symptoms. Now, symptoms of exertional fatigue, symptoms of presyncope, symptoms of breathlessness, these are the three things that I'll do. In addition, we can ask for family history. Sometimes conduction system diseases runs in family, and if there is a strong suspicion of that, additional any other problems are there that can also contribute. So that I would do, and maybe a repeat ECG or a routine examination, but doing a Holter, doing something else, I would not keep at the first visit in a asymptomatic.
Moderators, any comment?
Dr. Parle, I just wanted to add one more thing. If we can have the previous ECGs of the same patient and the previous ECGs of the patient is also showing left bundle branch block for many years, I don't think anything else is to be done. A patient is asymptomatic and is not having any structural heart disease.
Okay.
So I think that, when it comes to right bundle branch block, it's a very common occurrence. Almost 7% of the people have right bundle branch block in the population, and if you follow them for years, nothing seems to be happening. As far as left bundle branch block is concerned, in an asymptomatic normal individual, if you have even a couple of serial ECGs over the years, it may be normal and you may not need to do anything. As Shomu said, I agree. But I would follow a patient of left bundle branch block more closely than a patient with right bundle branch block, because I do feel that LBBB, in my limited experience, many of them actually present like an electropathy. It's an electropathy. It's something is abnormal. Over a period of 1 year, 2 year, 3 year down the road, you start seeing their LV function goes down or other issues start coming up. So LBBB is more sinister and need to be looked into more carefully and followed up more closely.
Maybe echo also can be added because of LV dysfunction if it sets in. So ECG and
so
echo.
So the follow-up is mainly in terms of echocardiogram, yes.
A 24-year-old presenting with atypical chest pain has these ventricular premature ectopics. Dr. Jagdish Remet.
He's 24-year-old, present atypical chest pain. I would keep it aside. What is the abnormality here is the premature ventricular beats. They appear to be uniform here. And if you look at the right bundle branch block pattern that has, so I would say left ventricular in origin. So definitely next step would be to look at a structural heart disease. It could be in the form of echo to start with. And these things have gone up to do a cardiac MRI early in these patients.
And if the frequency of VPC, does it matter? A Holter 24-hour load, VPC load?
Finally, when it comes to treatment, it would matter, the load of ventricular premature beats. But I'm more interested in the etiology of these VPPs rather than the rhythm problem.
Any cutoff for the 24-hour load? When you will treat, you will not treat?
So I think these are isolated PVCs. They are somewhat closely coupled, but they are left bundle branch block with tall R and 2-3 AVF. They are idiopathic RV outflow tract kind of PVCs or outflow tract PVCs. And here one is worried about three things. What is the PVC load? Is there a LV dysfunction? Are they symptomatic?
one thing you answered, the symptoms don't necessarily correlate with this. So you are interested in PVC load and the echo. Let's say the echo LV function is normal and you went ahead for a Holter and had a certain load reported. Probably there are no non-sustained VTs or sustained VTs reported, and the load is somewhere between 5% or 10%. You can neglect it in such a patient. 20% is a figure given as one that is significant in terms of PVC load, but may not necessarily mean that you take the next step of either suppressing them aggressively or recommending ablation, because those things can be discretely recommended for if there is LV function symptoms or if there are non-sustained VTs. So those are the reasons. So although 20% is a figure that is reported above which these patients have a 10% chance of landing up with tachycardiomyopathy. So just number may not mean much. They are more likely to be idiopathic outflow tract PVCs. So I think echo as a imaging might be sufficient going by the thing.
I thought sir would say treadmill test. This patient, because anyway patient has chest pain, and many a times young patients, if you walk them, if you don't have any high risk arrhythmia, you can actually keep them on medical follow-up. So it is sometimes good to have a treadmill test or maybe a Holter where the patient actually exercises well, rather than sit in the hospital and do that Holter recording.
Any role of beta blocker? Any role of beta blocker?
No, I would not at all. Not at all.
So what I just wanted to add is this only. PVC is such a common thing that, whenever you see your patients in clinic, PVCs are there and you are worried. Sometimes the patient has a symptom of feeling of the missed beat, they are worried. And the largest reference for arrhythmia which I get is PVCs with doctors. Doctors having PVCs are the most neurotic patients, because they every time think that they're going to land up with VT, VF and arrest. So one of the ways in which, simply in your clinic, you can differentiate between a benign and a malignant PVC is make them exercise, make them walk. In your clinic, you tell them, you go take a few rounds and come back. They will start feeling better. Now I am better. You will see the PVCs have gone. ECG, the PVCs. If exercise suppresses the PVCs, these PVCs are of benign nature. They need not be treated and they should be ignored.
Common mistake that is made here is after the diagnosis of benign VPBs, they are given beta blockers. So in fact, you are inducing a sinus bradycardia and probably allowing the VPBs to come up more.
(24-hour) or longer Holter monitoring, if it is frequently seen or gives some complaint, so long-term external loop recorder or long-term Holter monitoring 72-hour, 42-hour can be added.
Okay. I think a patient is in not showing any shortness of breath, etc. And these are monofocal PVCs. I don't think there's any more tests are needed, and patient has to be reassured.
Job he is coming from is also very important. So if he is an athlete or if he is in the armed forces, I would definitely want to complete certain more tests as compared to a person who's a clerk. So such individual for an occupational basis also we need to understand that these PVCs may have different significance.
But at the same time, many times echoes are done in these patients with the purpose of ruling out mitral valve prolapse. And in 90% of the patients, that diagnosis doesn't exist, even if they are labeled so. So the patient becomes neurotic for two reasons. He thinks that he has PVCs and he thinks that he has valve problem. So I think, this also needs to be kept in mind.
So this is a 30-year-old. ECG is recorded for insurance purpose, and you have these non-specific STT changes in the inferior leads, inferolateral rather. Dr. Amutan?
This patient should undergo exercise stress test, treadmill test supplemented by echocardiography, so that you can assess the ejection fraction, before and after the uh, exercise. So that will be the typical pattern. Because this patient comes for insurance, that is furthermore important. And the occupation is more important, because if the patient is an airline pilot, you have to do complete investigations including coronary angiography. That is the protocol of the airline pilot. But that may not be true for a manual laborer. And these two tests are must. Exercise stress test supplemented with echocardiography.
Is stress test more likely to be positive in these patients? It will be positive in these patients. So how will you proceed then?
Many a times these STT changes can be there with WPW, and possibly this patient may also be having a little bit of pre-excitation, I'm not sure.
Yes,
V5,
there is a
V6.
pre-excitation.
But means if it is dynamic versus fixed, that is very important. So, and in which leads it is. So if it is in the lateral leads versus anterior leads versus inferior leads, it makes a huge difference. So without pre-excitation, without LVH, without left axis, if you have T-wave changes, then it is abnormal. But along with left axis, along with LVH signs, if you have, then you need to consider that these STT changes can be secondary also. So that's very important to understand, that QRS is normal, axis is normal, and then you have T-wave changes is actually to be investigated rather than otherwise.
Now this is a pre-excitation. So how will you proceed? Dr. Sahu? Asymptomatic, insurance purpose ECG, and that's the ECG.
The pre-excitation, insurance. Pre-excitation is there, patient is asymptomatic. If asymptomatic patient, we have to observe and take history whether he had any earlier palpitation, evidence of tachycardia. If totally asymptomatic, we just need to observe the patient. Even if there is a pre-excitation without any symptom, totally asymptomatic, we have to observe the patient. And
how will you assess whether it... Any other investigations will you do?
Useful here,
yes.
treadmill test.
I think in most of the scenario, the dictum should be that whether the patient is symptomatic or not, whether he's having, he or she is having any underlying structural heart disease, and if there is, we are doing a 2D echocardiography, what is the LV function, and if need be, a stress test has to be done so that we know the effort tolerance of the patient. I think that will give us a lot of guidance regarding treating certain patients, yeah.
So when you say you do a treadmill, and if it is a left lateral pathway, the problem would be that the AV node will conduct faster and you might have loss of pre-excitation. Sometimes, even if it is conducting faster. So non-invasive method like a Holter or a treadmill or even medication, sometimes a sodium channel blocker, if it is used, have to be used with caution, saying that this is not absolute. And high-risk professions, again, athletes, armed forces, railways, all these should undergo an EP study irrespective of whatever the treadmill says or not. If the patient is really asymptomatic, otherwise okay, you can keep on medical follow-up, but tell them that report these symptoms of palpitations or syncope. Sudden cardiac arrest, 99% of the time will have a pre-syncope or a palpitation as a prior history. So if you have historically anything, do a EP study. If you don't have, you can tell them that if you have such, please report.
Holter has any role? Ambulatory ECG?
So what do you want to see is one-to-one pre-excited beats or not. And if all the beats are pre-excited, it's considered to be high risk. If there is a sudden transition from a pre-excited to a normal non-pre-excited beat at the same heart rate, then it is low risk.
The R waves look quite tall in V1, V2. So I think a echo to rule out Epstein's or something, that's to be done. Because this doesn't look like a normal WPW type. The QRS voltages are quite tall.
Because stress test is likely to come as positive, and the unnecessary angiography might be advised. Now this is to non-specific ST changes before a preoperative, as a preoperative workup. So this is a very common problem. A perimenopausal lady, before hysterectomy, referred, has these changes. No symptoms, no risk factors. How will you proceed? Dr. Gupta?
Again, I think if a patient is asymptomatic and ECG does not, there are maybe some non-specific minor changes are there, but if patient is asymptomatic and if she is climbing 3 or 4 flight of stairs without any symptom, I don't think anything more is to be done. But if somebody is, sometimes the surgeon will stress upon us that you do her 2D echocardiography or a stress test and then give the fitness, then that may be the case to do a 2D echocardiography and stress test, and then the fitness can be given.
If the surgery is high risk, would you investigate further, maybe stress thallium or something?
A patient is asymptomatic, no history of coronary artery disease, I don't think 2D echo and stress test should suffice. That's my thinking, but maybe.
The pre-op evaluation actually is made quite simple. In fact, we have to draw clinical diagnosis that there is no acute coronary syndrome. Even if the patient has coronary disease, no acute coronary syndrome, no heart failure, most surgeries can be performed. Now, if you ask this high-risk patient, then my investigation of choice would be a CT angio rather than a thallium. Because if the thallium turns out to be normal, still we have not ruled out anatomic coronary artery disease. So the anatomic evaluation has moved up the ladder than the physiological one.
Moderators, yes.
See, this lady, 52-year-old, non-hypertensive, non-diabetic, completely asymptomatic, what is the chance that she has significant coronary artery disease? That is one. If such a patient is able to perform regular, leading very active life and able to perform good amount of exercise, I think further testing in such patients is probably unwarranted, even if the surgery can be considered as major. Simply because it is now very clear that such patients do not require coronary revascularization unless it is indicated independent of her surgery. So that is very clear. So even if such a patient turns out to have a mildly positive stress test, doing further coronary workup is not going to help.
If she is diabetic or hypertensive?
Well, if she is diabetic and hypertensive but completely asymptomatic,
yes,
and able to do everything that a person of that age is expected to do, you can put such a patient on a treadmill and document it. And
but that would be positive. Many times it's positive.
Well, in that case, it's not. Again, I'm telling one thing is very certain, that such patients should not undergo coronary revascularization unless it is independently indicated. So the question is.
The first of all, whether she should go undergo coronary angiogram.
No,
not
that's
at
what
all.
I'm saying. That if you put.
I think
if it is positive,
no further tests.
No further tests.
No further tests.
I think when you are expecting, because of the baseline ST changes, the stress test, regular treadmill stress test is likely to show the ST segment worsen. Better is to use, in my opinion, dobutamine stress echocardiogram rather than going for a CT angio also. That is my preference, only because cost, radiation, both the things, and dobutamine stress echo, at least 85 to 90% accuracy is there. But I think what point I want to draw is that, we are asked for fitness and we decide about fitness. Patient is fit or not fit. It is incorrect. We cannot decide fitness. Fitness is to decide by the anesthetist. What you have to say is whether the patient is low risk, intermediate risk, or high risk for that surgery, which is major, minor, or intermediate. And with the consultation of the anesthetist, What pre and perioperative care needs to be taken in a given patient is what is important. This patient, non-hypertensive, non-diabetic, do nothing, just write patient is at low risk for any surgery under any anesthesia. That is it. Patient is hypertensive and diabetic, yes, I would want to do some kind of, because there are cardiovascular risk factors, it is a major surgery. If it's a minor surgery, don't do anything. If it's a major surgery, my choice would be dobutamine stress echo, but any other form of imaging, stress thallium or CT angio is reasonable. Two risk factors are bad.
A 38-year-old with palpitation, normal echo and biochemistry. Is Dr. Bora?
So if I see this ECG and you have nothing on medication list and you have a atrial flutter that is going on, definitely with a slow ventricular rate. Now, generally in a 38-year-old, you would expect a atrial flutter to be fast, 150, 160 rate. But if you are having a atrial flutter with a slow ventricular rate, that signifies something wrong with the AV node also along with the sinus, and that can be part of the sick sinus syndrome, it can be part of a cardiomyopathy, it can be part of myocarditis, and genetic cardiomyopathies also can present like this. So such patients should be evaluated thoroughly. I would not leave this patient alone at all.
What further investigation? Echo is normal. What further investigation?
If echo is normal, I'll do a Holter. I will see why this is there. In fact, we end up sometimes doing a CT chest with, because if MRI is not available, we do a CT chest to see for lymph nodes, to see whether there is inflammation going on or not, or a cardiac MRI definitely I would want to do. Many a times these patients, I'll do a Holter also to see how fast conduction is there or not.
How will you treat these patients?
This patient? So first of all, I don't know how long it has been. That is the first aspect. So any atrial flutter with long-standing atrial flutter, I'll first anticoagulate. If the patient is not having any symptoms, anticoagulation 4 to 6 weeks, see what is the reason, and evaluate that way. By that time, if I come to a conclusion, okay, this atrial flutter doesn't have any reason, I'll try to get back to sinus rhythm. Now, either it is by ablation or it is by cardioversion, either of the two. Because it's a first episode, I don't know whether it will recur or not. It might be just post-myocarditis and it may not come back again. So I will give both the option. Either if it is a typical flutter, it's easy to ablate, I'll just treat it with ablation, or cardioversion.
Any medications, flecainide or any other medications you will try before?
Yeah, so cardioversion is either chemical or DC cardioversion. Cardioversion is not always shock. So it can be a chemical cardioversion by ibutalide or by routine drugs. So cardioversion, before cardioversion, anyway you need anticoagulation 4 to 6 weeks, and that's very important.
EP study, all of these will undergo EP study?
I think Dr. Parale, one thing is
with
sure
the intention of ablation, if at all you go for it.
Yeah, so why I would go for an EP study in this patient would be, the patient has bradycardia. If you have a bradycardia with atrial flutter not on any medication, it will give an additional information after ablation with what is the status of AV nodal disease. And if you have an AV nodal disease, you might have PR prolongation in such patients. You might want to do an HV interval also along with that. That gives a fair idea. So preferably in this patient where the heart rate is not higher, I'll do an EP study post-anticoagulation.
So I think this patient is symptomatic for palpitation, so it is not worth leaving him alone. There is a red flag in terms of slow ventricular rate, but if you see the flutter to the QRS, it is the same interval. So I don't really suspect a high-grade AV block there. So one would be careful as to what, but may not take to the lab to study the AV conduction. It definitely requires sinus rhythm. Possibly he has a atrial flutter for a longer time, and therefore whether you have that you ensure adequate anticoagulation or do a transesophageal echo, whatever it takes. Cardioversion, electrical cardioversion may be the more better way to get him into sinus rhythm. This looks like a typical flutter. A definitive treatment in this case as a young person would not be to continue drugs. It would be best to ablate and give a better long-term cure than trying to...
so I'll get back to sinus rhythm is the last thing, that even if asymptomatic young patient like this, getting back to sinus rhythm is the end point that we have to achieve.
I would just like to ask one question. You know, often I've seen many times, and this is a question I'll pose to all. We always say that echo is normal. But believe me, in such cases, even Dr. Amutan is there fortunately with us, that if you do an echo, invariably you have to see the LA function. And nowadays the pre-pump is gaining more importance. You will find that the LA-GLS, you know, we say a cutoff of 35%, is often it is quite less, 20 or 18%. So even if you have cardioverted, and this is sort of atrial cardiomyopathy, and what would you do? Would you yet anticoagulate, or others you are happy that now the sinus rhythm has recurred and the LA-GLS is still low? What would you do?
Do further studies with the echocardiography. Simple 2D echo may be normal, but you do the LA function and you have to assess the LA appendage. There may be a thrombus in LA appendage. Before going ahead with the electrical cardioversion, you have to do transesophageal echocardiography. And
even there is no thrombus, but the LA-GLS is low. Would you continue NOAC or any anticoagulation?
Which conditions do not require a CHAD-VASc? One is valvular heart disease, rheumatic. Second is if your patient has amyloid. Even if their CHAD-VASc is not there, amyloid heart disease needs anticoagulation. Third is thyrotoxicosis. So if you have thyroid heart disease, then you need to have anticoagulation. Lastly, there are genetic abnormalities like patients who can have atrial standstill. Now, these patients actually present at a younger age with sick sinus, AV nodal, and it is many a times recommended to have anticoagulation in such patients even if they have CHAD-VASc 0. So, if you have familial history of strokes, familial history of pacemakers, familial history of bradycardia, definitely anticoagulation is required even if the patient doesn't have a good CHAD-VASc.
15-year-old has one episode of syncope. How will you proceed?
15-year-old boy with the syncope, no ECG. So the maybe congenital Brugada syndrome, will suspect Brugada syndrome, Ali repulsion
Assuming
syndrome.
is resting 12 lead ECG is normal.
ECG is
normal.
ECG is normal. So whether important to take the
because that's a
history.
common scenario we see in and out, such maybe standing for a long time they have syncope. So this is a very common scenario. So I would
history has to be taken properly, whether it is a syncope or a loss of consciousness, whether any associated along with the syncope, whether epileptic fit or anything associated with that. So history has to be taken properly. If ECG is totally normal, then we have to go for echocardiography, other investigation to find out any associated disease.
So
with one episode of syncope, how far will you investigate?
History is the most important to circumstantially. History is most important to rule out circumstantially if there is a suggestion of vasovagal syncope. If that is so strong, you might probably stop there. But if you have any doubt, at least a ECG and echo should be the minimum that should be done to evaluate whether there is any heart disease or whether there is any congenital kind of inherited arrhythmic disorder. Again, if these two are not there, then with one episode you may still further wait.
If he has 2 episodes, now
then you may ask for a Holter. If the echo is normal, you may ask for a Holter, because many of these inherited arrhythmic disorders may not are very labile in terms of their ECG findings. So you may not find something in the office ECG, and then there are provocative things that can be tests that can be done to uncover a long QT or a Brugada. So ECG, Holter, if both are negative, then you may really do the provocative test like a isophenylene challenge or a flecainide challenge, depending on what the family history or suggests. But then you will take it further in that direction.
So first, one ECG is always required. That is what the recommended guidelines are there. If you have syncope, historically vasovagal also, one ECG has to be done. That minimum investigation is an ECG, as recommended by the ACC-AHA also.
So that is what. So one ECG, once it is normal, then you need to see the circumstances and as required.
No,
I
we
think
said that if
the,
you're
one
more
of the
than
common mistakes in investigating syncope is patients come with 3 set of files, done everything, 72-hour Holter, 7 days Holter, but the tilt test is not done. Tilt table test is not done. I think that should move very high up in the ladder. Probably if it is done well, it can bring up a lot of diagnosis easily than we are going through a rather a circumstantial process. Head-up tilt test.
Now, this is a patient who after 4 days of STEMI has a asymptomatic ill-sustained VT. So, Dr. Bor, yes.
So the patient has had an MI. Now, what you consider as the primary period would be 48 to 72 hours. And once 48 to 72 hours are gone, it becomes a secondary VT or a non-sustained VT. And non-sustained VT in presence of structural heart disease is an indication for an invasive therapy like a device. Having said that, first, this is monomorphic in nature. What is the morphology of this PVC? Does it warrant? Does it correspond to the area of infarct? All these things should be put in perspective. And if you think that this is arising from the area of infarct, definitely an invasive therapy is to be offered to this patient as a technical background. Now, many a times anterior wall MI, patient who has persistent ischemia but mostly circumflex would present with non-sustained ventricular tachycardia if there is the area is not revascularized. So having that perspective of a non-revascularized territory and seeing whether it is arising from that area is very important to offer a device therapy. But yes, if a patient is fully revascularized VT after say 4 days, structural heart disease, it becomes secondary prevention for a device.
Would you straight away go ahead for ICD or we wait for a month and then go for ICD?
No, that moratorium period is of course described, but my feeling
I
is
think
that
adequate beta blockade should be tried first, whether the patient has been adequately beta blocked, and maybe if necessary short-term amiodarone therapy can also be tried.
So I think we should clear the concept about primary prophylaxis ICD and a secondary prophylaxis ICD. Primary prophylaxis ICD is used in subjects whom there has been no VT, VF or a cardiac arrest, and you are expecting because of the high risk status that he is likely to have a cardiac arrest. Now, in this patient, whether you will call it a primary prophylaxis or secondary prophylaxis is the question. You have had a recent myocardial infarction. He's passed that 48-hour period where we will say primary VT, VF versus secondary. This is a secondary VT. He has this VT. Now, whether to treat this as a primary prophylaxis or secondary prophylaxis is the question. If you have longer runs of sustained ventricular tachycardia, it is best to err on the side of saying that this is a secondary VT prophylaxis treatment that you are going to give, and probably ICD is a reasonable choice. Having said that, you have to look at the total picture into context. What was the extent of infarction? What is the left ventricular ejection fraction? The drug therapy has a role when there has been no VT VF. Here there is a VT VF. So this is a secondary VT VF. Secondary VT VF should be considered as needing an ICD. Unless you think, you look at the ECG here, and according to me, this does not fit in very well. If you have a ventricular tachycardia, which has a V1, V2, V3, V4, there is no R wave there. That means this origin of the tachycardia seems to be from the right ventricle, and then you have tall R in 2, 3 AVF. This looks like an idiopathic VT going on, coming from the RV outflow in a patient who has just recovered from a MI situation. So if his EF is good, if he is done well, I would not mind this ECG to be treated with beta blocker. But I think the larger question always comes up about this moratorium period after an MI and LV dysfunction. Should we be waiting for 30 days, 40 days, and then decide about ICD? That is true for primary prophylaxis when there is no VT-VF. If you have a VT-VF after 48, 72 hours after an MI, you should be considering this as a secondary prophylaxis which may require an ICD.
In an acute,
40%.
in a situation like this, 4 days after his MI, it's a non-sustained VT. We don't know his coronary anatomy. We are told that, you know, if VT after MI, one should not consider ischemia, but it's generally scar. But in a situation where this is 4 days after MI, would you think a coronary anatomy would be important in this patient? And if you see something, revascularizing it would make any difference?
So again, I don't know whether any angio revascularization has been done or not done.
No.
Not done. So I think as far as ischemia causing ventricular arrhythmia is concerned, generally speaking, the morphology will be polymorphic in nature. This is a very monomorphic ventricular tachycardia. So it is unlikely that I would find ischemia. And as I said that this is a RVOT VT, this is probably unrelated only to the coronary artery disease setting. But yes, if you are to decide about ischemia as a reason for VT-VF, it will be polymorphic in nature. Very unlikely monomorphic VT is a presentation because of an active ischemia. Ischemia often can be a trigger for a monomorphic VT, but the monomorphic VT generally is because of a scar. In the acute setting, we have seen monomorphic VTs occurring as early as 8, 10 days or 2 weeks time. 4 days is too short a time for a scar to develop and to give rise to monomorphic VT. So in this, probably things don't match. But yes, these are the situations where there might be a dilemma.
Many are.
Yeah. I was under the impression that the coronary angio and revascularization has been done. But if it has not been done, that is a priority in ACS situation, no question about it. You should do it. Even if a scar is formed, for monomorphic VT, scar is formed, we may prescribe an ICD, but we want to also look at the coronary status and the underlying ischemia problem and the burden. That to improve the overall outcome of the patient, revascularization may also be required and a device also may be required. Both may be required independently, but can't ignore ischemia.
If this is not a VT, if there are only VPCs, multiple VPCs, after 4 days, then?
Just beta blockers, not even amiodarone, I think. VPCs which are low risk. So
no, after MI, STEMI 4 days after MI.
Yes, so PVCs are not to be treated as a VT as such. They are just, so if the PVC is there and if it is an R on T or a pleomorphic PVC, then only you have to be aggressive. R on T or a fascicular PVC, especially in an anterior wall MI situation, even after revascularization, can induce a polymorphic ventricular tachycardia. So that's very important. What is the morphology of the PVC? When it is coming, is it R on T or not? And if it is not that, then they just beta blockade and nothing else.
Now, this is a patient who has been hospitalized for urinary tract infection, has sepsis, and you see atrial fibrillation. Now, how will you treat? The question is, will you attempt cardioversion? Either. If you attempt, will you start on antiarrhythmics? If yes, how long? Anticoagulation, yes. Okay, anticoagulation you will give. And how long? This is a transient sepsis, structurally normal heart. Maybe you can consider a diabetic, maybe 50, 55-year-old diabetic with urinary tract infection has gone in sepsis.
Yeah, I think this question is very important because in elderly people, infection like pneumonia or any infection can trigger.
This is a very
atrial
common
fibrillation.
scenario in ICU, very common scenario.
I think
ECG looks to be atrial fibrillation, irregular. What is the age of the patient not mentioned?
50-year-old diabetic.
50-year-old. Hospitalized for urinary tract infection, UTI.
Any non-cardiac condition, you can consider any non-cardiac condition, sepsis, and he has atrial fibrillation. How will you treat?
Anticoagulation and rate control has to be done here, and the primary disease, urinary tract infection, is admitted, has to be treated along with that.
I think that is a good answer.
Anticoagulation with rate control and echocardiography, what is showing, we have to know the echocardiography.
No, it is normal heart.
Normal. So we need to rate control and give anticoagulation in this patient.
Any comments?
That's a very good answer, I think, because he is admitted for UTI means he must be having quite a bit of sepsis and requiring good treatment with IV antibiotics. This AF must be probably chronic in all possibilities, and I don't think we will change rhythm control in this scenario. We would rate control him so that he is comfortable. The
No, he has
hemodynamics are good.
developed AF in front of your eyes. He was admitted, had a sinus rhythm. On next day you go for the rounds, has AF.
Well, if he has developed AF really acute as you put it, and his echo is normal, then obviously there is a possibility of restoring sinus rhythm. Then the question is why not? Because UTI probably has nothing to do with getting into AF. It is just that because of his age or that he has AF. So then you can easily...
How will you get? Medically or you'll cardio it?
So if the creatinine is good, echo is normal, potassiums are good, then for such a recent onset AF, I would love to give ibutylite. The chance of getting into sinus rhythm without the pain of cardioversion is much good. If the other option is of course DC cardioverting him, but it makes sense. But he's already in agony with the urinary tract infection and admitted for that. So I would give a shot at ibutylite because his recent onset AF and the rest of the things are good. But with UTI, I don't know what his creatinine and potassium is doing. So,
Dr. Ashish, if we just give IV antibiotics and wait for maybe 24-48 hours, and if patient returns to the sinus rhythm, I think nothing else is to be done.
Equally possible.
Yeah,
you can
nothing
choose
else is to
for
be
rate
done
control as
for
a
this
starting
patient.
and decide later also.
Yeah, we can wait for 24-48 hours, and the primary cause for atrial fibrillation is being treated. Maybe the sepsis is triggering, so patient can be kept under observation, and it could be maybe a paroxysmal AF, and then can be all the calls can be taken later.
That is again a very good thought. It could
With-
be a paroxysmal AF wanting to terminate spontaneously, so we need not be aggressive. Again, that's a
No,
good thought.
with ibutylite gets converted and reappears later.
Yes, then you will need to have a maintenance. What you do with AF really depends on what the AF is doing to the patient. Is he making him discomforted? Is it doing anything to the hemodynamics? All that decides what you really do, how much, but again, if he has again and again, then it's best to keep him on rate control initially, and then eventually when he's out of the UTI, see whether you really want to chase the rhythm control. So you can obviously go slow if it is not
No,
doing anything.
basically, why I'm asking question because routinely amiodarone is given as a bolus. So is it advisable? Not advisable.
I mean, it boils down to the same understanding is what is AF doing to him? Is it compromising the hemodynamics? Is he making it symptomatic? It's that will decide how aggressively you will want sinus rhythm versus whether you will accept a rate control as good for now in the setting that he is dealing with some other serious health issue. So not necessarily one answer is good.
Do you agree? Because routinely amiodarone is given in such situations, practically. So, do you want to give a message? Don't give amiodarone. So, it's such way. Is the message from this?
Because amiodarone is always given as a... So, amiodarone is more is always to be given. There are other issues. I mean, amiodarone is better given as a central line. Amiodarone as a peripheral line for more than 24 hours is adding to the problems of thrombophlebitis. So you might be complicating the hospitalization by doing those things. So I think it's fair to say you do rate control and probably prevent too aggressive management with amiodarone. I would expect this probably is some elderly person also, then I would be furthermore inclined to keep it at rate control.
Yeah, if he is converted to sinus, as you said, you have to treat him like an intermittent AF. So I would go by medical treatment, not amiodarone.
So that's the message is clear. No amiodarone. Now, this is a real life patient which I am having in the hospital. He had pre-excitation, WPW, for last 20-25 years. Had pre-excitation for 20-25 years. Intermittent narrow QRS tachycardia. The treating physician gave verapamil, sometime diltiazem, sometime beta blockers, got controlled, has been doing, for 30 years he has been doing well. And 2-3 days prior, he came with this. It's a known pre-excitation. Now, how will you treat this patient?
This is atrial fibrillation, and I think there is intermittent pre-excitation. The V1 to V6 is positive, and you have 2-3 AVF which is negative. So left posterior pathway can be there still in such patients.
So ablation alone or pacemaker implantation or what? Because there is a long pause. Many times you see a very long pauses after this. No P wave, nothing.
So means
this is the one pause which I have captured, but there are even more longer pauses were observed on the monitor.
So if the patient has had long-standing history of means WPW and narrow complex, and as Dr. Asirvatham has already said, the AF can be independent of the etiology of WPW. So treating WPW will not treat AF, nor it will treat the additional AV nodal conduction that is delayed during atrial fibrillation.
So I think the pause which you are talking of, what I can see is the pause is after termination of a short run of atrial tachycardia or atrial fibrillation. So when we talk of pauses which are significant, we have to keep few things in mind, especially when you're talking of sinus node dysfunction and sinus pauses. There is a flat line junctional escape kind of thing happening. We say 3-second pause is something which is sinister as far as sinus node dysfunction is concerned, especially if he is symptomatic. In post-AF termination or post-supraventricular tachycardia termination, a pause of 6 seconds is possible without any sinus node, primary sinus node dysfunction. It's a secondary suppression of the sinus node because of the atrial overdrive which is happening because of the atrial fibrillation. Up to 6-second pause, you may need not do anything. So independently, in absence of atrial tachycardia or atrial fibrillation termination, if you have sinus bradycardia, if you have sinus pauses, independent to the tachycardia termination, then only you can decide about pacemaker requirement. Otherwise, this patient, if you say that there has been pre-excitation all the time, requires to be taken care of the pre-excitation.
Okay. Thank you. Thank you. Thanks a lot.
Thank you all the chairpersons, moderators. Moving on to the last symposium, imaging symposium. May I invite the chairpersons for the next session, Dr. C.K. Ponde sir, Dr. Ajit Bhagwat sir, Dr. Bharat Mane sir, Dr. Deepak Fofre sir. The first speaker, Dr. V. Amuthan sir, the topic being echo as an adjunct to ECG.
Mic is on. You just connect it this side, this side. Okay, that's all right, that's all right. Thank you, organizers of ISEOCN and my dear friend Dr. Balaji, who has been my partner in PGI Chandigarh. He started with the jet speed presentation of a jet case in PGIMR, impressed all, and today he has impressed with all artificial intelligence. Now, this is about the urgent value of echocardiography in the ECG in acute coronary syndrome, and as you know, this is the pathophysiology and lot of ECGs you have spoken today. And site of obstruction may be very ambiguous by ECG diagnosis. Now, in this setting, echocardiography gives you the value in all the views, especially in short axis, apical 4-chamber, 3-chamber and 2-chamber. You can just identify the level of infarction, whether it is anterior or whether it comes to the circumflex territory or it comes to the RCA territory. So, this diagnosis of anterior wall infarction is made easy when you do the echocardiogram. And again, this is the value of strain echocardiography. As you can see here, there is a regional wall motion abnormality. And this is very amply represented by this strain. This is a bullseye pattern in this strain. You can see here, this is the anterior septum, this is the anterior wall, anterolateral wall, this is the infralateral wall, inferior septum. So, this basal rings 6 segments and this mid LV 6 segments and in the apex 4 segments. So, classically you have a very easy way of identification. You can see here this pertains to the anterior wall, that is the LAD territory, and you can see have the 3D echocardiography which easily identifies the diagnosis and localization of infarction. Here you can see the LAD is totally cut off and it was opened and the patient had a good recovery, and after the recovery you can do the strain echocardiography which shows a classical recovery pattern. Now this is the 3D echocardiography in the same patient. Now this question of failed thrombolysis, a patient is referred with thrombolized outside by alaxim, and you can see here this is before alaxim, this is after alaxim. Now you are questioned whether he has undergone successful thrombolysis. So at that point echocardiography helps you. Here you see a huge area of strain abnormality including the LV apex, and you can see the clot. So, additional value of a diagnosis of a clot is helpful in this patient. You can see the LV clot in both close-up view and the 3D echocardiography, and this patient we had the totally occluded LAD and patient was thrombolized. I mean, he underwent PCI, he recovered. This is after recovery, the clot has gone. Now, in patients with acute ST elevation in AVR, you can see here this is another patient, ST elevation in AVR, whether it is a LV left main disease or LAD proximal or whether it is some other lesion, can be easily diagnosed. So, this is a case here. See ST elevation in AVR and V1 of similar magnitude, widespread ST depression V3 to V6, so you don't know. And now echocardiography at this point tells you that the patient has anteroseptal lesion, anterior wall and the LV apex pointing to the LAD territories. And this is the angiogram. It shows the proximal LAD lesion there. The patient underwent PCI and is doing very well now. This post PCI, the area of strain abnormality has reduced. This basal and post PCI compared. This is the ejection fraction, which was 48, improved to 61. So the value of ejection fraction is there. When you do PCI, before PCI and after PCI, if there is an improvement in this thing, you can have that. And another area of importance is the strain pressure loss. These are called a strain pressure loss. Area under the curve is very, very important. You can see here, this is basal and this is after PCI. Area under the curve has increased. This suggests that your PCI has helped the patient. So this is another case in inferior wall infarction. Again, can be due to circumflex or can be due to RCA, or it can be due to a wraparound LAD. So this is another patient. You can see here, this is the patient turned up with acute MI, ST elevation in 2-3 AVF and V4R. And you can see here the extensive area of strain abnormality in the inferior septum, inferior wall and inferior lateral wall. And the patient underwent PCI. You can see here the coronary angiogram reveals 99% lesion in the mid RCA and patient underwent angioplasty, and this is a post angioplasty. Strain has markedly reduced. So these are some of the points. This is a patient with acute coronary syndrome presented with heart failure, and ECG showed only the sinus tachycardia, and echo shows the marked nature of the disease. The gross LV apex, anterior and inferior septum and anterior wall lesion, and the poor ejection fraction of only 22%. And you can see here the patient had double bend lesion in the LAD, and the patient underwent PCI. This is again in non-STEMI, you don't know where is the lesion. This is the patient with the SCD segment depression, 2-3 AVF and lateral leads, and this is the echocardiogram, which shows the strain abnormality in the inferior and anterior septum, and you can see here this is the ejection fraction was reduced, and the patient had a RCA lesion, marked RCA lesion, underwent the angioplasty and recovered from that. This is the PCA, post PCA. Now again, a patient with acute coronary syndrome can have normal ECG. This patient even underwent a treadmill test, which we were discussing before some time. The treadmill test was normal. There was no SC segment deviation, but echo showed the lesion. This is the basal strain echocardiography, which is normal. This is after stress, post stress. You can see here the LV apex, anterior wall and inferior septum are affected, and you can see here this, compare this basal with the post stress, and you can see that the patient has a very prominent lesion probably after the D1. That was the point. Because of that the patient had a normal ECG. This is a 99% lesion there in the LAD, mid LAD, and patient underwent angiogram and subsequently angioplasty, and the patient is doing well. Now this is another case of acute coronary syndrome with a normal ECG. You can see here 71-year-old unstable angina patient, and this is the basal, this is the post stress. You see the marked area of strain abnormality after the stress, and the patient has marked tandem lesion in RCA. Patient underwent angioplasty, is doing well. This is another interesting case, post PCI. This is a lady with LAD and OM lesion, stented in 2020, and I had a redo PCI for ISR in 2021. Patient came, and you can see here, this is the treadmill test. She developed marked SC segment changes in this scenario, and associated with that, this is the basal echocardiogram, and this is patient had 53% ejection fraction, and this is post stress. And there is a strain abnormality in the anterior septum. In addition, most important thing is ejection. This is 3D ejection fraction came down to 46%. From 50 and dot came to 46%. And this patient underwent CAG, had a stent thrombosis of the LAD, so underwent CABG. So this is another patient with inferior wall infarction and pansystolic murmur, and you can see here this is a 2D echo, this mechanical complications. This is a ventricular septal rupture. You can see that inferior septum is ruptured and the flow can be seen. This is a very important area. This is a akinetic area of the inferior wall, which you can see here, and the ventricular septal rupture in this patient. This is the 3D echo of the same patient, and this is the angiogram, which shows the marked 100% occlusion, 99% occlusion in the mid RCA in this patient. Now, finally, I want to show one more case which may be of interest to the electrophysiologist. This is a non-coronary case. This is a young engineer, underwent trucking. Then he had this. He fainted for 10 minutes. He was taken to the nearest hospital, which showed this typical Brugada pattern. He had one another episode of this unconsciousness after a tiresome cycling expedition. And this is the current ECG of this patient. This 72-hour Holter showed only one ventricular ectopic, and the most important thing is this has to be supplanted by the echocardiography because of the recent editorials. This is two phases of Brugada syndrome, electrical and structural. So in 84% of these patients, it may be associated with structural involvement of the RVOT. There is a dilatation in the RVOT more than 36 millimeters, associated with a reduction of FAC more than 33%. So this is the echocardiogram in this patient, and you can see there is a dilatation, mild dilatation in the RVOT. This is the RV free wall strain is reduced here. TAPSE is on the borderline 19 millimeters, and this is the angiogram which is normal for this patient. So this is the prevalence and this thing. So this patient I have sent for CMR and the results are awaited. Thank you for your kind attention, and thanks for the opportunity. I request that small handheld ultrasound can be carried with every resident. You can examine your patient, you can find out the ejection fraction, look out for the regional wall motion abnormality and ejection fraction. Thank you very much.
Thank you, Amuthan sir, for this wonderful talk. I now request the chairpersons to please felicitate Amuthan sir. Thank you, sir. We now move on to the next speaker, Dr. Uday Jadhav, sir. He's a senior cardiologist at MGM Hospital, Mumbai. He would be covering two topics: CT angiography and stress perfusion imaging.
Can I have the first slide, please? First slide. So thank you, Dr. Gurunath Parale, for this invitation. It's a big topic, CT coronary angiography. So I thought let me make it only relevant to probably what we need to learn here for a ECG meeting. Some more insights and put it in the right perspective. I think that's what is relevant. All right. So the clinical applications are two, right? You want to rule out the presence of significant coronary artery stenosis, and it expands to two areas: patients with stable angina, patients with acute chest pain. So straightforward, let me tell you this, that the radiation is not as big a issue as we have been talking about. I have been a part of the Protection 6 study, and the publication got through in JACC Imaging in 2020. And what we need to understand is this, that the CT radiation which you give for cardiac CT is not even more than the abdomen CT, plane and contrast, which we talk about. And I see a lot of questions coming on this, but we never ever question a CT abdomen. So protection study was, we participated from India. It's a global study, real world study. All incoming patients were taken, and the average was 3.4 millisieverts. That's reasonable. We were a little on the higher side. We were a little outliner. We had a 64 slice CT, and our experience was lesser 5 years back. Calcium score, we do it at 0.8. We have just gone down to 0.6. So we are good, I think. It's not as big a problem. So please, let's keep it at that. Now, the first thing is calcium scoring, Agatston score. And whenever you see a calcium, it's not just hanging around there. It's the proof of a atherosclerotic plaque. It is the presence of atherosclerotic plaque. How you want to stratify further comes then into question. So this is how you see a LED, some plaques. It need not be obstructive, but it still tells you a lesson. Now, once a CT coronary calcium score is done, where do not proceed with it? Sometimes I see cardiologists saying, well, it's all adventitial. You know, it's not really important. We see it all the time in the cath. The conventional CT, as you can see in the mid portion, here, this is what we may be seeing in the second slide, and that's a little problem because you may not be actually able to see the lumen effectively the way you want to. But the ultra high resolution CT, which are now coming up, the 320, for example, Aquilon CT, will allow all that calcium, you can see through it, and then you can see a lumen. So same patient's angio has been done, and you see a reasonably clean angio. These calcium scores were more than 400. So it's not a dictum that at a certain calcium you need to cut off. We do it at a higher one. So it's the 320 detector calcium scanner. One is by Canon, and Siemens has another one. So there are ways to do it and get the results better. There are two very recent articles published. One came last week and one came a week before from Patrick Sarais. I have all my references from that because that's the most recent. Here are the ESC guidelines and here are the NICE guidelines, and they tell you how do you go about it. Once the NICE guidelines, in fact, have put multi-detector CT right up there. And based on if it's functional testing, if it's inconclusive, you go to the other side and look at what the ESC has to say. And ESC is getting better by the day now on this, and they say, based on the clinical impression that you have, you can go ahead with the CTCA. Now, I was talking to Dr. Ponde just outside, and jokingly said that stress test is a cath generating machine. So I am going to show you a couple of examples because this happens in all our hospitals. It's unfortunate, but I must say so if I'm on the stage. All right, these are pictures, cardiology reference for us, and I personally don't like to get into it unless I really have a knowledge about it. So this patient was stress test reported positive. This is the basal ECG of this lady. Some ST segment depressions, not very convincing, mind you. 2, 3 AVF, V3, V4, V5. This is at the peak exercise and recovery. And this is at the recovery. And the cardiologist has referred saying that for cath, patient did not agree. So second option, do a CT CAG. I had no option, I had to do it, and it's all clean. There is nothing there. LED is clean, RCA is clean, circumflex is clean. There is absolutely nothing. You can see all the images. LED is very well. I am just showing you snapshots of what we got. It's all clean. There is nothing. This is all absolutely normal CT CAG in a patient reported positive for stress test. And every day in our hospital, we have at least 50 patients who undergo a stress test every single day, right? And you see all those images. So the same patient, you see the RCA PDA, the proximal RCA, I don't see anything. Next patient, 45 years old gentleman, no comorbidity, asymptomatic. He had nothing. The test was stopped due to fatigue. He has a little high lipids, so mind you, that's important. And this is the one which is typical, I find every single day patients come referred for either a calcium score or a CAG. So here is stage 3 of exercise. And this is reported positive by the computer synthesized rhythm and the ECG tracing. And the cardiologist does not have an option. He also has reported positive on stage 4. Mind you, patient did very well. He had no problem. This is recovery phase. And so that's the report. I have taken the picture as it is. Went ahead, did the CT, nothing. Clean, absolutely no problem. All the arteries are clean. RCA, LAD, the distal ones, LAD, LCX, nothing. I've just shown you these 2 examples because they are relevant. Patient went on a statin, and I hope that helps him in primary prevention. So the question is, what do you exactly do? Now, the presence of calcium may actually be a stabilizing event in atherosclerosis, right? But any calcium score, even if it is more than 0, would detect a plaque in 84% patient. It's a proof. CSE will let you know what's going on around, whereas stress test will detect the functional consequences of atherosclerosis. It does not diagnose atherosclerosis by itself. It cannot detect a non-flow limiting plaque. It's superior for detecting those who are at a high risk or whose probability factor is very high. Here is the way I probably would suggest. If you have a calcium score more than 400, and I was just talking to Dr. Christopher, who is an absolute expert in this, and I saw those lovely images of stress imaging on echo. If it's more than 400 and you need to do a treadmill test, but that doesn't tell you anything, mind you. So I don't believe it's pre or post anything that helps. What then will help is if you can get a strain, a global longitudinal strain, put that patient then on a stress echo, and if possible, and I think it's very difficult, to get an excellent strain image at that point of time. That gives you a complete answer. It may even, you don't need a dynamic perfusion scan on the CT. SCOT-ART is the largest study which you can carry home. 2,000 patients subjected to standard care, and these patients, TMT was performed in 85% of the patients, very low radiation risk, mind you. Here were the SCOT-ART results. Standard of care, CTA versus the standard of care. CTA helped in reducing the non-fatal MI, the need for angio, and primary endpoint. It was really very helpful. If you summarize that trial, when you do a CT angio, in addition to standard of care with stable chest pain, there is a significantly lower rate of death from CHD or non-fatal MI at 5 years. At 5 years, without resulting in a significantly higher rate of intervention. So what does this tell you? If you use it judiciously, it becomes the first line of investigation because it does tell you. And here is Harvey Hecht's editorial after that, and here he asked this question. Should CTCA be the non-invasive test of choice? Unequivocally, yes. For coronary calcium, unequivocally, yes. CTCA, you may take a call based on that. We don't do CTCA in everyone. Are all other available tests, all predictors, etc., but does it make a difference to the patient? Mostly no. You do a treadmill test, it's negative, you don't know whether these patients have coronary plaques. You do a treadmill test, it shows positive, n number of patients will have absolutely nothing going around. So those tests are not going to tell you unless you get a true physiological information, and stress test alone in today's date cannot do it. Here is Patrick Saray's this week's article, and I think it's very good. When you have a patient with chest pain and without diagnostic ECG changes, look at the tropi, low risk, low troponins, intermediate troponins, retest it. If the troponins continue to build up, please send him for other investigations. If it is at a low risk, you don't have to do anything. If it's less than 3, look at the data. Those with a normal troponin and a outpatient CTA with obstructive disease is only 19% versus those patients where the troponins are elevated, and you see that that percentage becomes 30%. This is an excellent slide trying to tell you the state of affairs as it is. The other important comment, and I'm finishing both my lectures together in another 7 minutes or 5 minutes. A stenosis more than 70% is the greatest predictor of a positive CT-derived FFR. But mind you, close to 1/3 of those patients with a 70% stenosis and a positive CT-derived FFR are functionally insignificant. Go the other way around. Stenosis, which are said to be negative for obstruction, actually 20% of those patients, if you study them carefully, are functionally significant. So there is a lot of science which we have not touched base. One important thing is looking at the plaque characteristics on CTA. There are 4 characteristics, and this is a slide which you will see everywhere in imaging meetings. If you are experienced or a learner for CTCA, look for 4 things. The plaque remodeling. By the sides, that's A, you see those yellow dotted lines. Second is the loosened plaque that you see. Third, on the left side, is a spotty calcification less than 3 mm. And fourth and important is something called as the napkin sign. What is a napkin sign? You have those washrooms, those hangers on which the napkins are kept. That exactly looks like that, right? The ring, then the lucent area, and then the calcium. On the cross section, this is the vulnerable plaque. You will not be able to identify that on any cath, believe me. This you will pick up only on CT-CAG. This is the plaque morphology. Not that it is sacrosanct, we don't want to discuss that part, but it truly signifies a vulnerable plaque. Few pictures for you to see. Here is one of our patients, LAD gone. You can see a proximal lesion. You may think it's a complete stenosis, but it's of interest. We measured the plaque size and everything. A cath was done, and this patient's plaque, when you look further, it's very loosened. In fact, it's a thrombus with a HU unit less than 40. So this patient had a thrombus, right? You can see it now better and better. And that thrombus initially wouldn't make that out, but yes, this is a LA thrombus. So that helps. And finally, you can look at stents. You can see these stents, and this is a different sort of discussion altogether. The one place where it's very difficult to identify either lesions or, study the stents on CTCA, limitation is when there is a bifurcation stent. That's one place where calcium, stenosis, and stents. 3 situations become difficult to imagine, right? Here is an occluded stent. You see a lucency on CTCA. And my final picture, just to save time, are the venous grafts post-CABG. I think we need to encourage arterial grafts in this country. These venous grafts, we have been seeing n number of patients getting occluded. This is called as the Newbin sign. You see the occluded shadow of the SVG graft, right? This is very common. And as the grafts go over a period of 5 years, they are more and more common. All those occluded grafts. Okay, let me stop here. Thank you very much for the short time and patient hearing. Dr. Christopher, please.
Yes. No, I request the chairperson to please felicitate Dr. Uday Jadhav, sir. Thank you, sir, for the lovely images. The next talk, Dr. Johann Christopher, he would be speaking on cardiac MRI.
can have the first slide. Good evening, everybody. I think I'm the last batsman standing. Thank you, ISEOCN. Thank you, Dr. Parale, for this nice invitation. We have seen a lot of ECGs, and I will be talking a little bit of how we can integrate our ECG with what I'm talking today. And this is our imaging center at the Care Hospitals, Hyderabad. So MRI is safe, and this was some time ago, where even ICDs today are safe in the MR magnet, and we are imaging these patients routinely. So the MRI toolbox is for whom? For basically 4 people. One is assessment of cardiac function, assessment of myocardial viability, assessment of structural abnormalities, and mapping of arrhythmias. Now, if you look at the technique of MR, it's a little complex to start with. But if you train your technique well and you follow a protocol and make sure that non-ferrous material are only there in the magnet, you're going to be finishing your studies very quickly, and you will have most of the information by about half an hour. And that's the time we take to do most of our adult studies. Now, when we're talking about cardiac function, all the parameters that you've been looking at in echo, whether it's EF, ventricular volumes, wall motion, and LV mass comes up. But what happens extra is that the inter-observer variation is very low. There are no windowing issues, and it's extremely accurate and highly replicable. That means if you do the MR after 3 months, 6 months, you're going to get the similar numbers, which is very important, irrespective of the operator. So it becomes a very attractive tool to follow up patients. Now, if you look at the societies, whether it's the American College, the Society of Cardiac CT, the SCMR, all of them, including the British Society, have only one thing to say. That is, the measurement of ejection fraction, cardiac MR, is the gold standard by a far margin. So, and if you look at this patient who has a regional wall abnormality in all his 3 coronary territories, and there's dyskinesia in the basal segment, it becomes very difficult for the echocardiographer to map this out and get an accurate volumetry and ejection fraction. But the cardiac MR does it very well, does it very simply, and does it very quickly. You get all these parameters with a click of a button, and you get a very accurate ejection fraction, which is highly replicable. Now, moving on to myocardial viability, we know that viability is important despite some of the small RCTs which didn't come true. And this is Allman's data, which clearly showed that if you have a patient with a viable myocardium, irrespective of what you chose to use, the mortality comes down by 80% compared to somebody being kept on medical management who has a non-viable myocardium. And if you revascularize non-viable myocardium, you end up with a similar mortality than keeping him on the GDMT, the 4-GDMT that we are used to. So viability certainly, I believe, is important. Now, this is a typical case of an LAD total occlusion. We follow the viability algorithm by looking at the ejection fraction, the wall motion, and then we look at the gadolinium enhancement. And we see whether it is more than 50 or less than 50%. Now, this is a patient with an LAD infarct. You can see that there. And the red arrow is pointing to the scar in the anterior septum. It's a transmural scar, and there's a little bit of edema also on the picture to the left. Contrast it with another patient with an LAD occlusion, and you can see that this patient has only a subendocardial scar. The red arrow is pointing to it, which is less than 50%. And obviously, this patient is going to benefit with revascularization. More than just the scar and reporting the scar, we have started looking at the quantification of scar, and we believe that this becomes extremely important in following up this patient and also trying to differentiate between what was discussed in the last session between a primary VT versus a secondary VT. When you have a scar of more than 15%, and it's not in the guidelines yet, these are patients at very high risk for sudden cardiac death, irrespective of the revascularization. And when they looked at EF, when they looked at the volume, when they looked at revasc, and they looked at scar area in a multivariate analysis, and this is a small study, they found that the scar percentage in the scar area is one of the most important things for sudden cardiac death. And this is a patient with an occluded RCA, and you can see how clearly the white scar is there, and this is a transmural scar. And the same thing happens in a circumflex. You can see there is wall thinning, and there is again the white scar which is transmural, suggesting that these patients will not benefit with revascularization, but will actually benefit with a primary prophylaxis of an ICD, provided the clinical situation warrants it. We are moving on to structural heart disease, and I will show you 4 cases to make you understand what we're looking at. And this is a young person who came with an acute chest pain syndrome in the ER. His troponin was positive. He had T-wave inversions like you saw in the last presentation. And we went ahead and did the cardiac MR because the echo showed a wall motion abnormality. And you can see in the first picture that there's a typical wall motion abnormality in the infralateral wall. There is a small trace of a pericardial effusion. The picture in the center is pointing to white material, which is nothing but myocardial edema. And the picture on the right is showing you a patchy scar in the infralateral wall. Infralateral wall edema and scar is generally of a viral etiology, especially of the parvovirus too. So this is a patient who we diagnosed on the MR, and this is again the sequence which is used to detect edema is called the T2 FATSAT sequence, and it's a good sequence to show water in the myocardium. Now, the importance of this is there's a white paper in JACC which is now telling us that the MRI is a very important tool to detect early myocarditis in a young patient, because we have very good therapies available, both steroid, IV, and intravenous immunoglobulin, if given early in the course of the disease, can completely reverse these patients. And we saw a lot of this during the COVID time, where we used these drugs and these patients actually recovered. And MRI was central in making the diagnosis of COVID myocarditis and making sure these patients were aggressively treated. The second patient is an elderly man who came in. He actually collapsed in the ER. He had to have a DC shock. He had a VT, and this is something that we've been seeing all evening. It's an LBBB type of VT with an inferior axis. And again, the echo showed an abnormality in the right ventricle, and the right ventricle is very important and very well visualized on the MR. You can see the free wall circulations in this picture, and you can also see the same circulations in the axial view, and you can see a markedly dilated RVOT. But the most important thing that we have not seen is the EF less than 40 and the end diastolic volume of more than 110 mils per meter square. You can clearly see here that there are trabeculations which are heavily there in the RV apex, and there is fat deposition in the RV free wall. And when you look at the cine images, you will see that the RV is dilated and dysfunctional. What is more important, there is patchy scarring in the free wall in the RV, which you can see in green. And this makes the diagnosis of ARVD. If you look at the whole constellation of diagnosis of ARVD, the MRI constitutes 2 factors, one major and one minor. And we know that the diagnosis of ARVD is made by either 2 major or 1 major and 2 minor. So MRI gives you 50% of the diagnosis, and the very fact the patient had an aborted SCD with an LB type of VT is again a major criteria. And obviously, with the numbers in the new or modified criteria of more than 110 mils per meter square and an EF of less than 40 constitutes a major criteria, and cardiac MRI is very exquisite to give you those numbers compared to 2D echocardiogram. MRI also plays a role in screening the first degree relatives and also leads to the ICD in these kind of patients wherever there is a kind of a dilemma whether to use the ICD early or not. The third patient is a young male with a loss of consciousness of 1 episode. We discussed that again with the ECG. He had an LVOT murmur. The Holter showed a non-sustained VT, and he was taken up for a cardiac MRI. This picture is obviously very familiar. We see that on the echo, but what is important is that the septum measurement is very exquisite on the MR, because the contrast to noise ratio on MR is very, very high compared to echocardiography, especially if the septum has an atypical appearance, that is mid-septum or anterolateral wall, where the echo cannot really look at those things. But what is even more important is what I'm going to show you, and that is a very patchy scar which is there in the mid portion of the myocardium. You can see healthy myocardium on both sides, and we got a number to this now, which is more than 15%. Again, not in the guideline, but most EP folks would take this as a threshold to start thinking about an ICD in this patient. And if you look at the high-risk features, the MRI is able to give you two of them. One is it gives you a massive hypertrophy of more than 30. You saw that in the first picture. And it is also giving you the second character, which is extensive LG. And if you add the loss of consciousness to this patient, you have three high-risk features, which I believe are enough to warrant what most of us would advise in this patient, and that is an ICD. The fourth case is a 42-year-old gentleman. He came with progressive heart failure. Echo EF was low, under 30%, and he had runs of monomorphic VT, and this was his baseline ECG, and LBBB with a wide QRS complex. And we were thinking of what to do next, and this is what we did. We did a cardiac MR. We saw the same thing. We saw a dilated ventricle. We saw moderate mitral regurgitation, a low ejection fraction of 28%. But what is even more important is after gadolinium, we saw this, an extensive scarring of more than 50% in the septum. So number one, we discussed LBBB pacing. This will not be possible in this patient with so much of septal scar. And second thing, we were discussing of CRT. Definitely he would get it just based on the ECG, but we had a doubt of CRT P or D, and here the D is well established because of the extensive scarring, and these patients have a very high risk of sudden cardiac death. So it really helps the practice going forward to choose between two investigations or two therapies. Moving on to mapping of arrhythmias, we know that cardiac MRI is very, very exquisite for looking at abnormal pathological barriers. And this is a patient with a anterior wall MI who was, PCI was done, but unfortunately he didn't do well. He has microvascular obstruction, which is there in the middle picture, and he has a lot of myocardial edema over here despite the PCI. And if you look at strategies for ICD in this patient, the electroanatomic map versus the MRI has a very close correlation. And there is a lot of talk from the Johns Hopkins group about looking at tissue heterogeneity in these patients, because we believe that the mechanism of the VT is a re-entry VT which happens between the islands of scar and healthy tissue. So if you look at patient A on the left, you can see it has a transmural scar, but it is very homogeneous and red. Whereas a patient in B has a similar scar, it's transmural, but it is very heterogeneous. And the ability to distinguish between homogeneous and heterogeneous scar is inbuilt in the MRI. And if you look at on the picture of the heterogeneous on the right, you will see that there are patchy islands of normal tissue interspersed with the red scar, and that is also seen in this model here. And these seem to be areas where VT can develop. And if you look at the heterogeneous zone in green, you will see that the scar burden is higher, the inducibility of VT is higher, and the recurrence of VT despite therapy is also high. And so this group has now recommended that after you do your OMT, GDMT, ICD, we must also think about a VT ablation in the heterogeneous zone in case the patient has recurrence of VT despite an ICD. The next thing we're going to talk about is pre-procedural EP planning, which you know is very difficult, it's very time consuming, but MRI guided images you can see here are almost exactly the same as the electroanatomic map which you see in the EP lab. And the picture on top is the EEM and the picture below is MRI, looking at a scar in the apex in red, and you can see the pictures are extremely well matched. So a pre-procedure MI can show you exactly the same place, and if it is matched into your CARTO system, it will decrease the time that you will use to do the electroanatomic mapping. The same thing can be done on the atrial side, although it is a little difficult. And this picture of the right atrium for a cavo-tricuspid atrial flutter has been taken from MRI and made into a easily visuable electroanatomic map for the EP person. So it becomes very easy to map this arrhythmia and do this. This is obviously the future where future EP will be done in an MRI lab or in a hybrid lab, and you can see the MRI catheter, and the anatomy that the MRI gives is exquisite, but this is obviously a few years away. The last thing that I want to talk about is after you do an EP intervention, we saw that a lot of EP interventions are only palliative, and the reason is that we don't have enough of structure to actually see whether the ablation is good enough or not, and MRI gives that information, as you can see after the EP procedure, whether the ablation was actually through and through, or was it actually only in the surface, and therefore the substrate was not actually touched and therefore led to a recurrence of the arrhythmia. And you can see here in the lower segment, these are all the EP lesions that we see commonly after the patients have had an EP procedure to distinguish it from scar. Last but not least, I believe scar determination is very important. It is important in ischemic heart disease where the degree of scar helps us in the revascularization technique. It is useful in the cardiomyopathies not only to make a diagnosis, but also for prognosis, like you've seen in sarcoid and hypertrophic cardiomyopathy. And most importantly, MRI is very exquisite in detecting scar, and it has the capability of changing a treatment strategy and management strategy. So in conclusion, ladies and gentlemen, MRI is a very valuable tool. It is a good tool for all high-risk patients in our cardiac practice, especially those who come with LV dysfunction, structural heart disease and arrhythmias. But it is very important to also understand, to get the best out of the MRI, like we saw in the AI talk, that you need to have cardiologists, EP people and radiologists speaking to each other, and only then will you get the maximum benefit. Thank you very much for your kind listening.
Hello. Thank you, Dr. Jonathan. Please, organizers, please get the memento. I request Dr. Bharat Mane to felicitate Dr. Jonathan. Sorry, Dr. Uday Jadhav, you have to rush due to time constraint. Yes. Thank you all for your patience. Since 9 a.m. you are sitting on a chair. I think our program is, yes, over to MC.